Good morning, everybody. Am I audible? Good morning, everybody. Am I audible?
Yes, ma'am.
Yeah. Is everybody there? Shall we start? We'll be starting in 2-3 minutes, okay?
जी.
Hello, everyone.
Good morning,
I am
sir.
Dr. Rashesh Diwan, the organizing chairperson for Isacon 2021. I welcome you all on behalf of the Governing Council of Indian Society of Anesthesiologists and the organizing team of Isacon 2021. We all know we have passed through a very difficult phase in the life, and now gradually we are trying to overcome the situation. Many of us suffered the pandemic, and of course, many of us also worked for the pandemic for the community, and we were praised all over the country and all over the world. It was a great learning time for all of us. However, we missed the last year completely for the academics. But now we are beginning, and we are beginning with a very mega academic fiesta under the banner of Indian Society of Anesthesiologists. This is the biggest ever hybrid conference and happening for next 5 days. I'm sure you will enjoy the most. We have made a humble attempt to accommodate as many presentations as possible. And in view of the overwhelming response for the presentations, we extended the conference on the pre-CME day. This is the today. We are starting today at 8 o'clock, and we have plenty of e-papers accommodated for one day. Once again, I thank you all for the participation in Isacon 2021 and wish you good luck. Stay safe. Long live ISA.
Good morning, everybody.
Good morning, ma'am.
Yeah, I'm Dr. Divya Kiskani, Assistant Professor, GCS Medical College, Ahmedabad.
Hello, everyone.
And I would like to welcome, I'll be your hall. Hello.
जी, ma'am.
Yeah, I'll be a hall coordinator as well as your chairperson. I would like to welcome Dr. Vijayanti Madam. Is Dr. Vijayanti Madam online? I would like to welcome Dr. Prashant Kumar, sir, Dr. B. Srinivas Rao, Dr. Ranjan, and Dr. Devashi Swen, our esteemed chairpersons and faculty for today's session in college. Hello. Yeah. For the e-paper session today, our first participant is Rakesh. Is Rakesh online?
जी मैम.
Yeah. One second, just give me 5 minutes.
जी मैम.
Good morning, everybody.
Good morning, ma'am.
Am I audible?
Yes, ma'am.
Hello.
Yes, ma'am.
Good morning, everybody.
Good morning, ma'am.
Good morning, ma'am.
Am I audible? Can I get some response?
Yes, ma'am.
Pradeep, can you unmute
Audible.
them?
Ma'am, you are audible, ma'am.
Can I request the technical team to unmute the participants?
Yes, ma'am. Hello.
Yes, ma'am.
Good morning, everybody.
Good morning, ma'am.
Technical team को unmute.
Can you unmute them? I cannot. There's no conversation only. Maybe my voice is not going. Yeah. So you have muted all the participants? Yeah. Okay. Yeah. Good morning, everybody. I'm Dr. Divya Khiskani, Assistant Professor, GCS Medical College, Ahmedabad. I welcome you all to this virtual platform of Isacon 2021. We begin with this hybrid conference. Today is our first session and we are all in Hall H. I'll be welcoming one of our chairpersons, Dr. Vijayanti Madam, who would soon join us. Okay. Please, can we start with the first presentation?
जी, ma'am.
Good morning.
Good morning, ma'am.
I cannot hear you.
Good morning, ma'am.
We cannot hear you. There's some problem with your voice.
Good morning, ma'am. Am I audible?
Yes, Dr. Rakesh, you are audible.
80%. Battery 90%.
Please can you start with your presentation? I cannot hear you. Hello.
Hello.
प्रेजेंटेशन और उसका जो उन्होंने ऑनलाइन स्लॉट दिया है वो 8 से 11 बजे का है तो मतलब मेरा 14 नंबर है तो अब जैसे हो जाएगी वैसे ही मैं आ जाऊंगी क्योंकि मैं वहाँ बीच बीच में नेटवर्क तो नहीं आता है क्लास की पूरी नेटवर्क नहीं आता और उन्होंने बोला ऐसे हो गया उसके हिसाब से मतलब बैठने को बैठना नहीं मैं सर ने बोला है कि अभी उनसे बात करूंगा टेस्ट करूंगा तो मतलब वो कह रहे हैं कि तब तक केस कम लेगा उसके बाद जो है ठीक है मैं सर जी को
Hello.
Respected sir and ma'am, myself Dr. Rakesh, third year PG student. Today I'm going to present a comparative study of effect of dexmedetomidine and fentanyl
Rakesh,
on
you have to
immune
unmute
response in
yourself.
patient undergoing lumbar spine surgeries
ma'am.
under
Am I
general
audible?
anesthesia under the guidance of Dr. Jitendra Agarwal sir. Introduction. Spinal surgeries present a challenge to the anesthesiologist as they are accompanied with many perioperative problems which include fluctuation in blood pressure, heart rate and severe postoperative pain. In general anesthesia, endotracheal intubation, prone positioning, and time of extubation are most crucial events which provoke transient but marked sympathoadrenalic response such as hypertension and tachycardia. Various pharmacological, non-pharmacological methods have been used, but no single anesthetic technique is accepted to be completely effective in attenuating or preventing the sympathetic response following laryngoscopy, intubation, skin incision, and extubation. Aims and objectives. To compare the efficacy of dexmedetomidine and fentanyl in terms of hemodynamic changes during lumbar spine surgery under general anesthesia and in post-operative period. To observe any side effects or complications. Material and methods. After obtaining approval from the Institutional Ethical Committee, a prospective double-blinded randomized control study was conducted on 64 patients belonging to ASA 1 and 2 undergoing lumbar spine surgery under general anesthesia at GR Medical College and JA Group of Hospitals. Sample size is calculated with this formula. Inclusion criteria. Patient undergoing lumbar spine surgeries under general anesthesia belong to ASA grade 1 and 2 with both gender, male and female, are included in the study between the age group of 25 to 65 years and who are give consent to participate in the study or included in the study. Exclusion criteria. ASA grade 3 and above, patient on calcium channel blocker, beta blockers, chronic use of opioids, patient with BMI more than 35, patient receiving drugs known to interact with our study drugs are excluded from the study. Method. Patients were randomly allocated into two groups, Group D and Group F by closed envelope method. Group D patient received loading dose of IV dexmedetomidine 0.5 microgram per kg over 10 minutes before induction of anesthesia and 0.25 microgram per kg per hour by continuous infusion during intraoperative period. Group F patient received loading dose of IV fentanyl 1 microgram per kg over 10 minutes before induction of anesthesia and 0.5 microgram per kg per hour by continuous infusion during intraoperative period. Hemodynamic parameters during the period of loading dose of the study drug at 0, 5, 10 minutes were noted and supplementary oxygen was provided. Hemodynamic parameters such as heart rate, systolic, diastolic, mean arterial pressure, and SpO2 were noted during the induction at the time of intubation and thereafter every 5 minutes up to 30 minutes and thereafter every 10 minutes till the extubation. After extubation, all patients were shifted to post-operative anesthesia care unit and systolic, diastolic, mean arterial pressure, heart rate, and SpO2 were assessed on arrival and at 1, 6, 12, and 24 hours. The statistical analysis was done using SPSS software. Results and observation. The demographic parameters like age, weight, gender were comparable between the two groups. The highly significant attenuation in heart rate, systolic blood pressure, diastolic blood pressure, mean arterial pressure during intraoperative period and postoperative period were observed in the group D as compared to group F in all time interval with a p-value of 0.000. Discussion. Various methods like inhalation anesthetic agent, lidocaine, opiates, direct acting vasodilators, calcium channel blockers, and beta blockers have been tried for blunting the hemodynamic responses, but all had their own limitations. It's a drug which can blunt hemodynamic response without having any adverse effect like respiratory depression, a post-operative nausea and vomiting was required for the purpose. The main finding of our study was that intraoperative infusion of dexmedetomidine significantly attenuated the pressor response to intubation, noxious stimulus, extubation, and recovery as shown by the heart rate, mean arterial pressure was significant with p-value of 0.000 in the dexmedetomidine group compared to fentanyl group. Our study correlates with many other studies conducted by many others. Conclusion. Dexmedetomidine provides to have better hemodynamic stability and more effective in attenuating hemodynamic response following intraoperative infusion when compared to fentanyl without significant side effects. Thank you.
Thank you, Rakesh. Am I audible?
Yes, ma'am.
Yeah. So in your study, you have used dexmedetomidine and fentanyl, right?
Ji, ma'am.
How have you prepared your drugs to make it a blinded study? Is it a double-blinded or a triple-blinded study?
Ma'am, it is double-blinded study, ma'am. One of the yes, ma'am. Yes, ma'am. One of the invigilators prepared the drug in 50 ml syringe. we prepared dexmedetomidine in the 4 microgram per ml, and fentanyl as 2 microgram per ml, and we gave same amount of drug in both the groups, ma'am.
So you have prepared it in 50 ml for loading as well as infusion, or you have prepared it for the bolus as well as the infusion, or you prepared it separately?
No, ma'am, in the same syringe, ma'am.
Same syringe.
Yes, ma'am.
So both are diluted up to 50 ml.
Yes, ma'am. But in a concentration of dexmedetomidine as 4 microgram per ml and fentanyl as 2 microgram per ml.
Okay. And
Dose is double, ma'am. Same amount of drug is given in both the group, ma'am.
okay. And the second thing is, how many minutes prior did you give it, this infusion?
Ma'am, 10 minutes before the induction, ma'am.
For both fentanyl as well as dexmedetomidine.
Ji, ma'am.
Okay. So you found dexmedetomidine to be better.
Ji, ma'am.
Yeah, and for any drug, there has to be some maximal dose, the toxic dose, which should not exceed, irrespective of the weight. Have you
Yes.
have to give that in consideration or in your material and methodology anyway?
Ji. Ma'am,
Right.
yes, ma'am.
You have used dexmedetomidine in how much dose?
Ma'am, loading 0.5 microgram per kg as loading dose and 0.25 microgram per kg per hour as a infusion dose, ma'am.
Okay, and fentanyl?
Fentanyl 1 microgram per kg as loading dose and 0.5 microgram per kg per hour as infusion dose, ma'am.
Okay, and you have mentioned post-operatively, but you haven't showed any observation for post-operative.
Ma'am, I showed graphs in post-operative
That is
hemodynamics.
intraoperatively.
So, and post-operative also, ma'am. I added in the last 2-3
Have you
slides.
used any other analgesic agents intraoperatively?
Ma'am?
You have used any other agents intraoperatively except for the inhalational agents and the muscle relaxants?
No, ma'am.
Perioperatively, any other things you have used?
No, ma'am. No, ma'am.
Nothing. So when did you have assessed the pain scores post-operatively?
Post-operatively, yes, ma'am. Assessed for 24 hours, ma'am.
Yeah, so how did you go about? If patient has hemodynamic instability pain, how did you go about?
Ma'am, I got 2 patients with in dexmedetomidine group. 2 patients had hypotensive episodes in post-operative period, ma'am.
Yes, so how did you treat them?
Ma'am, with IV fluids and
Yeah, so you are supposed to give a detailed description of that also, right? Because when you are giving your study, you have aimed at operative and post-operative as a main aim, right?
G, ma'am.
Yeah. So next onward, it is a good study. Just keep in mind those things to cover whatever aspects are there in your aims and objectives should be covered at the remaining portion equally.
G, ma'am. G, ma'am.
Any other questions from your side? Can we start with the second presentation, please?
Thank you, ma'am.
Pradeep, is Dr. Vijayanti madam online? Do we have Dr. Vijayanti madam? Okay, can we start with the second presentation, please? It's Dr. Ramya, right?
Yes, ma'am.
Yeah, good morning. You can start your presentation.
Good morning.
Myself, Dr. Ramya. My paper topic is effectiveness of intravenous lignocaine versus nebulized lignocaine on attenuation of hemodynamic stress response to endotracheal intubation. Introduction. Laryngoscopy and tracheal intubation stimulates sympathoadrenaline system and subsequent catecholamine release may partially contribute to the hemodynamic instability. Various methods and drugs have been used in modifying these responses. Lignocaine can be used as a local anesthetic as well intravenously in blunting the hemodynamic stress response to laryngoscopy. Nebulized form has been used to treat the bronchial asthma. The objectives of the study is to assess the amount of hemodynamic stress response during intubation and to compare the effectiveness of nebulization versus intravenous lignocaine. After ethical committee, the study was conducted and the study design is randomized clinical trial. The duration of the study is 1.5 years. The inclusion criteria is all the patients were posted for elective surgeries requiring general anesthesia, age group between 18 to 60 years, ASA grade 1 and 2, Malapati class 1 and 2. Exclusion criteria are age less than 18 years, more than 60 years, ASA grade 3 and 4, Malapati score 3 and 4. Patients who are allergic to lignocaine, lactate, pregnant women and lactating mother, preoperative medicated with clonidine and alpha methyl dopa. Sampling method by a simple random sampling and patient allocated into two groups. Nebulization group 45 patients, intravenous group 45 patients. Basal heart rate, SBP, DBP and saturation were monitored 15 minutes before surgery. Nebulization group receives 2% lignocaine 1.5 mg per kg using simple face mask 10 minutes before induction. Intravenous group received 2% lignocaine 1.5 mg per kg 90 seconds before induction drug. The outcome is measured by the vital signs including heart rate, SBP, DBP, mean arterial pressure every 1 minute till the 5 minutes and every 2 minutes till 15 minutes after intubation. The statistics include the data entry was done by the Microsoft Excel and the chi-square test was used for a qualitative data and independent t-test was used for a quantitative variable. The p-value is less than 0.05 was taken as statistically significant. The results include there is no statistical difference between age, sex and baseline parameters with a p-value respectively, whereas there is a significant statistical difference between heart rate, SBP, DTP, mean arterial pressure in nebulization group when compared to intravenous group after intubation at the first minute or till 15 minutes after laryngoscopy. Discussion. Lignocaine is one of the most commonly used local anesthetic which is available in multiple dosage forms and can be used various routes. Nebulization attenuates the airway circulatory effects which acts both by topical anesthesia of the area and from the direct local anesthesia rather than from a systemic absorption. Very effective surface anesthetic causing rapid absorption from mucosal surface. There are many studies. Priya Ganeshan et al. Noted that there is a minimum increase in the heart rate from a baseline in both the groups. Whereas there is an increase in the heart rate, SBP, DBP, mean arterial pressure at intubation was more with the intravenous group when compared to nebulization group. Amarnath et al. Noted that the difference in the mean arterial among the three study groups, that is clear that increase in the mean arterial pressure was higher in patients receiving intravenous lignocaine than the nebulization. Akhilesh Agarwal et al. Concluded that return of mean arterial pressure towards the baseline value was observed to be earlier with the nebulized lignocaine than with the intravenous. These are my the bar diagrams. Limitations of present study include only patients with a ASA grade 1 and 2 and cannot be given with a patient who are allergic to lignocaine, pregnant woman, lactating mother. Measurement of plasma lignocaine levels is more objective means of evaluating hemodynamic stress transfer, which were not considered in our study. I conclude with my study suggests that nebulization lignocaine is more effective than the intravenous lignocaine. Hemodynamic instability was lesser with the nebulized lignocaine as compared to intravenous lignocaine. These are my references. Thank you.
Hello.
Hello, ma'am.
Yes, you can hear me?
Yes, ma'am.
You have used two different modes of lignocaine, that is intravenous and nebulization, right?
Yes, ma'am. Yes, ma'am.
So study
Hello, ma'am.
Okay.
Hello, ma'am. Ma'am, there's so much of disturbance, ma'am. I can't hear you, ma'am.
But I can hear you.
Yes, ma'am.
Yeah, you have used two different modes of lignocaine administration, intravenous and nebulization, right?
Yes, ma'am.
The time of giving both the drugs in various forms is also different.
No, yes, ma'am. Various forms also is different, ma'am.
One is 90 seconds prior and the other one is?
Ma'am?
You have given nebulization 90 seconds prior, right?
Yes, ma'am. Nebulization 10 minutes before, ma'am. Whereas
intravenous 90 seconds prior.
Before. Yes, ma'am.
Yeah, but then it is a lot of bias in your study. You have not explained how have you blinded, who will be looking it. It is a very biased study, right?
It is a single blinded study only, ma'am, where I'll decide which patient. Like
single blinded your study. How have you single blinded your study?
No, after doing a pre-op, I'll decide whether ASA grade and 1 and 2, and I'll decide what to give the patient, ma'am.
That is not blinding. How have you make it single blinded? Blinding is what
The teachers will decide what to give. Ma'am?
No, what I am telling you is it is not single blinded, or it is not, the results are to be very biased, right? You know, for 10 patients you are giving nebulization, that is better. So it goes towards a bias thing. You have not hidden, there is no equality, not in the mode of administration of drugs, not in the timeline of administration of drugs, right? Nor you have mentioned that a third participant would always be, whoever is observing is different, right? So whenever you're doing a study, you're supposed to keep these things in mind.
Okay, ma'am.
Because
Okay.
your information for me also goes towards that you have given nebulization, you have given this, right? Moreover, the onset time of drugs is also to be taken into consideration, right?
Yes, ma'am.
Yeah. And you have to, your exclusion criteria need to be more precise.
Exclusion criteria.
And you have used them for which surgeries. That is also not mentioned.
Which surgeries? Okay, ma'am.
Yes? Yeah. Hello? Yes. Yeah. Oh, can you talk to somebody else? I'm already online for some chairperson session. Pradeep, can you hear me? Please, can we start?
Can I play next video? अरे भाई So please don't.
Yes, session has ended. So the next.
Our next presenter would be Dr. Ramya B. Please, can we have the presentation for Ramya B? Is she online?
Yes, Ramya.
Yes, ma'am. All my topic is optimized reversal without train of four monitoring versus reversal using quantitative train of four monitoring and equivalent study. Introduction, less residual paralysis was demonstrated when quantitative neuromuscular monitoring was applied. However, the device
I
is
can't
not
hear you, Ramya.
When it is not available, we have to depend on the clinical signs of recovery for administration of neuromuscular blockers. Aim and objective to compare the adequacy of reversal using neuromuscular monitoring versus reversal based on clinical signs of recovery. Location, Department of Anesthesiology, Kanyakumari, Government Medical College. Methodology, non-inferiority study, duration 6 months. Participants, patients undergoing elective surgeries other than head and neck surgeries under general anesthesia, assessed under ASA PS 1 and 2. Methodology, after informed consent, patients were connected to routine monitors. In preoperative room, subjects were given midazolam 2 mg IV and induced with propofol and fentanyl and vecuronium 0.08 to 0.1 mg per kg IV. Anesthesia was maintained with sevoflurane 1 to 2% and nitrous oxide and oxygen in the ratio of 50:50. Ventilation was adjusted to maintain EtCO2 in the range of 35 to 45 millimeter of mercury. All the subjects were connected to the TOF device. The TOF were then connected to the electrodes and transducer was taped to the distal phalanx of thumb. Then optimal reversal management using neostigmine was done. Train of four done at before reversal, after extubation, and 1 hour after extubation at the recovery room. Group A patients received a reversal based on the time since last vecuronium administration and based on subject spontaneous breathing effort. Group B patients received based on the train of four monitoring. Selection criteria, inclusion criteria, written informed consent, ASA PS 1 and 2, age 20 to 60 years, elective surgeries under GA. Exclusion criteria, patient refusal, ASA PS 3 and 4, elective surgery less than 1 hour duration, head and neck surgeries, hepatic disease, renal insufficiency, and neuromuscular disease. Parameters monitor, demographic data, anesthetic duration, total vecuronium dose, frequency of vecuronium administration, time of last vecuronium, reversal to extubation time, total neostigmine dose, strain of 4 value in recovery room, and residual paralysis. Adverse events monitored, respiratory adverse events, and post-operative nausea vomiting. Statistical tests were performed in terms of means and standard deviation. P-value less than 0.05 was considered significant. Students' key test for comparison of means and chi-square test for comparing the variables. Results. Assessed for eligibility, total 62, excluded were 2 patients, randomized total 60 patients, and they were allocated into group A and group B, each 30 patients. Demographic data comparable between 2 groups and statistically insignificant. Duration of surgery, there is no statistical difference between 2 groups. Total vecuronium dose, there is no statistical difference between 2 groups. Frequency of vecuronium, there is no statistical difference between 2 groups. Time of last vecuronium, there is no statistical difference between 2 groups. Total neostigmine dose, there is no statistical difference between 2 groups. Strain of 4 value in the recovery room, there is no statistical difference between 2 groups. Reversal to extubation time in group A was longer than in group B patients. Discussion, reversal strategy without train of 4 monitoring, although optimized, was not equivalent to reversal strategy using train of 4 monitoring. Both the groups did not differ in the parameters of the duration of anesthesia procedure, total vecuronium dose, the frequency of vecuronium administration, the time of last vecuronium administration, and total neostigmine dose. The train of 4 ratio in the recovery room also did not differ in between the 2 groups. However, the reversal to extubation time in group A was longer than in group B. No serious adverse event was found in both the groups. Limitations, we did not keep the core and upper body temperature in a specified range. Train of 4 value measuring was not normalized. Conclusion, in optimal reversal neostigmine strategy, though the reversal to extubation time is prolonged, there was no evidence of residual paralysis. Hence, it can be considered non-inferior to train of 4 monitoring. Thank you.
Hello.
Yes, ma'am.
Yeah, okay. So what were the train of 4 values you have used for intubation, for maintenance in the train of 4 group, and for the reversal and for the extubation?
Ma'am, during extubation, I have categorized my patients into 4 groups, ma'am. If the train of 4 ratio is less than 0.4, then it is a mild block. Then I have given optimized reversal using neostigmine. My dose is 40 mics per kg, ma'am. If it is between 0.4 to 0.7, then I have given 20 to 30 mics per kg. And if it is 0.7 to 0.9, then I have given 10 mics per kg. More than 0.9, the patient is fully recovered, ma'am.
So you have given no reversal for that.
Yeah, no reversal for that patient, ma'am.
Okay, how many such patients were there where you did not give reversal and they had a ratio of more than 0.9?
I think 3 patients, ma'am. 3 patients from group B had train of 4.9
Were they
during
included as a part of the study or were they not included as a part of the study?
they were not included as part of the study, ma'am. Actually, if it is my train of 4 ratio between 0.4 or 0.7 and 0.7 to 0.9, whenever at what time see, whenever I can give the reversal, but the thing is I have to extubate only if the train of 4 ratio is more than 0.9, ma'am. So I waited for the train of 4 ratio to come till 0.9. At that time only we'll extubate, ma'am.
So there will be none who will be not excluded, right?
Yes, ma'am.
So you have included.
Yeah, they're also part of the study, ma'am.
Yeah, so be clear in what you're saying, okay? Once you're saying it is excluded, once you're not, okay?
Okay, ma'am.
Yeah, and the second question is routinely, what are the other sites of trains for placement of electrodes?
We have to place 2 electrodes in the forearm, ma'am. A proximal electrode and a distal electrode. The proximal electrode will be placed in the wrist, whereas the distal electrode will be placed 6 centimeter more proximal from the distal one.
Hello?
Ma'am, 2 electrodes have to be placed, ma'am. A proximal and a distal one. They have to be placed on the forearm, and there should be a distance of 6 centimeter from between the 2 electrodes, ma'am.
Okay, what are the other sites other than routine sites for the placement of electrodes?
We can use the facial nerve stimulation, orbicularis oculi muscle. We can place it in the face and we can see, ma'am. And for the forearm, this is for the adductor pollicis to test the ulnar nerve.
Okay. Okay, thank you.
Thank you, ma'am.
Good morning, everybody. I would welcome Dr. Vijayanti, madam.
Hello. Hello.
Madam, this is Dr. Divya Kiskani here. We welcome you to our session.
Yeah.
Dr. Vijayanti, madam is our chairperson and a senior professor with us today for the session. Madam has been a professor in HOD, Medical College, Ahmednagar, and madam has been teaching and clinical expertise since 26 years. Thank you for being with us. We are lucky to have you for this session today.
Hello. Thank you. Thank you for my introduction, and I would like to express my gratitude for inviting me for this session. Please continue. It was a short notice, that's why I couldn't join. Sorry for the delay.
Yes,
how many students have been presented up till now? How many students?
3 students have presented, and we'll be continuing now for the further presentations, madam.
Thank you, Divya.
Thank you, madam. One second. Now we have a 4th presenter. Please, can you connect to Rana Ether?
Yes, ma'am. Good morning, ma'am.
Yeah. Rana Ether, you can start your presentation.
Good morning, everyone. My topic of discussion is a study to assess the efficacy of glycopyrrolate as pre-medication and prevention of intraoperative bradycardia during major abdominal surgeries, a randomized controlled double-blind trial. Introduction: intraoperative bradycardia is seen in 20 to 30% of the cases operated on abdomen. Common factors responsible include pharmacological properties of the drugs, physiological reflex. Glycopyrrolate and entropine are commonly used medication to prevent bradycardia. Most of the upper abdominal surgeries are done for neoplastic lesions in geriatric population who have already compromised cardiac parameters. Prevention of bradycardia and hypertension in these patients are of paramount importance to good surgical outcome. Glycopyrrolate has been used prophylactically for the prevention of bradycardia and hypertension for many laparoscopic, gynecological, and urological procedures. Its use for prevention of bradycardia and open abdominal surgeries is not clearly established. The primary objective is to study the efficacy of premedication with glycopyrrolate when compared to placebo, that is 0.9% saline, in prevention of intraoperative bradycardia in patients undergoing major abdominal surgeries. Secondary objective is to know the effect of glycopyrrolate premedication on blood pressure intraoperatively, to study the incidence arrhythmias, dryness of mouth, postoperative pulmonary complications, nausea, and vomiting. Materials and methods. It is a prospective randomized controlled study conducted in tertiary case center after due ethics committee approval. The inclusion criteria includes a major abdominal surgeries, non-laparoscopic, age between 18 to 60 years, ASA grade 1 to 3, duration of surgery less than 3 hours. The exclusion criteria includes the patient with coagulation abnormalities, end organ disease of liver, lung, or kidney, severe aortic stenosis, high degree AV block, history of seizures or epilepsy, glaucoma, patients on beta blockers, hyperthyroid state at the time of surgery, history of angina of CHF. Post-inclusion exclusion criteria include the major blood loss, hemodynamic instability requiring inotropic support, surgery extending beyond 3 hours. The collected data were analyzed using IBM SPSS software version 20. The t-test was done to compare the age, sex, height, weight, heart rate, and blood pressure variables. Comparison of categorical variables between the groups was performed using square test of Fisher exact test. A two-tailed p-value of less than 0.05 was considered statistically significant. The plan of anesthesia was GA with endotracheal intubation and epidural analgesia. Procedure: the patients were divided into two groups. 3 minutes before induction, the patients in group 1 received injection glycopyrrolate 0.005 mg per kg diluted to 2 ml, and group 2 received 2 ml of 0.9% saline. The parameters recorded were heart rate, arterial blood pressure, mean arterial pressure, systolic pressure variation, pulse pressure variations. Incidence of bradycardia was noted. Bradycardia was treated with 0.3 mg of atropine, which was repeated at 20-second interval till heart rate increased to the basal levels. Details of precipitating surgical stimulus, if any, were recorded. Patients were followed up till 48 hours post-surgery for any post-op pulmonary complications. The results: the total sample size was around 67, which was randomly divided into two groups. Group 1 had 34 patients and group 2 33. In group 1, 4 patients had a major blood loss and inoperable tumors, so they were excluded after inclusion. And in group 2, 3 patients had major hemodynamic dearrangements. So these patients were excluded after inclusion, and the total sample size which was analyzed was 60, 30 in each group. This is a graphical representation of the 4 different variables. Discussion: the demographic variables like age, sex, height, weight, ASS standards were similar in both the groups. Duration of surgery in both the groups lasted for 3 to 4 hours. There was no significant difference in systolic and diastolic blood pressure, systolic pressure variations, pulse pressure variations between the two groups at any of the time intervals. Mean arterial pressure after 1 minute of demedication was found to be higher in group 1 when compared to group 2. There was significant increase in heart rate at 1 minute after premedication with glycopyrrolate and 4 minutes and 5 minutes after intubation in group 1 when compared to group 2. 4 out of 30 patients in group 1 and 3 out of 30 patients in group 2 experienced bradycardia intraoperatively, which subsided after bolus of 0.3 mg of atropine sulfate. Limitations: the sample size of the study was small, and hence the outcome of the study cannot be extrapolated to regional or national levels. The study would have compared the efficacy of atropine and glycopyrrolate in prevention of bradycardia. The study did not correlate the action of glycopyrrolate with other anesthetic agents which increase or decrease the heart rate. So we conclude that from our study, injection glycopyrrolate in dose of 0.005 mg per kg when given as a premedication does not play a role in prevention of intraoperative bradycardia during major abdominal surgeries. These are my references. Thank you.
Hello.
Hello, ma'am.
Okay. It was a nice presentation.
Thank you,
So,
ma'am.
what was the criteria for using atropine? I mean, you have used glycopyrrolate as well as atropine.
Yes, ma'am. We usually, in our institute, we use a glycopyrrolate, ma'am, as a pre-medication.
Yeah, that is true. But then you have mentioned that you given atropine also.
Yes, ma'am. In this study, yes, ma'am.
Yes, yes.
We gave in one group glycopyrrolate, ma'am, and in the other group we gave 0.9% in this, ma'am.
Acha, that is true. But then you used a glycopyrrolate and still there was the incidences of bradycardia, isn't it?
Yes, ma'am.
And so that is treated with atropine.
Yes, ma'am.
So what is the difference between glycopyrrolate and atropine? Why atropine is now not used commonly, and everybody is using glycopyrrolate? Is there any
risk of arrhythmias might be there with the atropine, ma'am, and it is a longer duration.
Is the basic mechanism of action? What is the difference? Central action and other.
Yes,
so you should have gone in detail about that, isn't it? The vagolytic drugs which you are using. Okay, what are the incidences at which you are expecting the bradycardia in your surgical procedures or during induction?
during induction with our anesthetic agents, ma'am, like opioids, and during surgical procedures while traction on the abdominal viscera and all, we're expecting a bradycardia.
Okay. हाँ ठीक है. The other chairperson can ask.
Yeah. So as ma'am truly said that you need to go in detail and you should know your class of drugs of what you're studying.
Yes.
Study you're carrying out. Okay.
Okay.
Surgical steps also and other factors also that we are important in bradycardia.
Okay.
So you cannot clearly say that prevention of bradycardia by giving drugs or by not giving a class of drug, you can rule out that. So you have to rule out and create a common platform for those causes.
Okay.
Else your study results are always biased and you cannot say that it will be a correct result.
Okay.
Yes.
Okay.
We can switch over to the next participant, madam.
Thank you, ma'am.
Yes, yes.
Yes. I request the technical team to please, is Dr. Ranjita online? Ranjita Karmali.
Yes, ma'am, I'm there.
Please start with your presentation.
Dr. Ranjita, and the topic of my paper is comparison of post-operative analytic efficacy between transversus abdominal spleen block and local wound infiltration in cesarean section using bupivacaine and clonidine. My co-authors are Dr. Shiv Kumar sir, Dr. Krishna sir, and Dr. Archana. Pain is the commonest symptom observed in the post-operative period. Cesarean section is different from other surgeries because the mother has to tend newborn without feeling sleepy or drowsy. There are several methods to treat post-operative pain, which include systemic analgesic drugs and local anesthetic techniques. Tap block is a regional anesthetic technique where the anesthetic solution is injected between inguinal oblique and transverse abdominis muscula where the nerves are present. Local infiltration is a simple technique where anesthetic solution is instilled at various layers of abdomen during and after the surgery. So our aim is to compare these two regional techniques for their analgesic efficacy, to know the time of administration of first dose of SP analgesic, total analgesic consumed in 24 hours, and patient satisfaction. The study was conducted in Teaching Hospital of MIMS Mandya for 1 year. It is a prospective randomized single-blind open-label study comprising 60 participants. Sample size was calculated by Das and et al. Using formula for 2 means. The random sampling was done and randomization was based on computer-generated random numbers, and 2 groups were created with 30 each. Group T received tab block and Group L received local infiltration anesthesia. Inclusion criteria: those giving informed consent belonging to ASA grade 2, aged 18 to 35 years, weighing 50 to 100 kg and height more than 150 centimeter, undergoing lower segment cesarean section. Patient contraindicated for spinal anesthesia and with other systemic disorder were excluded from this study. So patients satisfying inclusion criteria after the consent were randomized into Group T or Group L and both underwent spinal anesthesia. Group T received tab block after the surgery with a volume of 40 ml of 0.25% bupivacaine with clonidine 1 microgram per kg. 20 ml of this solution was given on each side using nerve stimulator. Group L received the same volume of drug, 10 ml in the each paracolic gutta, 10 ml in the rectus sheath, and 10 ml infiltrated at the incision site. Both of them were followed up for 24 hours. VAS score of more than 4 was considered as breakthrough pain, and tramadol was given as rescue analgesic. So our data obtained was analyzed using Microsoft Excel and IBM SPSS software, and chi-square test and 2 sample student test were used. P-value of less than 0.05 was considered significant. We analyzed that there was no significant difference in the age group and weight distribution as well as duration of surgery. Post-operative VAS score as well as total tramadol requirement was significantly reduced between 2 to 6 hours in TAP group when compared to that of LIA group. In the first figure, we can see rescue analgesic given, which was very high in case of Group T. VAS scores were significantly lowered in Group T in figure 2, and the total tramadol requirement was much higher in Group L in the figure 3. So secondary outcome, the systolic blood pressure and the pulse rate variations, there was no significant difference between both the groups. Cesarean section is under regional anesthesia. It provides a great opportunity to do these regional techniques. And our study demonstrated that tab block significantly reduced VAS score, increased duration of breakthrough pain, and decreased tramadol requirement. Bilateral tab block gave a very good analgesia because the nerves lie in the specified plane and can be easily located using nerve stimulator compared to LIA technique where there is diffuse spread of nerves.
In meta-analysis conducted by Gyuk et al. In 2015, the results were similar to that of our results, where Tablock was found to be superior than that of local infiltration anesthesia. RCT conducted by Tawfiq was it was contradicting, and they said there was no difference between both the groups, and opioid requirement was also same. Though both the procedures were invasive, there were no complications observed. Limitation was that blinding could not be done because there were two different techniques. So to conclude, transverse abdominis plain block as a component of multimodal analgesia is highly effective. It also decreases opioid consumption. It is easy to perform and reliable, and there were no complications observed. These are my references. Thank you.
Okay. So, Divya, how much time she took for the presentation? These people are quite fast.
Yeah,
So they are just hurrying up.
The time given to them is 4 minutes, madam.
4 minutes, acha. Okay,
Yeah,
okay.
but many of them are faster than 4 minutes also probably.
Okay, okay.
I would request
So,
to place it's a timer for the questions if possible.
it's 2 minutes.
Was there
Okay. I would like to ask whether the concentration you used 0.25 or even you reduced that, tried with that, or bupivacaine, of course.
No, ma'am, it was 0.25% for all the patients.
You are not giving 0.125 or so for post-op analgesia.
In our study, ma'am, we have used 0.25, not 125.
Okay. What are the other drugs you can use it for post-op analgesia in such condition?
All
other drugs you are using, suppose?
Ma'am, in my study, I've
other local
included,
anesthetics. Yes.
ropivacaine can be used.
Yes, ropivacaine is much more effective, isn't it?
Yes, ma'am. Yes, ma'am.
It has advantage of what?
The duration of action is longer when compared to bupivacaine.
And another one? Considering the toxicity?
Toxicity, yes, ma'am. Bupivacaine has a lower toxic range.
Yeah. So it is likely to cause toxicity, and which is cardiotoxicity is very
high in
dangerous.
bupivacaine.
Yes. High. And by chance, if you are going to give a larger dose over shooting the proper dose, I mean toxic level, the cardiac arrest can occur, which is difficult to revive, isn't it?
Yes, ma'am. Yes, ma'am.
Bupivacaine has a special advantage over that.
Yes,
and you have not used USG in this case?
No, ma'am.
While giving? Okay.
No, ma'am. We have used nerve stimulator.
In your institute, you are using USG or not?
We have USG, ma'am, but it is not there in our OBG OTs, hence we could not use it.
But then in OT you are using, no?
Yes, ma'am, we are using.
So that is far from the routine OT, obstetric OT is?
Yes, ma'am. Yes, ma'am. It is quite far from the major OTs, hence we could not shift it.
Transport, okay.
Yes, ma'am. For other laparotomies, we are using USG guided tab blocks.
Yeah, USG guided.
Yes.
So, what are the adjuvants you can use it for while giving the block?
Ma'am, adjuvants we can use opioids, ma'am, as well as other alpha 2, that is dexmedetomidine can be used.
Yes.
In our study we have used clonidine.
Yes, you are used. Okay, nice presentation. Okay,
thank you.
Yes, Divya, you can ask.
Yeah, it was a good presentation and one of the latest modality of the blocks which is being used nowadays. However, the USG trend is more, as Madam said.
Yes,
ma'am. Ask the basic question: what is the actual anatomical location where we give that?
Ma'am, it's the triangle of Pettit, and exactly the plane, transverse abdominis plane, which lies in between the internal oblique and the transverse abdominis muscle. There, the intercostal, the nerve supplying the anterior abdomen passes. Hence, we are locating the specific plane using the nerve stimulator in our study.
Okay, so you'll be covering which segments of the nerves does it provide analgesia to, and what is that is one of the reasons where we use it in as a post-operative for anesthesia and cesarean section
T6
patients, right?
to T12, ma'am. Yes, ma'am. Generally, T6 to T12 nerves are covered in our study. So it's useful for the lower abdominal surgeries.
And it is a large volume block, right? It huge volume block. It requires
Yes,
like
ma'am. They have to. In our study, we have used 40 ml in each patient, ma'am.
Okay. Any exclusion criteria and cesarean section
Ma'am,
patients?
yes, ma'am. Any patients who had cardiovascular diseases or respiratory diseases or who are contraindicated for spinal or regional anesthesia were excluded from my study. So, yes, ma'am.
Yeah.
Thank you, ma'am.
Yeah. Madam, we can start with the next presentation.
Yeah. We can go for the next.
Can we have
Wait, Dr. Divya. Give me a minute first.
Good morning, sir.
Very good morning. This is Dr. Rashesh Diwan, the organizing chairperson from Isacon 2021. And I welcome you all on behalf of the Governing Council of ISA as well as the organizing team. This is a mammoth program, this time in Isacon, being a virtual and hybrid. I'm thankful to the chairpersons, Dr. Vajayanti and Dr. Divya, and additionally, you are coordinating the session also, and to all the participants who have presented the papers today. I'm sure it is going to be a wonderful time, and we have a wonderful 4 days to come. And let me tell you, this is the biggest ever hybrid conference happening after COVID, and thanks to COVID pandemic in the world. So no biggest such a big program has taken place. We have a mammoth 2100 plus abstracts coming from all the postgraduates which have taken part. I appreciate their enthusiasm, and they all who missed last year because we could not do Isacon, they have come today. But this scientific program is almost double than any of the scientific programs which has taken place in any Isacon in last 10 years, and almost 8 times presentations from the postgraduates. So it's a really a great success. And the success is because of all of you who have participated, all the chairpersons, all the faculties who have taken in efforts to make this program very successful. Thank you so much for joining. And thank you so much, Divya and Dr. Vajayanti, for carrying out this program.
Thank you, sir, for giving us a platform and the opportunity.
Yes. Thank you.
Thank you so much. Carry on.
For the first time being a part of it.
Yes.
The live media. And
Thank you
Dr.
so much.
Also for giving us the opportunity.
Yes.
We shall proceed, sir.
Yes.
Yeah. Okay.
Yes,
so
Divya.
we can ask the technical team to please introduce Dr. Rashmi, and she can start with the presentation. Rashmi, over to you.
Is to study the effectiveness of magnesium sulfate in post-operative pain and post-anesthetic shivering in surgeries under spinal anesthesia. Post-operative pain management is very important as it prevents patient discomfort, anxiety, and prolonged hospital stay. 2 to 10% of the acute post-operative pain, if inadequately treated, will go into chronic post-surgical pain. Post-anesthetic shivering is the most common regional anesthesia complication due to impaired thermoregulation, with the incidence of 20 to 70%. Magnesium sulfate has anti-nociceptive effects when administered IV due to antagonism of NMDA receptors, and also prevents central sensitization. And with its muscle relaxation action, it is effective in prevention of post-anesthetic shivering. Taking care of post-operative pain helps indirectly in gaining the confidence of the patient and also helps in faster recovery. Intraoperative shivering interferes with the measurement of to increase oxygen consumption by 2 to 3 times. Thus, for better recovery of the patient, there is a need to study the efficacy of magnesium as a management of post-operative pain and post-anesthetic shivering in surgeries under spinal anesthesia. Objectives: to study the incidence of post-anesthetic shivering with the use of magnesium sulfate, to study the effectiveness of magnesium sulfate in reducing post-operative pain for 24 hours, comparison of the test and control groups, time of rescue analysis among both the groups. Inclusion criteria: ASA grade 1 and 2, patients undergoing lower abdominal and lower limb surgery under subarachnoid block, belonging to the age group of 20 to 60 years and in elective procedures. Exclusion criteria: severe cardiovascular and musculoskeletal disorder, history of any drug allergy, patients with bradyarrhythmia, renal disease, and parturients, patients taking calcium channel blockers. Methodology: patients were divided into two groups by chit selection method. Even numbers were the study group who received magnesium sulfate infusion at 15 mg per kg per hour, and odd numbers were the control group who received normal saline infusion. This infusion was started 10 minutes after the spinal anesthesia. Shivering was assessed according to the Crossley and Mahajan scale, and any time the grade was above 2, the rescue drug was given according to the protocol. Visual analog score was noted, and any time the score was more than 4, analgesic was given according to the institutional protocol, and the time of requirement of rescue analgesic was noted. Sedation was graded according to the 4-point sedation scale, and post-operatively patients were monitored and results were noted and interpreted. Results: visual analog score among both the groups. In the graph, we can see that the mean VAS score was significantly low at 4th, 6th, 12th, and 18th hour in those who received magnesium sulfate. Start of analgesic in both the groups. In magnesium group, 63 patients had the first dose of analgesic at the 18th hour, and in normal saline group, 93 patients had the first dose of analgesic at the 6th hour. Number of times the rescue drug given: most of them who received magnesium sulfate required 1 to 2 doses of analgesics, and in those who received normal saline infusion, mostly required 2 to 4 doses of analgesics. 22 patients from the study group required no analgesics. Grades of shivering: in magnesium sulfate group, most of them experienced grade 0 to 2 of shivering, and in those who received normal saline, experienced grade 2 to 4 of shivering. Discussion: magnesium sulfate infusion during surgery under spinal anesthesia reduced incidence of shivering, post-operative pain, and analgesic consumption without any notable complication. Thus, we can conclude that magnesium sulfate, when given as low-dose infusion intraoperatively and immediate post-operative period, is effective in prolonging duration and in decreasing the requirement of analgesia. Also, in reducing the incidence and severity of post-anesthetic shivering in patients undergoing surgeries under spinal anesthesia. Thank you.
Okay. It was definitely a good presentation, and I would like to ask, what is the other uses of magnesium sulfate in obstetric patients, of course. So apart from this, you are using it for the shivering, okay? So what are the other uses the obstetricians are using? What is the, are you listening or not? Hello? Hello?
Yes, ma'am, you're audible.
No. So because you are using the magnesium sulfate, you should be able to tell me the other uses, which is very commonly nowadays they are using. Definitely. In which patients they are using? Hello? Any, okay, can you tell me the disadvantage of the magnesium sulfate or side effects? I think she's not audible. She's not able to listen.
Please check why she's not audible.
There's no response. Because her voice quality also was interrupted intermittently. So whether she's connected or not.
What is the issue with the voice quality and network of the presenter? Rashmi, it was, right? Rashmi?
Hello, Rashmi. No, I think she's not able to listen, or we are not able to listen what she's saying.
No, ma'am. If we cannot listen, but we cannot.
What is the technical party saying?
Pradeep, I'll just one.
Hello, good morning, ma'am.
Hi, you were not connected or what?
Ma'am, there was some error, ma'am.
You
The
able-
host was not letting me in.
Error. Okay. So I just wanted to ask, what are the other uses of the magnesium sulfate in practice for obstetrics?
Ma'am, it can be used in the treatment of preeclampsia and eclampsia with the Zaspan and Pritchard's regimen. That
What
is
is
the
the
use in
dose for
obstetrics.
that? What is the dose they are using for prevention of convulsions?
Prevention of convulsions,
Prophylactic,
4 grams IV they'll give, followed by 5 grams to each buttocks.
Yeah. And what was the disadvantage of it? While giving what we have to be careful when the patient is receiving magnesium sulfate. So while
We should be monitoring the urine output and also the hemodynamic stability, and respiratory depression might occur. And there are also in higher doses chances of cardiac arrest, and deep tendon reflexes have to be assessed. And also there might be chances of turning into PPH also, because magnesium causes uterine relaxation.
And what about the other drugs which are used for the control of tremors? I mean, the shivering.
Shivering, ma'am, we can use tramadol at the dose of 25 to 50 mg, and we can use dexamethasone.
Yes. Okay. So this was a trial of how many patients?
A trial of 350 patients, ma'am. We took according to the statistics followed by the Sloven's formula.
So they were
Yes,
divided in equal parts.
Yes, equal parts.
So other team received what? Nothing.
Normal saline, ma'am. Nothing.
Normal saline.
Nothing. It was just a placebo.
Okay, placebo. Okay, that's a nice.
Thank you,
nice
ma'am. Thank you. Sorry for the delay.
No, it's a technical thing you can do.
Yeah. Okay. Thank you, ma'am. Thank you.
Thank you. Can we have the next presentation, please? This was Rashmi, right?
Yes, ma'am.
Yeah. So now our next presenter will be Dr. Renuka.
Good morning, everyone. I'm Dr. Renuka, final year postgraduate from MR Medical College, Kalburgi. Today, I'm going to present a paper on prospective comparative study of USG guided interscalene block with superficial cervical plexus block versus general anesthesia for fixation of clavicle fracture. My co-author is Dr. Pratima Kamreddy. Clavicle fracture constitutes 5 to 10% of all fracture, whereas 35% of the shoulder girdle. It was usually performed under general anesthesia due to inability to access the airway. With advent of ultrasound, the combined interscalene cervical plexus seems to be effective and promising method for surgical anesthesia. My aim of the study is to access the clinical efficacy of combined interscalene brachial plexus and superficial cervical plexus as a sole anesthetic technique in patients for clavicle surgeries. The objectives include to compare the following between two groups: intraoperative vitals, analgesic requirement in 24 hours, and time duration spent in PSU. Study type is prospective randomized comparative study. It was undertaken involving 60 patients undergoing elective clavicle fracture surgeries who were randomly allocated in two groups in Basaveshwar Teaching and General Hospital, Kalburgi. Duration of study is 1.5 years. Group G is general anesthesia and Group B is a block group. Ethical clearance was obtained by Institutional Ethical Committee. We also registered trial in Clinical Trial Registry, India. The inclusion criteria being 160 age between 60 to 65 years of either sex, ASA 1 to 3, patient with normal function, pulmonary function test, patients undergoing elective clavicle surgeries. Exclusion criteria are patients with ASA grade 4 who is history of alcohol or drug abuse, patient with known allergy to local anesthetics, patient with coagulation disorders or an aunt who are respiratory. Regional anesthesia technique involved investigated block with using 20 ml of 0.5% ropivacaine, 10 ml in each group. Intraoperative
There are some network issues on your side.
Ma'am, it is a pre-recorded session. Hello.
Please can you play the video again, the technical team? There are some network issues. Right, madam, even you are facing issues.
much difference between the age with a PA value of more than 0.05, 24 and 0.01, and the post anesthesia care unit, the time taken for that modifier score less than 0.05. In the line diagram, you can see there is no difference. There is no hemodynamic stability in group B, whereas in even in mean arterial pressure, there is no much difference in the group B. Conclusion: regional anesthesia avoids unwanted side effects of general anesthesia early and during the surgery. It carries the usual risk of increased human stress surgery, apart from the risk of airway-related complications. These are my references. Much.
Hello.
Hello, good morning, ma'am.
Actually, we could not listen to what you
Yes,
presented, but just what I got it from that is it's a clavicle fracture
Yes, ma'am.
cases for which you are given an interscalene and
Superficial cervical.
superficial cervical block with the
Yes.
USG guided, isn't it?
Yes, ma'am.
With the general anesthesia. So, what
Yes.
are the advantage of combined general anesthesia and block? Can you mention?
Ma'am, we can avoid the unwanted complications of general anesthesia, such as the most common is nausea, vomiting, and difficult airway whenever we encounter, and the chances of bronchospasm, laryngospasm, and
But then you are already giving general anesthesia. So, how can you avoid all this?
no, ma'am.
You are combining general anesthesia
no,
with
ma'am.
the block, isn't it?
Yes,
So,
ma'am. One group is a block group, that is interscalene and brachial plexus, and the other is general anesthesia. We're not combined.
it's not the combined. It's
No,
not
no.
combined.
Yes, ma'am.
Okay. So what I got that you combine everything so that you can
The video was not appropriate.
so you can, of course there is a technique that you can combine these two
Yeah,
so
yeah.
that you can reduce the amount of drugs or volatile anesthetic agents or relaxant
ma'am.
dose you can in such cases. So
Yes,
it's a
ma'am.
totally two different groups. Okay.
Yes, ma'am. Yes, ma'am.
Okay. So for in the group of block under USG guided block. So whether the sedation was required? I mean, I couldn't get it from that because
No, ma'am. We have not used sedation because we have used most adult patients, and we have convinced the one day prior to surgery and on the table that only slight amount of prick, that is an equivalent to putting the cannula. So they have agreed, and we have not added any of the sedatives or any of the extra sedation that.
Okay. So actually, what is the advantage of USG guided versus peripheral nerve stimulation?
USG guided, ma'am, we can see the roots, and we can even see the spread of the local anesthetics, and hence we can give less amount of local anesthetics, whereas in peripheral nerve block it is a blind technique only on the action of the muscles. So we can inject the drug, and we can't see the spread exactly where is the drug.
Okay. And what about the anatomical marking? I mean, you give the block as per the anatomical marking?
In peripheral nerve
without using peripheral. I mean, that's a blind technique, you can say.
Yes, yes, ma'am. Yes.
Depending upon the anatomical landmarks. So, what is the advantage or disadvantage in this?
In peripheral nerve block, ma'am?
Yeah, yeah.
Yes, ma'am. We can't see the structures, and there are chances of going into vascular structures. So we can avoid peripheral nerve block rather than.
What is the criteria for blind technique? What is the criteria by which you see that the your drug is going to be deposited at a proper place?
Sorry, ma'am, I didn't get you.
What is the criteria while giving anatomical block, landmark block? What is the criteria? You just ask the patient, or the patient feels something?
Current sensation while
Paresthesia, no?
Yes, ma'am, paresthesia.
So that is the body you have to use.
Yes, ma'am.
Anyway, so what are the complications of the interscalene block likely?
Horner syndrome, ma'am. And
yes, what is it? What is it? It is because of what?
Because of phrenic nerve injury on the ipsilateral side, ma'am.
Yes. So, what are the things you can see in Horner syndrome?
Ma'am, ptosis, meiosis, and loss of celospinal reflex and breathing difficulty.
Oh. All right. All right.
Okay.
Okay. Divya, you can ask anything.
Yeah, Renuka?
Yes, ma'am.
Yeah, talking about various approaches, you have given USG guided interscalene block, right?
Yes, ma'am.
In addition to the cervical plexus block.
Yes, ma'am.
So what are the certain contraindications or exclusion criteria which are must, which need to be emphasized properly?
For ma'am?
For the cervical plexus block.
Yes, ma'am.
What category of patients you will totally omit?
Local infection at the site.
Yes.
And any sweat.
Yeah. So any previously operated patients?
Yes, ma'am. Only previously operated patients for incision and drainage, scar marks so we can avoid those kind.
Yeah, and what is the difference? What is like over interscalene and supraclavicular approach? The complications. What? Yes.
Supraclavicular approach, the block is distal, means more distal to the shoulder, ma'am. So we can't use for clavicular surgeries. Whereas interscalene, it blocks C5, C6 roots, which are more proximal, and the nerve supply for the clavicle is nearly C5 to C6 and C7. So for that, we can use interscalene rather than supraclavicular.
Okay. Yes. And what Madam truly said, that with PNS also there's a lot of patient discomfort.
Yes.
Right?
Okay.
When
Yes,
you're
ma'am.
giving voltage and everything, patient experiences jerk while the patient is already in pain. So the USG has an additional advantage of patient comfort.
Yes,
with
ma'am.
patients who have represented us in the perioperative period with complaint of pain.
Yes, ma'am.
Okay. Yeah. Okay. We
Thank
can
you so
proceed to the next session, madam.
Yes, yes. Definitely.
Yeah. So our next presenter is Rinkal Patel. I would request the technical team to please start with her presentation. Rinkal is online.
Ahmedabad. I am presenting in. Hello, I am Dr. Inkal Patel, second year resident from GCRI Ahmedabad. I am presenting intranasal dexmedetomidine versus intranasal midazolam for pre-medication in pediatric patient undergoing surgery. Surgery and anesthesia causes fear of unknown and unfamiliar environment, parental separation, emotional and psychological consequences, hemodynamic changes, and physical resistance in pediatric patients. To minimize this response, we have non-pharmacological methods and pharmacological method. Pharmacological method provides sedation and alleviate anxiety. It should be easy to administer, non-painful, and rapid onset. In this study, we had selected midazolam and dexmedetomidine. Aim of the study was to compare effect of midazolam and dexmedetomidine to reducing anxiety, level of sedation, parental separation, mask acceptance, and intravenous cannulation. Secondary goal was to compare hemodynamic stability. Objective were smooth parental separation, anxiety, facilitate smooth induction of anesthesia. In the methodology, we had first taken ethical committee approval Patient's parents' verbal and written consent taken. Study design was randomized, open label, observer blinded, prospective control study. Sample size was 60 patients. Time period was 4 months. Inclusion criteria were age between 1 to 6 years, ASA grade 1 and 2 of either sex, MPG grade 1 and 2, duration of surgery less than 2 hours. Exclusion criteria were parents' refusal, ASA grade more than 2, allergic or hypersensitivity to drug, difficult intubation and IV access. Patient randomly divided into 3 groups, Group D, Group M and Group C. Group D received dexmedetomidine 1 microgram per kg. Group M received midazolam 0.2 mg per kg. Group C received 0.9% of normal saline. Total drugs equally dropped into both nostrils using needleless syringe in a recumbent position 30 minutes prior to shifting to OR. These are the result, statistical analysis and discussion. This table shows comparison of different scores in study groups after drug administration. In this table, there was a statistical significant difference between 3 groups with better parental separation anxiety score, no or mild reaction to IV cannulation, higher mask acceptance in group D than group M and group C. Ramsey sedation score were statistically higher in group M at all time after drug administration, while it was lower than group D just before shifting to OR. No sedation seen in control group. This table shows comparison of different variables in study groups after drug administration till patient shifted to OR. In this table, after study drug administration, there was a significant difference in heart rate in group D as compared to group M and group C. We did not observe any significant decrease in respiratory rate and percentage of SpO2 before and after drug administration. From this study, we conclude that intranasal dexmedetomidine and intranasal midazolam provide effective sedation, parenteral separation, lower reactivity to IV cannulation, and better mask acceptance. Intranasal dexmedetomidine provide better sedation than intranasal midazolam as pre-medication in pediatric patients. These are the references. Thank you.
Madam, you need to unmute yourself.
Hello. Huh.
Yes, ma'am. Yes.
Sorry.
No problem.
And this is a very interesting topic and very important one. The study is really nice. And what is the amount of dexmedetomidine in ml, which was given intranasally? Approximately, because it will depend upon the weight.
Weight of the patient.
So what was the ml? I mean, was it comfortable for the patient?
Hello.
Or acceptance while putting intranasally?
Hello. Sorry, ma'am.
Hello. Hello.
Hello.
Huh. Can you listen to me now? Can you listen?
Yes, ma'am. Yes, ma'am.
So I just wanted to know that how much was the in ml quantity of the dexmedetomidine or midazolam. You can tell me the range. So was it comfortable for the patient to introduce intranasally?
Yes, ma'am.
How much it was maximally? Suppose 1 to 6 years you said. Okay. You
Yes.
selected the range of age was 1 to 6, isn't it?
6. Yes, ma'am.
6, huh? So what was the maximum ml of dexmedetomidine you introduced intranasally?
Ma'am, around 0.5 ml to 1 ml.
So 5 ml is quite a quantity. Whether the patient accepted that?
Yes, ma'am.
Intranasally.
Yes, ma'am. We have pre-visited a pre-anesthetic evaluation and
that is
you
true.
You have mentioned 2 ml in your study. So there should be some maximum limit.
Because 5 ml introducing via nasally is quite an amount. Nobody will accept that. Patient will resist, isn't it? That is what I think. So was that practically done or not?
Yes.
Patient accepted like introducing 5 ml of this thing? Dexmedetomidine or by calculation?
My dose was 1 microgram per kg.
Okay. Suppose patient is 2 years old. So how much must be the weight? Suppose
Around
5 kg.
5 to
Anyway,
7.
you consider the 5. So what will be the dose? 5 microgram.
5 microgram.
So what is the concentration of the dexmedetomidine available per ml? So you must be knowing whether it is
Dexmedetomidine
ampule.
ampule, madam, is asking is how many mg
Ampule.
per ml?
Concentration original in ampule. It's a
Undiluted
50,
ampule.
no? Isn't it? So you have diluted it now. You should have said why there is hesitation or not answering this question. How you diluted it is the important thing, so that you can reduce the quantity to put in intranasally. Okay.
You can
Whether
use
she's,
CT syringes for dilution and exact dosage.
so you
That
can.
is the intention.
Okay.
Are we audible, Renuka?
I don't think she is audible.
Well, are we audible?
She's
Unmute
disconnected.
yourself, Twinkle. Yes.
Okay. So you should why you are so under tension that you are not able to tell the concentration which is available for which you have diluted. Available concentration of dexmedetomidine. How you prepared is the important thing, isn't it? Hello. She's disconnected, I think.
No, she's unmuted. She's muted herself. Wrinkle? Can you hear, madam?
Yes, ma'am.
Yeah. So, what is the concentration available? Is it clear now? Commercial availability of the concentration. Wrinkle?
Yes, ma'am. It is 10 microgram per ml.
No.
In an
And I'm saying
ampule.
the ampule available, no? 0.5 ml and 1 ml, 2 ml. What is the concentration of the drug available per ml? That is what we aim to ask you.
Sorry, ma'am.
Okay, so what is the advantage of dexmedetomidine over midazolam? Why is it preferred in children nowadays? Even for daycare procedures like MRI. What is the beauty of dexmedetomidine?
Compared to midazolam, dexmedetomidine.
Why is it used in pediatrics? I can give you a hint for the answer. Dexmedetomidine belongs to such a class of drugs where it has minimal effect on the respiration. Okay.
Yes, ma'am.
So even if the child or the adult is he is arousable as compared to when given for other drugs. So intranasal dexmedetomidine is nowadays also used for daycare procedures in pediatrics like MRI, right, by intranasal route. So whenever you're preparing, you can use a tuberculin or a BD syringe, dilute your drugs according to the weight of the child, right?
Okay.
And administer it in each nostril equally, or whatever method you use, 30 minutes prior to. So the patient would be in a sleepy state but arousable with minimal effect on respiration, right? Our aim is not to sedate too much such that it protects its airway reflexes and we don't have to do any invasive intubation or anything, right?
Yes.
Sorry that I was disconnected because of some call. There is one candidate, Amrut, from Patna. He is not able to communicate with this. Somehow he is not getting the network. So he said he is not able to. Can you do something for him?
We'll check, ma'am.
Okay.
Amrut. Okay.
Yes. From Patna. Okay, we can go for the next.
Yeah. Thank you, Rinka. Our next participant is Rishika Reddy.
Good morning, ma'am.
Yes. We have too much of dexmedetomidine today.
Greetings. My name is Dr. M. Rishika Reddy, and my topic today is role of dexmedetomidine as an adjuvant to ropivacaine in supraclavicular brachial plexus block. Introduction. Plexus blockade remains as a well-accepted component of comprehensive anesthetic care. Skillful application of plexus neural blockade broadens the anesthesiologist's range of options in providing optimal anesthetic care. Regional anesthesia avoids unwanted effects of systemic anesthetic drugs during GA and the stress of laryngoscopy and tracheal intubation. My aim is to evaluate the effect of dexmedetomidine as an adjuvant to 0.75% ropivacaine for institution of supraclavicular brachial plexus block. My primary objective is to compare the onset of sensory blockade and duration of analgesia with combination of dexmedetomidine and 0.75% ropivacaine against 0.75% ropivacaine alone. My secondary objective is to compare the onset of motor blockade and incidence of adverse effects between the two groups. My place of study is Kamneni Academy of Medical Sciences and Research Center, Hyderabad. My sample size is 60 and my study population are patients admitted for upper limb orthopedic surgeries between November 2019 to October 2020. My study design is prospective randomized double-blinded control study. Ethical committee approval was obtained. Written informed consent obtained prior to the study. My inclusion criteria is ASA grade 1, 2, 3, age group less than 70 years of age. Both sexes are included. My exclusion criteria are patient's refusal, patient with local infection at the site of injection, suspected brachial plexus injury or peripheral neuropathy, known hypersensitivity to study drugs or bleeding disorders. All patients are randomly allocated into two groups using chitin box method. Patients in group B received 20 ml of 0.75% ropivacaine with dexmedetomidine in 0.5 microgram per kg dose. Patients in group A received 20 ml of 0.75% ropivacaine alone. The onset of duration of motor block was recorded with modified bromate scale. My rescue analgesia was provided if VAS score was greater than or equal to 3. All results are tabulated and analyzed statistically. My technique of blinding are all study drugs were drawn by an anesthesiologist who was blinded to the study, coded and handed over to another anesthesiologist who was blinded to the drug for administration and subsequent follow-up. My statistical method included quantitative data analyzed using unpaired t-test, qualitative data analyzed using chi-square test, and p less than 0.05 was considered significant. Data was entered in Microsoft Excel and analysis was done using SPSS for Windows software. In my statistical analysis, it was seen that group B, which contained dexmedetomidine with ropivacaine, had prolonged duration of analgesia when compared to the group which was given only 0.75% ropivacaine. My onset of sensory and motor blockade was also more in group B when compared to group A. In few patients in group B experienced hypertension and bradycardia, which was not seen in group A, which was given only 0.75% ropivacaine. So in this study, we observed that dexmedetomidine significantly shortened the onset of sensory and motor block. So this observation matches well with Kathuria et al. Study. Duration of motor and sensory block was also significantly prolonged. A few patients in the study group had bradycardia and hypertension. Signs of LAST was not seen in any of the group. So my conclusion is addition of dexmedetomidine as an adjuvant to ropivacaine for ultrasound-guided supraclavicular brachial plexus block is highly effective in hastening the onset and prolonging the duration of analgesia so that the patient will be comfortable in the post-operative period. Thank you.
Okay. So what was the maximum duration of action which was prolonged because of dexmedetomidine in this block? How many, I mean, average hours?
Average around 10 to 11 hours, ma'am.
With dexmedetomidine.
With
Okay.
dexmedetomidine.
And what about only ropivacaine?
Ma'am, it was around 8 hours or so, 8 to 9 hours. So
definitely it is more than bupivacaine, isn't it?
ropivacaine, yes, ma'am.
Yeah, I know. But when you give the bupivacaine, it is more than that. Ropivacaine has got a prolonged.
It has more sensory action than bupivacaine, yes, ma'am.
Yes, definitely. So the analgesia is more with the ropivacaine.
Yes, ma'am.
And as you said that there are side effects like bradycardia and hypotension. So how it was treated?
Ma'am, we have given anticholinergics like glycopyrrolate or atropine for bradycardia patients, ma'am.
Okay. And hypotension required?
For hypotension, we have given mephentermine, ma'am.
it was required, or when you corrected the bradycardia, the hypotension was corrected?
Ma'am, actually,
you needed separately give a mepentine also.
Ma'am, in one case we have given both, and in one case only after giving anticholinergics the BP has settled itself, ma'am.
Okay, so there were out of your study number of patients were total
60, ma'am.
Number of 60. So
yes.
30 were given dexmed. So
yes,
out of that, what was the incidence of bradycardia?
Around 4 patients.
You can tell about how many patients out of 15, no? 30 patients.
Around 30, around 4 to 5 patients have experienced the adverse effects.
Interference.
Yes, ma'am, they needed interference.
Yes. Okay. Okay.
What are the concentration of ropivacaine available? In what concentrations is ropivacaine available?
In my study, I have used 0.75% ropivacaine, ma'am.
Have you used 0.75%? Which other concentrations are available, which you can be using?
0.5% ropivacaine, 0.375% ropivacaine concentrations are also available in the market.
0.2, 0.5, 0.75.
Yes, ma'am. 0.375, 0.5.
Okay. And what other adjuvants you can use with ropivacaine in? What there are other class of drugs also which faster the onset rather than faster the duration?
Opioids can be used as adjuvants, ma'am.
What about sodium bicarbonate and other drugs?
Yes, ma'am. Sodium bicarbonate can also be given for with local anesthetics.
Those are for faster onset.
Yes,
okay.
ma'am.
How
yes,
do they work?
Soda bicarb actually decreases the PK value of local anesthetic so that it increases the onset, hastens the onset of action of the local anesthetic. So
faster
it is
rather than the
yes,
duration.
ma'am.
Okay. Can IV dexmedetomidine used as an adjuvant for what other forms dexmedetomidine can be used as an adjuvant to prolong the effect of block?
I'm not quite
Let's
sure.
go into that. Yes.
Yes.
Yes. Yeah.
Yes, ma'am.
Okay. Yeah. We can go on with the next presentation, madam.
Yes, yes.
Thank you. It was a nice study.
Thank you, ma'am. Thank you, ma'am.
We have our next presenter is Rituraj Singh. Yes, Rituraj.
Good afternoon, respected judges. My name is Dr. Rituraj Singh Baghel. Title of my paper is A Case Series of Continuous Supraclavicular Brachial Plexus Block in Upper Limb Surgeries under the guidance of Dr. Anis Dubey, Associate Professor, and Dr. Nupur Chakravarti, Professor and Head, Department of Anesthesiology, LN Medical College, Bhopal. My introduction: injury to upper extremities are very common and can lead to everlasting disabilities. Elective and emergency surgical procedures for upper limb surgeries are frequent. Brachial plexus block is a very respected and useful regional anesthesia procedure which provides selection with appropriate selection of patient and sedation. This block not only provides positive condition for surgery but also provide excellent post-operative analgesia. Supraclavicular approach of brachial plexus block with added ultrasound guidance reduces the possible risk of pneumothorax. Along with this, it also allows a faster onset time and reduction of dose of local anesthetic. My aim of study is to evaluate the effect of continuous supraclavicular block on post-operative analgesia. My objectives are to observe the duration of analgesia, to observe the duration of onset of pain, to observe the number of top-up with local anesthetic drug within 24 hours, and to observe the incidence of side effects. Methodology: 30 patient, age between 18 to 60 years, sample size 30, duration of study, type of study is observational. Supraclavicular brachial plexus blocks was given by an experienced anesthesiologist. The continuous brachial plexus block consists of 3 phases: placement of needle, the catheter, advancement, and securing the catheter. The transducer is positioned in transverse plane immediately proximal to the clavicle, slightly posterior to at its midpoint. The brachial plexus is visualized as a collection of hypoechoic oval structure posterior to the superficial to the artery. Appropriate amount of drug is introduced and deposited with proper precaution. An 18 gauge 3.5 inch 2A needle was used to perform this block, and 18 gauge 60 centimeters stimulating catheter was inserted to various depth and desired position was confirmed with ultrasound. All catheter were secured in place with elastic adhesive bandage and sterile strips. Drug used for block is 6 ml of lignocaine ADR, concentration 21.3 milligram per ml, and 4 ml of bupivacaine, concentration 5 mg per ml, 1 ml of normal saline, 1 ml of sodium bicarbonate. While the top up done with 3 ml of lignocaine ADR and 2 ml of bupivacaine with 0.5 ml of normal saline and 0.5 ml of sodium bicarbonate. Result is the 30 patient underwent USG guided supraclavicular block, and during all blocks, sonographic visibility of needle, plexus, subclavian artery, and local anesthetic spread was achieved. All the patients were between 18 to 60 years of age with mean age is 31.03 with standard deviation of 10.07. The mean BMI is 27.72 with a standard deviation of 4.44. Surgical regional anesthesia was achieved in 90% of blocks. 4 cases of catheter displacement, 3 patient complaints of itching at the site of catheter insertion. Mean duration of analgesia in minutes is 218.12 minutes with a standard deviation of 18.87. Top up with local anesthetic done when patient complains of pain or was more than 4. The mean number of times top up done within 24 hours is 3.66 with standard deviation of 0.80. Brachial plexus block is a highly efficient nerve block for surgeries of upper limb. It provides peculiar and superior operative condition and post-operative pain relief. The use of real-time ultrasound guidance allows a visualization of target or structure with its anatomical surrounding, and lower volume of local anesthetic is required to achieve an adequate block, as well as quality of block is also better. Apart from that, the incidence of complication is also decreased. Use of continuous supraclavicular block as a post-operative analgesia significantly reduces the requirement of IV analgesics and opioids. As the procedure is performed under brachial block, early return of GI motility and early discharge of patient. Post-operatively, in few patients, there were minor degree of operative site pain, anxiety, itching at the site of catheter insertion, which were treated with symptomatic and supportive treatment. As there was no report of any severe operative site pain, all the patient resumes oral intake on the day of surgery. Thanking you.
It's finished. Okay.
Morning, ma'am.
So this is, hello. So
Yes.
these are the cases in which you put the catheter, isn't it?
Yes, ma'am.
So analgesia was provided for how many hours?
Analgesia is average duration is 218 minutes, ma'am.
Achha, so how many top-ups you have to give?
Around on an average, ma'am, 3 to 4 times, but mean is 3.66 with a standard deviation of 0.80, ma'am. 3 to 4 times top up usually done, ma'am.
Okay. So what were the surgeries which were done?
Ma'am, most surgeries of upper limb surgery, mainly that fractures of forearm, wrist, and elbow.
Yeah. You cannot do humerus fractures, isn't it? Or can you do with that?
Yes, ma'am. We can do, but yes, ma'am. But not. We can do it. Yes, ma'am. It's under the coverage of brachial plexus, our block.
सुप्राक्लेविकल में अपर पार्ट कवर होता है क्या?
No, ma'am. वो upper part spare होता है, ma'am. So we usually, मतलब we avoid.
Yes.
It depends upon the quality of
So
block.
the action of the supraclavicular block is below half of the humerus, distal.
Yes, ma'am.
Part of the humerus, and that is covered, isn't it?
Yes, ma'am.
So all these procedures required tourniquet, isn't it?
Yes, ma'am. Yes, ma'am. To avoid the decrease the blood supply, blood loss.
Yeah, but then where you put the tourniquet then in this block?
Ma'am, upper half of the arm.
Upper half will definitely give the pain. Proximal.
Yes. Ma'am, you are not audible, ma'am.
Ma'am, ma'am will have to probably unmute. Ma'am, you need to unmute yourself. By mistake, there is a click on the mute button. Am I audible?
Yes, ma'am, you are audible, ma'am. Yes, you are audible.
So, ma'am is probably, there must be some. Okay, how is your? Yes, madam is audible now. Yes.
No, there was again call from the Amrut. She said, I'm going to get connected, is possible. So when we can post him. I mean, that has to be scheduled.
Amrit Kumar, madam.
Patel,
He's on
Amrit from
medical-
Patna.
Ma'am, he is not in the list of today's probably.
Acha,
So,
please inform him that, because he
we-
is under the impression that his presentation is just now. So he's calling me
Ma'am,
off
we
and
don't
on.
have his number, so kindly share that number in the group or
Okay.
to Divya ma'am so that we can call him. Okay. Yeah.
Let us finish with this and then. Okay. Hello.
Yes,
Yes, madam.
So I think yes, I was asking about the tourniquet, isn't it?
Yes.
Tunic pain.
Yeah. So what precautions you have taken so that the catheter doesn't get displaced in the post-operative period?
Ma'am,
There
Dynaplas.
are chances with the
Yes,
moment of
ma'am.
the limb, yes.
Ma'am,
Because
there
I-
are chances and there are four patient in which there is a displacement of catheter.
Yes.
Yes, ma'am.
So what are the precautions which you took so that it will not get displaced?
Ma'am,
Because with the analgesia which is provided by your technique, patient is likely to make the movement, isn't it?
yes, ma'am. Slight movement is there apart from the cast. Minimal movement is there, and but we have to avoid. We have to reduce the pain only in post-operative period, which is achieved by the lower amount of drug we are giving through the top-ups.
Okay. Okay, all right.
What is your criteria for giving top-ups?
Ma'am,
At what cutoff value you are saying that the patient has pain? How are you grading? You are using
ma'am, patient complaints of pain or visual analog score equal to or more than 4, ma'am. This is our criteria. This is what we do when in post-operative when
yeah. So
patient
complaints of
requires
pain is a
analgesic.
subjective matter. So
Yes,
you
ma'am.
need to set it more on a VAS score
Yes, ma'am.
or any NRS score which is used nowadays for pain. Okay. In
Yes,
your study type, you have said it is an observational study. Here you are placing the catheter, you are giving the block. So how is it an observational study? You are doing an intervention, right?
Yes, ma'am.
So your type of study should be an interventional prospective study or a case series, whatever it is. It is never an observational study. Observational is somebody else is carrying out and you are just retrogradingly doing the observation of it.
Yes, ma'am.
Okay. So that is what is to be kept in mind.
Yes,
As Madam truly said, what other drugs would you or what are the modalities you would use for reducing the tonic weight pain?
ma'am. Analgesics, ma'am. We can use fentanyl, opioids.
Yeah, so you have to mention that whatever you have done and whatever you give in that case, there should be a uniform platform as it would be giving an additive effect on your drug.
Yes, ma'am.
Okay, so that should
Definitely.
be mentioned clearly,
Yes.
stating whether it is done or whether it is not done or what is done.
Yes, ma'am.
There should be a uniform platform so that it can be easily compared.
Yes, ma'am.
Okay. And you are just giving the top-ups. You're not giving any other analgesic agents, right?
Yes,
If the
ma'am.
VAS score is more.
Yes, ma'am. If VAS score more, we are giving top up.
Okay.
Yes, ma'am.
Yes, thank you.
Yes.
We
Good
would
day.
put the next. This was Rituraj, right?
Yes, ma'am.
Our next presenter is Rohit Gohil. Do we have Rohit with us?
Yes, ma'am.
Yeah. Madam, we'll start with his presentation.
Yes, yes.
Yes.
And I have shared the number of that Amrut from Patna.
Good morning. Myself.
Chairman group, please.
Okay.
Please.
Pradeep, are you there in the chairman group? Okay, madam. I'll do the. No, madam, we haven't received the number in the chairman group.
Yeah, I was just WhatsApp group में भेजा है अभी. I'll see just. I'll check it.
Yeah, no problem. Yeah. Okay, till then we can continue with Dr. Rohit.
My topic is a comparative evaluation of the video endoscope. It's a direct endoscope in the patient undergoing tracheal intubation for elective surgical procedure, prospective randomized study. Introduction: it is a primary concept of anesthesiology to secure airway to pressure and protect during induction maintenance recovery from anesthesia. There are many requirements for proper visualization of glottis using the direct endoscopy, like patient to be positioned in morning sniffing to align other pharyngeal and laryngeal axis in single line. Moreover, putting the endoscope blade in LQA and lifting the glottis to visualize the glottis, serve as noctis stimulation and ECG pressure response. In the last few years, with the development of new technology, visual endoscope have been developed and are said to overcome this shortcoming of the direct endoscopy. Aims and objective aims to compare the suitability of video endoscopy with the direct endoscopy. Primary objective: expert time, insert time, total duration of intubation, number of attempts, quality of visualization, quality apparatus, maneuver. Secondary objective is it is a hemodynamic response and any complication. Tail and method. After April Pro IRB and informed writing consent from all the patients, the study was carried out in the Department of Anesthesia, 30 Hospital, Bhavnagar. Total 50 patients with age group from 18 to 60 year and age grade 1 and 2 are included. In the OT room, the baseline vital are recorded. Standard general anesthesia was given to all patients. Group D intubation was done with use of direct endoscopy. Group B intubation was done with use of visual endoscopy. Glottis expert time was counted from introduction of endoscope from teeth to visualization of glottis. Quality of visualization of glottis was assessed by Cormac Line Grading. To be insertion time was taken from visualization of glottis to insertion of endotracheal tube. In NIPP, RTET, it is also will be recorded and any complication are recorded. Observation and result is gender, weight, and height were comparable in among both group.
Please continue. Hello, you are not audible.
Yes,
in group D was calculated 48. In group B it was a 80% and statistically significant. Number of attempts and optimization maneuver comparable among both group. Optimization maneuver is assessed by Cormac and Lanagan. It is statistically significant. Hemodynamic parameter were comparable between both groups with increase in heart rate after endoscopic in group D more than group B. No any serious incident or any complication occur. The discussion about expert time and total duration of intubation was less in group B than in group D, and it is significant. It is due to video endoscope has high resolution CMOS camera with wide viewing angle. Quality of visualization of glottis was assessed by Cormac and Liana Redding. Number of attempts and optimization maneuver were comparable in both groups. Hemodynamic parameter and complication were comparable in both groups. Conclusion: we can conclude from present study that video takes shorter time to achieve successful intubation, offer hemodynamic stability and better quality of glottic view than mechanical endoscope during intubation. Video endoscope less frequently need assist maneuver, so facilitate intubation with less complication. Both devices are useful for routine intubation in adult patient.
Hello.
Yes, Rohit.
Yes, ma'am.
Yeah. You compared video laryngoscope with the normal laryngoscopy. What are the advantages of video laryngoscope?
Ma'am, advantage of video endoscope is the decrease in video endoscope. Total intubation time is less, and the visualization of glottic exposure is better in video endoscope, and the video endoscope.
I would like to ask, what are the clear-cut indications where you would prefer video laryngoscope over normal laryngoscope? With respect to positioning or other cases, I'm giving you a hint, okay?
Video special indication in the ma'am cervical spine injury. In the cervical spine injury, in the video mobilization is not required. So in cervical spine injury, any COVID in the COVID patient, because chances of infection is the more. So video endoscopy also used in a COVID
aerosol generation and everything, and the distance with respect to COVID. Yes, very good. So in short,
Very
the
good.
positioning required for the patient during video laryngoscopy is different as compared to the routine scopy, which requires your sniffing position, everything. So anything with dealing with cervical
Yes, ma'am.
or where trauma patients where minimal
Yes.
movement is to be done as
Yes,
you
ma'am.
correctly
Yes,
cervical spine. Yes.
Yes, ma'am.
Over to you, madam.
Hello.
ma'am.
Actually,
Yes, ma'am.
video laryngoscopy requires some experience for the operating person, isn't it?
Yes, madam.
So if you are going to operate that for the first time, you may not be able to do it in a lesser time, intubation, isn't it?
Yes, ma'am.
Because the tube has to be guided.
Yes, ma'am.
Either it is having a slot or sometimes it is having no slot.
Yes, ma'am.
So you have to guide. So that is the experience which is required. Unless and until that you get the experience, you are not able to do it quickly.
Yes,
So
ma'am.
that is the disadvantage of the video laryngoscopy, that you have to be conversant with that technique.
Yes, ma'am. Yes.
You have to use the stillet, isn't it?
Yes, ma'am. Yes,
For the
ma'am.
endotracheal. Otherwise, it is not possible.
Yes,
The
ma'am.
view, one has to be get used to that, isn't it?
Yes, ma'am.
Nice topic. Okay. Thank you.
Thank you, ma'am.
Thank you, Rohit. Ma'am, we can proceed, right?
Yes.
Yes.
The other person, that Amrut, is frantically calling.
No,
I
madam.
have
Actually,
shared
I
that
have handed over Amrut's number to Pradeep. He will be
Yeah,
dealing
yeah.
with it, right, Pradeep?
because he is calling. Just please call him because he's
Yeah,
frantically
madam, we have
calling, and
transferred the
every
number to
time
the
he's
technical team.
I'm
Pradeep,
getting
please can you deal
disrupted.
with Amrut? Yes.
Yes, okay. Next
Yeah.
present.
Next presentation is Roshni Tripathi. Roshni,
Yes, ma'am.
is from NHL Medical College. Yes, Roshni. You can start.
My PG guide is Dr. Sangeeta N. Parikh. The title is Ultrasound Guided Central Vein Cannulation in COVID positive patients in ICU. My institute is NHL Medical College and Hospital, Ahmedabad, Gujarat. Introduction: the portable ultrasound machine are highly valuable in the ICU, where the patient's condition might not permit shifting the patient to the USG department for imaging, and proper positioning may be difficult due to the hemodynamic condition of the patients. For ICV access, the patient should be placed in a slightly random position. The head should be in the neutral position. For operator-assisted IGV sonographic guidance, the operator should be standing on the lateral side of the patient, and the procedure should be performed from the head of the patient, and the indicator of the probe should be kept pointing to the operator's left side. Aim: we performed a study guided ESO cannulation, time consumed, associated complication in the USG guided IGV cannulation in ICU patients of COVID-19. Indications: other peripheral sites are unavailable or inaccessible. Large bore venous catheter is in needle for rapid administration of the fluid or blood products, for infusion of vasopressor and sclerosing agents, etc. For replacement of the pulmonary artery catheter, for CV pressure monitoring. After other indications are infection inside. These are
For the interruption, you need to unmute yourself. Rohit, please unmute yourself.
Hello.
More common understanding the technique development to be candidate may be located in ultrasound
Present candidate is not seen.
performed with the aid of the system and a portable ultrasonographic machine is 5 megahertz. It's heat. And the ultrasound probe is then placed on the patient's skin, and the target vessel is.
Hello, Divya.
Yes, madam.
The previous candidate is seen, and there is disturbance
Yes.
of the.
Dr. Rohit, you need to please mute yourself. You're creating disturbance unknowingly. You're facing a lot of disturbances as your speaker is on. Thank you. Now you can start, Pradeep.
Yes.
The vein is identified with several techniques, like including physical, respiratory, pulsation, etc. The vein tube cannulator should be centered on the ultrasound screen. Once the anticipated path of the nerve is identified, it is anesthetized with lidocaine. Next, the skin is punctured with a thin-walled percutaneous entry needle. Do not focus the ultrasound monitor until the needle has been entered into the skin. Visual focus is then directed to the ultrasound monitor. Here the needle appears isomorphically as an echogenic line. In the short axis view, some scan back and forth with the probe over the needle to locate the needle tip. After the needle is seen puncturing the vessels and the flash of the seen in the syringe, the ultrasound transmission may be set aside. Visualization of the guide by using the longitudinal view within the target central vein verifies the intravenous placement. After the needle puncture of the vessel and the guide by replacing the entry of the needle is withdrawn, the puncture site is enlarged with the number 11. Calculate the dilator will be used to facilitate the placement of the catheter. Venous blood return and easy flushing suggests acute placement. A 3-element port is inserted. Ultrasonography can be used to visualize the catheter and its related location. After the catheter is in place, it is secured with either simple intraocular sutures and chest radiography is necessary. Results are output on the patient 100% cannulated successfully. Only one patient directed artery was confident and was cannulated in second attempt. Mean access time of ITP was 126.2 plus or minus 15.4 seconds. Success rate is 100% and 96% patients are cannulated in the first attempt and complication rate is 4%. Discussion of the studies, the music approach had lower rates of complication for cannulation of the internal jugular vein like pneumothorax, hydrothorax, etc. After 3 or more attempts at infarction mechanical complication increased by 6 times compared with the single attempt. In USG-guided approach, most patients are cannulated in the first attempt and compared to the conventional method. Conclusion of our observation and result, we came to the conclusion that the USG approach took lesser time, required lesser attempt, and had lower incidence of complication for cannulation of the internal jugular vein as compared to the conventional method. These are my references. Thank you.
Hello. It was a very fast presentation, I must say. It is like a fast train. Hello.
Yes, ma'am.
So what are the advantages of USG guided central vein access over the routine one, like anatomical?
Yes, ma'am. There are less chances of vessel ruptures. Then there are less chances of pneumothorax. And many a times when we use the LADMA guided technique, then we rupture carotid artery. But there are less chances in USG guided, and pneumothorax is also less in USG guided technique.
So there is a, but still there is a complication of carotid rupture in your case.
Yes, ma'am. Yes, ma'am.
So how can you explain that? How can we explain that?
Yes, ma'am. There can be some experience related issue which can relate to this one complication in which the person who is doing the cannulation might not be that experienced, so maybe because of that one or two complication rate might be there.
So how it was treated?
Ma'am, yes, ma'am. We pressurized with some bandages. We pressurized the area for 10 to 15 minutes until the bleeding is stopped, and we made sure that there is no hematoma, and then only we proceeded further.
So that was the sufficient? Even that sufficed the complication?
No, ma'am, but we made sure that there is no hematoma or there is no further bleeding. Then only we proceeded. Otherwise, if there was some bleeding or if the bleeding didn't stop, then we wouldn't have proceeded, and we checked the coagulation also beforehand.
And hemodynamically, patient was stable then?
Yes, ma'am. Hemodynamically, patient was stable.
So your measures were successful when you checked by hemodynamically?
Yes, ma'am.
Isn't it? What is the
Yes,
criteria otherwise? You can see on ultrasonographically also whether the leakage is going on or not, isn't it?
Yes, ma'am.
Immediately
yes,
you can check that.
Yes, ma'am.
And what the procedure was stopped then? I mean, for the venous access or what?
No, ma'am. No, ma'am. As the patient required it urgently, so procedure was not stopped, but we delayed the procedure for some time until the patient was hemodynamically stable, and then only we proceeded for the next.
So you accessed for the same side, or you went for the other side? In that case, in the
other side.
Other side?
Yes, ma'am.
You went for the other side, or you just tried for the same side?
No, ma'am. We were on the same side, but we were more cautious the next time that we don't puncture it again.
Okay. So you accessed from the same side?
Yes, ma'am.
IJV.
Yes,
Okay.
ma'am.
All right.
I'll ask you a very simple
Dr. Vaijayanti, ma'am.
Yes.
Dr. Divya.
Good morning, madam.
Good morning, ma'am. Can I take 1 minute, ma'am?
Yes, madam.
Yes, of
Thank
course.
you for providing us an opportunity, madam.
Yeah. Ma'am, Dr. Vaijayanti, ma'am, and Dr. Divya, I'm Dr. Hina Chanwal, Scientific Secretary, Isacon 2021, ma'am. And we are thankful to you for chairing the sessions, ma'am. And
Nice.
wish you
Pleasure
good
is
luck for
our.
all the participants. Thank you,
Yeah.
ma'am. Thank you, Divya, Dr. Divya.
Thank you, madam.
Thank you.
You are doing a good job. In spite of so much of a response, you are managing it quite well.
Yes, ma'am. Thank you. Your blessings required, madam.
I know the workload is quite high, but
It is quite high, ma'am. Yeah.
going
Thank
on.
you, ma'am, for chairing the sessions. Thank you.
Yeah.
Thank you, Dr.
Madam.
Divya.
Thank you coming on.
Pleasure is ours.
Yes.
Thank you.
Yeah. Roshni, I'll ask you a very
Yes, ma'am.
simple and practical question. You have done USG guided cannulation on your own, or you have assisted, you have been a part of it?
Ma'am, I have assisted also, and I have done it
So,
also.
as madam, and you spoke about that, how did you accidentally puncture the internal carotid artery? I want to just ask you, how will you differentiate vein and an artery while through your USG probe?
Practically, we can differentiate that after removing the syringe, the flow of the
Asking
blood.
you with the probe, how will you differentiate this is a vein or this is an artery?
Yes, ma'am. The vein is compressible, ma'am. If we just move the probe a slight bit over the position, if it is compressible, then that will be vein, and if it is not, then that will be the artery.
Okay. And my next question is, while coming from medial to lateral side, okay,
yes,
what will be the structures you would cross while you have kept your marker on the left lateral side, that is your needling side? Which structures you will see when you do USG guided cannulation in case of your CVP cannulation?
Yes, ma'am. First, from medial to lateral, first will be the artery, and then only there will be vein. And even if we don't get through that, then we can also guide our needle through, like the pulsations will be there. We will try to slide the artery towards the medial side, and then we will take puncture.
Okay. And for this, in case of accidental puncture, one of the reason might be also that whenever you are giving the drug, considering it is a vein, okay,
yes,
sometimes due to when you aspirate and when you give the drug, there is a blackish, bubblish structure where you can see the dispersion of the drug. Okay. Sometimes when you're just at the border of it, not completely, your tip is not completely in the vessel, due to the pressure changes and everything, you might have an arterial bleed also.
Okay, ma'am.
So just
Yes,
be very
ma'am.
careful that you see the needle tip while you are guiding the structure.
Yes, ma'am.
And
Yes,
for the cannulation, you would prefer a right side cannulation first in a normal patient or a left side, and why?
Ma'am, we will prefer the right side cannulation because in the left side, as the lung apex is slightly on the upper side, so there are chances of pneumothorax. So we'll be first prefer the safer side, and that is the right side.
What are the other reasons? You can go.
Yes, ma'am.
Yeah. Anything else, madam?
No, nothing.
Yeah.
We'll ask for the next.
Yeah. Can we go with the next presentation, Pradeep?
Yes,
Thank you, ma'am.
Yeah, thank you, Roshni. Our next presentation is Rubal Jalota.
Good morning, everyone. I am Dr. Rubal Jalota, third year junior resident in Department of Anesthesia in KGMU, Lucknow, and I'm the presenter and author of my paper presentation topic, Evaluation of Anxiety Using Faces Anxiety Scale in ICU Patients Using Noise Ablating Headphones During Nighttime versus ICU Patients Receiving Usual Care. And my co-author are Dr. Professor MP Khan and Dr. Manish Kumar. ICU is one of the most stressful environments for people among various clinical settings in hospitals where patients are not only compromised by illness, but they're also faced with wide variety of stressors such as experience of pain and insomnia, fear of death, loss of interaction with family members, as well as continuous ICU alarms and ICU noises. Anxiety is believed to occur in about 70% to 87% of ICU patients. The aim of my study is to evaluate the anxiety using Faces Anxiety Scale in ICU patients who are using noise ablating headphones during nighttime versus ICU patients who are receiving usual care. Primary objective of my study is to evaluate whether reduction in the stressful ICU noises during nighttime reduced patients' anxiety levels over the course of their ICU stay. And my secondary objective is to determine the effect of requirement of sedatives over the course of their ICU stay. This trial was registered with Clinical Trial Registry of India (CTRI), and after clearance from Ethical Committee, this study was conducted in Intensive Care Unit, Trauma Ventilatory Unit (TVU), Trauma Center, Department of Anesthesiology, KGMU, Lucknow. And this was a randomized prospective study trial. It was done over the duration of 1 year. Statistical analysis, the sample size was calculated on the basis of reduction of anxiety in 2 groups using the following formula. And we included eligible patients or any patients who could interact even intermittently in order to respond to questions about their feelings and emotions and open their eyes and respond to hearing their name spontaneously or are awake and can understand Hindi as well as sufficient corrected vision to see the faces scale. And we excluded patients having severe to profound hearing loss, head oromaxillofacial trauma, baseline use of hearing aids, and any other contraindication to the use of earplugs or headphones. 100 patients that were admitted in ICU after recording their baseline characteristics were randomly divided into 2 groups with 50 patients each, in which group A, study group or the cases group, used standard noise ablating headphones applied from 11 p.m. to 7 a.m. for 4 nights, and group B, that was a control group, received usual care except the use of noise ablating headphones during nighttime. At 11 p.m. and 7 a.m., patients in both groups were assessed by recording their vitals like heart rate, blood pressure, SpO2, and Glasgow Coma Scale, and their anxiety levels were checked both times using Face Anxiety Scale. Requirement of sedatives were also recorded over the course of these 4 nights. And Faces Anxiety Scale, this scale was used in which 0 denoted no anxiety and 4th denoted highest anxiety. I observed that incidence of anxiety levels in the morning in study group was found to be lower than that in control group, and requirement of sedatives were significantly increased in control group as compared to study group over the period of 4 days of their study. And there was a study which was given by Schlenn LL et al. 2007, performed a randomized clinical trial in 12 ICUs of 5 hospitals where 373 patients receiving acute mechanical ventilation were enrolled, and they were divided into 3 groups. One was receiving self-initiated patient-directed music (PDM), second using noise-cancelling headphones (HP), and third which was receiving usual care. The study concluded that greater reduction in anxiety levels and sedation frequency was observed in PDM group. So I conclude that there is a reduced incidence of anxiety in study group, that is cases group, indicated that ICU noises can help ICU patients to sleep through the night and reduce some of the deleterious effect that ICU environment have on the patients. The study also showed that requirement of sedatives was reduced in study group as well as that compared to control group over the course of use of noise ablating headphones. These are my references, and thank you so much for your patience. Thank you.
Very interesting topic and useful one also. So in this your study, the noise ablating headphones were used. So that provided music also. Hello. Ablation of the sound was there with the headphones, but simultaneously the music was supplied or what in your study through the same headphones? Hello. I think disconnection is there. Voice quality is not good. We can't listen.
Now it is better.
Distorted voice.
Pradeep, is there any connection problem from our side?
No, ma'am.
The candidate's voice is distorted. She's not connected, I think.
Google, can you hear us? She's probably disconnected. We'll wait 2 minutes.
She's disconnected.
Hello.
Yes,
Hello.
Rubal, you're there?
Yeah, ma'am.
Yeah, okay, madam. Here she is.
Okay. So this is a very interesting topic that you have taken on to study. And I just wanted to ask whether this ablation of with the microphone or headphone, you can call it, was the patients were supplied with the music also?
No, ma'am. Patients were just supplied with the headphones, and they were able to ablate the noises of the alarms, and sisters and nurses, their noises were getting ablated. Just that, ma'am.
Yeah.
And ma'am, because music, ma'am, all the people, they have different choices of their music, so we could not be able to provide what type of music will be applicable for certain kind of patients.
There was a study that you mentioned that this was also applied for the patients, no? You mentioned that, no?
Ma'am, there is
video?
yeah, ma'am, there was a similar study in which they were using music therapy. It was conducted somewhere outside India, and in that they were having a special they were having a music therapist person who was randomizing the kind of music which were given to the people.
Okay. So the results were very good with that? Even
Yes,
better
ma'am.
with the... Okay. Nice experimentation. Good.
Thank you, ma'am.
And
Thank you.
beneficial for the ICU, definitely.
Yes, ma'am.
Good one.
Thank you so much, ma'am.
It's a nice innovative study, something
Yes,
new,
ma'am.
but still in practice. We'll proceed. We'll proceed with the next presenter.
Yes.
Our next presenter is Ruchi Vinci. Can we have her presentation, please?
Respected judges, I'm Dr. Ruchi, and my topic for paper presentation is evaluation of the effect of intravenous lignocaine and dexamethasone on postoperative sore throat. A sore throat after tracheal intubation is one of the most common postoperative problems causing dissatisfaction to patient. It is ranked 6th amongst the 10 most undesirable adverse effects following GA with a high variable incidence of 30 to 70%. Various methods have been tried to combat it, such as steroids, lignocaine, aspirin, ketamine, but not many studies have compared the effectiveness of these drugs. Thus, our aim was to compare the effect of intravenous lignocaine and intravenous dexamethasone on postoperative sore throat. This was a non-randomized prospective observational study conducted in a tertiary care hospital having 90 participants. They were divided equally into 45 participants in each group, Group L for lignocaine and D for dexamethasone. We included patients belonging to ASA grade 1 and 2 between the age of 18 to 60 years, and patients with a pre-existing URTI, anticipated difficult intubation, difficult airway, chronic diabetes, on steroid medications, vocal performers, pregnant and obese patients, ENT surgeries, and prolonged duration surgeries were excluded from our study. A detailed PAC was done prior to surgery and patients were kept NBM for 6 hours. They were allocated into two groups, L and D. Group L received injection lignocaine 1.5 mg per kg IV, and Group D received injection dexamethasone 8 mg prior to induction, after which standard protocol of GA was followed. We recorded postoperative sore throat and hoarseness of voice up to 12 hours post-extubation at hours 1, 3, 6, 9, and 12. The scoring system that we used was this. Demographically, our data was comparable between both the groups. There was no significant difference in the mean age, sex distribution, or average BMI of either groups. Time taken for intubation, EDT, cuff pressure, and duration of intubation was comparable in either groups, with p-value being less than 0.05. Presence of blood on ETT and on suction catheter was also comparable between both groups. P-value was significant for Group D, that is less than 0.05 throughout the observation period, that is up to 12 hours post-extubation, which shows that there is better reduction of postoperative sore throat in Group D as compared to Group L. In Group D, there was a significant decrease in postoperative hoarseness of voice as well at hours 1, 3, and 6 post-extubation, with p-value being less than 0.05, and no significant difference was noted at hours 9 and 12 post-extubation. Several interventions have been attempted to reduce this problem, but none have been able to eliminate it completely. Soon et al. Conducted a meta-analysis in which they found that IV dexamethasone in the dose of 0.5 mg per kg was very effective at reducing the risk and severity of postoperative sore throat and hoarseness of voice. Cochrane database also conducted a systematic review which showed lignocaine was very effective at significant reduction in overall risk of postoperative sore throat. Kirmani et al. Conducted a study in 2019 that aimed to compare the effect of IV dexamethasone and lignocaine for the same thing in laminectomy surgeries. They found that both the drugs were equally effective. However, in our study, we aimed to compare both the drugs. We found that IV dexamethasone in the dose of 8 mg is better at reduction of postoperative sore throat, cough, and hoarseness of voice as compared to IV lignocaine up to 12 hours post-intubation. Subedi et al. Conducted a study in 2018 which had similar findings to our study. This study was carried out in a limited number of patients, and being a subjective finding, there can be a reporting bias. It was a single-blinded study, and further evaluation can also be done to extrapolate these findings in patients having difficult airway. After comparison of these results in both groups, we can conclude that IV dexamethasone is more effective in reduction of postoperative sore throat, cough, and hoarseness of voice. These are my references. Thank you.
Okay. So you used dexmedetomidine and
Ma'am, I used dexamethasone.
dexamethasone.
Yes, ma'am. Yes.
Dexamethasone and lignocaine. Okay.
Yes, ma'am.
Dexamethasone.
Okay. So when you gave actually at the
Ma'am,
induction,
prior to induction, ma'am, prior to pre-medication as well. As soon as we take Ma'am, as soon as we take the patient inside the operation theater, after attaching all routine monitors and noting the vitals of the patient, we have given this drug, ma'am.
So dexamethasone seems to be better than lignocaine.
Yes, ma'am. Yes.
So what are the other causes of, what are actually the causes of sore throat in post-operative?
Ma'am, one of the first causes is, ma'am, if there is a trauma during intubation during our laryngoscopy, if we use larger size tubes as compared to the weight surgeries, if they have kept intubated the patient for a longer duration. And ma'am, if the cuff pressure is not monitored adequately intraoperatively and it goes beyond 30
What are the types of cuff pressures?
of water.
Endotracheal cuff pressures. What are the type of it? There are types of cuff pressures.
The ETT tubes can be cuffed or uncuffed, ma'am. There are two types of cuff tubes. Ma'am, they can be high volume, low pressure, and low pressure, high volume cuffs, ma'am.
So which is better? Which is better?
Ma'am, it has studies that have been performed, ma'am. It has
voice
been
is not,
duration of surgeries give rise to lesser. Hello, ma'am. Can you hear me?
It is getting interrupted. Okay, you carry on.
Is it better now? Yes.
Yeah.
Ma'am, it has been found that in shorter duration surgeries, high volume, low pressure cuffs are better and give less post-operative sore throat because their impact on the tracheal mucosa is lesser, ma'am. So there is lesser tracheal mucosa ischemia, lesser irritation. But they have also found that if the patient is kept intubated for a prolonged duration, these high volume cuffs will involve a larger tracheal wall area. So yes, ma'am. So in longer duration, they will cause higher incidences of post-operative sore throat.
Okay. So they are using high pressure, low volume?
No, ma'am. We use low pressure, high volume cuffs only, ma'am.
Because that is the better one. So
yes,
any other thing, can you deflate at intervals to reduce all?
Yes.
Deflation.
Yes, ma'am. It can be intermittently deflated with keeping in mind adequate risk for aspiration.
Of course, you have to aspirate before that.
Yes,
before
ma'am.
That precaution has to be must.
Yes, ma'am.
Okay. Nice presentation.
Thank you, ma'am.
Nice presentation. You need to specify your precisely your time of giving the drug.
Okay, ma'am.
Like 5 minutes prior to intubation, 15 minutes prior to the incision,
yes,
to make it a uniform study.
Okay.
Secondly, as ma'am highlighted very well, that you can also use a digital nowadays available cuff pressure monitor.
Yes, ma'am. Yes, ma'am.
And certain syringes available.
So you
Yes,
can make it a uniform thing.
ma'am, for
Because your
this
size of the
study,
leaky
we
tube
have
also,
maintained it
your
uniform.
size of the endotracheal tube also plays a very important role.
Yes, ma'am.
So you need to uniformly precise on that also.
Yes, ma'am.
Okay. So the timing and those things should be kept in mind.
Yes.
Okay. And we'll go with the next presentation.
Thank
We
you,
have
ma'am.
Archana with us. Thank you, Ruchi.
Thank you, ma'am.
Pradeep. Yeah.
Next presenter, please.
Archana.
Morning, my topic is comparative study of jaw thrust and trapezius squeezing test for laryngeal mask airway insertion.
Can you increase the volume of the presentation if possible?
Coming to the introduction,
I think it is pre-recorded.
laryngeal airway mask has become an indispensable airway management tool in anesthesia practice, even though it is less invasive than endotracheal intubation. Inadequate depth of anesthesia may lead to complications such as increased airway reactivity and physical injury to the patient. Aim of the study is to compare the effectiveness of trapezius squeezing test with that of jaw thrust maneuver as a clinical indicator of adequate condition for LMA insertion under sevoflurane anesthesia. Methodology: randomized control study. This 40 patients were included in this study. Group P were trapezius squeezing test and Group J were jaw thrust test. And inclusion criteria were age ASA 1 and 2, age 18 to 55 years, final surgery, and exclusion criteria were asthma, patient with LRA, URA, and anticipated difficult airway. Patient is shifted to OT, monitors were connected, glycopyrrolate injection 0.2 mg IV was given. Patient was induced via plasma with 6% sevoflurane and oxygen 4 liters per minute. No neuromuscular blocking agent were used. The trapezius squeezing test or jaw thrust was performed for monitoring of entitled sevoflurane concentration according to the study group. The study was repeated every 10 seconds and LM was inserted immediately after negative response to the trapezius test or jaw thrust test. And parameters recorded were insertion entitled sevoflurane to the negative trapezius squeezing test or jaw thrust test, pre-insertion heart rate map, and post-insertion heart rate and map after 1 minute of LMA insertion, entitled sevoflurane concentration using the gas monitor, successful attempts. This is the image. It shows the patient with LMA insertion and the gas monitor, and this is a method for trapezius squeezing test, and this is a method for jaw thrust test. And the results were no demographic significant data, and p-value is statistically significant in post-insertion heart rate and map and entitled p-value. And this is the data showing the p-values statistically significant in post-insertion heart rate, that is 0.08, and map is statistically significant in post-insertion, that is 0.005, and coming to the insertion, that is relatively significant compared to both groups. And entitled sevoflurane concentration is a little bit high, required higher in T compared to J, and it is statistically significant p-value which is less than 0.001, and the number of successful attempts are statistically relatively significant in both groups. And coming to the discussion, this group trapezius squeezing test is a better indicator of adequate condition for LMA insertion than jaw thrust maneuver under the sevoflurane anesthesia. The trapezius squeezing test, which is performed by squeezing the trapezius muscle and observing a movement of the first toe, is negative in deep anesthesia. It has been used as a standard stimulus to assess the depth of anesthesia. And positive trapezius squeezing test requires a more anesthetic agent to eliminate the response. And trapezius squeezing test is the best indicator also in the children. However, mean anticipation heart rate was maintained during LMA insertion in both groups. These results suggest that the trapezius squeezing test is not excessive nauseous stimulus that can induce hypotension and bradycardia. Coming to the conclusion, the trapezius squeezing test is a superior indicator of adequate condition for LMA insertion compared to the jaw thrust maneuver in the adult under sevoflurane anesthesia. These are the references. Thank you.
Okay. This is something new measure to assess the depth of anesthesia.
Morning.
I mean, how it is related like trapezius squeezing?
Ma'am, trapezius squeezing test requires more power than jaw thrust test. So jaw thrust may come LMA incision only with jaw thrust may result in coughing, inadequate anesthesia, inadequate depth of anesthesia.
This is quite a novel. I mean, I have never come across such a trapezius test and I mean pressing. So anyway, you conducted the study on how many patients?
Sir, I'm 20 patients, ma'am, each group.
Which way? How many? 120?
20, ma'am, totally 40
only
patients.
20. Only 20. That was
20,
enough.
20 on each group, ma'am.
Yeah, that is total is 40. So
total 40, right?
Yes, ma'am, yes, ma'am.
So that is quite a small number of patients to conclude. Sample size appears to be very small to conclude on that. That is what I think.
Okay.
Divya, have you come across such a test? I mean, to assess?
The first for my side also.
Yeah, because even
But
I
we are
am
thankful
surprised.
to you for bringing us that highlight. We will surely go through it and try the same. But however, your sample size is too small because for any study to have a non-biased result, for as we talk about a sigmoid curve or S-shaped curve, to be on any of the side, you take a smaller sample size in general. I'm saying for all participants, you have a very biased result. You cannot ascertain it onto a bigger set of population. So your minimum sample size should be 60.
Okay.
Yes.
Right? Yeah. So that, and you have a new study, that is a good thing. We will also, you've also given us a ray of studying towards that topic.
Okay.
You have highlighted your references, right?
Yes, ma'am. Yes, ma'am. I have highlighted my references, ma'am.
Yeah. Okay.
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 We'll proceed with our next presenter, an
Okay.
innovative study. Thank you.
Thank you. Thank you.
Our next presenter is Sachin Patel. Sachin Kumar Patel. Yes, you are online. I can see you. You can, Pradeep, we can start with his presentation, please.
Hello everyone, myself Dr. Sachin Patel. Today I am presenting a paper on effect of intraoperatively dexmedetomidine on hemodynamic changes in patients undergoing laparoscopic cholecystectomy under the guidance of Dr. Tarlika P. Doctor and Dr. Seema Gandhi. As we know, laparoscopic cholecystectomy is one of the commonest surgery performed under the general anesthesia with advantage like smaller incision, reduce the blood loss and shorter recovery time. But maintaining hemodynamic stability is challenging because increase in intra-abdominal pressure and volume, extreme of the patient positioning and accumulation of the CO2, which affect on patient's hemodynamic, respiratory and metabolic function. Dexmedetomidine is a potent and highly selective alpha-2 adrenergic receptor agonist when used in intraoperative period in laparoscopic cholecystectomy. It provides sympatholysis, analgesia, sedation, hemodynamic stability, post-operative analgesia, and reduce the requirement of the opioid and other anesthesia drugs for maintenance. This pilot study was designed to evaluate the effect of the intraoperative IV dexmedetomidine on intraoperative hemodynamic changes and incidence of the side effect in patients scheduled for the laparoscopic cholecystectomy. The pilot study was conducted on a 20 adult patient of ASA grade 1, 2 and 3 of either gender scheduled for the elective laparoscopic cholecystectomy. All patients were preoperatively assessed a day before surgery and informed and written consent obtained before the surgery. IV line secured and monitor attached and baseline vital parameter recorded. Pre-medication were given 10 minutes before the surgery and pre-oxygenated for the with 100% oxygen with 3 minutes for 3 minutes. Patient induced with propofol and succinylcholine. After the induction, all patients received a dexmedetomidine infusion 1 microgram per kg in 100 cc normal saline over the 15 to 20 minutes. Patient were monitored for the changes heart rate, systolic blood pressure, diastolic blood pressure, mean arterial blood pressure, SpO2 and EtCO2 at baseline, and then every 50-minute interval till the surgery end, and patient were reversed and extubated. In our observation, out of 20 patients, 5 patients had a bradycardia and 4 patients had a significant hypotension. The maximum fall noted in a pulse rate was 53 beats per minute, and maximum fall noted in systolic blood pressure was 88 mmHg. Intraoperatively, requirement of inhalation gas was less, and after the extubation was for 2 or 3 for 6 to 7 hours, and rescue analgesia requirement also a less within 24 hours. Recovery was smooth, calm, and pain-free. This slide show the graphical presentation of the result. The fall of heart rate, systolic blood pressure, diastolic blood pressure, and mean arterial blood pressure started from the 15 to 20 minutes after the induction, and maximum fall noted around the 45 minutes. As we know, dexmedetomidine is a highly selective alpha-2 adrenergic agonist, which act through the alpha-3 receptor alpha-2 A, B, C. The hypotension and bradycardia are caused by the activation of the alpha-2 receptor present in the brainstem, and the sedation is caused by the activation of the alpha-2 A and C, which present on the local cellulars. And we can conclude that dexmedetomidine infusion is a better option to maintain hemodynamic stability during the laparoscopic surgery, as it effectively attenuates the hemodynamic stress response with the reduction in requirement of the other anesthesia, drugs, and cases with post-operative pain-free periods. Thank you.
Yes.
Good morning, ma'am.
Good morning. Very nice presentation. And as we all know, the dexmedetomidine is a wonder drug which has been used for, in different ways we are using it. So you are using it for the hemodynamic stability during laparoscopic surgery. So what are the other drugs which have been tried for such purpose?
We can use for hemodynamic stability for laparoscopic surgery. We also use the clonidine as a pre-med. Also, we intermittent doses of the fentanyl in intraoperative, and also we propofol we use for the hemodynamic stability intermittent dose of. Yes.
And out of this, dexmedetomidine has been found to be very effective, isn't it?
Yes.
It has the advantage of post-operative analgesia also, and the requirement of the anesthetic agent is also reduced. So, all right. Nice. Nice presentation and the cases.
Thank you, ma'am.
Conduction. Okay. Divya?
Yes, yes. So we have covered various of dexmedetomidine today. The one of the pending one, laparoscopic surgery with Colida. Yes. So you have given it for attenuation of hemodynamic response, basically, right?
Yes.
There's some network issues.
Sorry, ma'am. I can't hear you. Sorry, ma'am. I can't hear you.
Yeah, we cannot hear. You can continue. Pradeep, there are some network issues. You can start the next presentation.
Ma'am, from our end is okay. We can hear him also and you also.
Am I audible, ma'am?
Yes, yes, you are audible.
Yes, you are.
Yes, we can start with the next presentation. There are probably some network issues. I cannot get through it.
Hello.
Yes, ma'am.
Yes. So what are the adverse effects you found of dexmedetomidine?
Ma'am, mainly adverse effect is bradycardia and hypotension. Is due to the effect of the dexmedetomidine central action on the in the brain in this on local cellulars alpha 2A receptor. It causes the so we have to treat with if a bradycardia happen, then we give the atropine, and if hypotension is a transient, we have to give the mephentermine injection.
Okay, all right. Thank you.
Thank you.
We can go for the next presenter. Yes. Hello, Divya.
Am I audible?
Yeah, you are audible.
Yeah, okay. So the next presenter would be Nida Haidar.
Yes, what is it?
Yes.
Good afternoon. My title is Evaluation of Effect of Preoperative Duloxetine on Reducing Postoperative Morphine Requirement After Open Radical Cholecystectomy, a randomized control study. Introduction. As cancer has become a public health problem, onco-anesthesiologists function as perioperative physician. Postoperative pain is mediated by a variety of distinct mechanisms. Thus, analgesia with many mode of action can help alleviate postoperative pain. The goal is to decrease opioid consumption and thereby opioid-related side effects or hyperalgesia. Duloxetine, SSNRI, increased serotonin and norepinephrine neurotransmission in descending inhibitory pain pathways have been shown to be effective in the treatment of persistent and chronic pain. Duloxetine may play a role in lowering postoperative pain. Primary objective is to study the efficacy of preoperative duloxetine on total morphine requirement at 24 hours after open radical cholecystectomy. Secondary objective is to assess the time to first rescue analgesic requirement, to measure VASA score at 30 minutes, 1 hour, 6 hour, 12 hours, and 24 hours, and to assess the patient satisfaction postoperatively. My study design is a randomized control double-blind prospective study which was conducted at post-operative ward of the Department of Surgical Oncology and General Surgery, KGMU, Lucknow. My study population was gallbladder carcinoma patient. Material and method. My inclusion criteria were ASA grade 1 to 3, patient aged between 20 to 70, undergoing open radical cholecystectomy under general anesthesia for carcinoma gallbladder. My exclusion criteria were patient not giving consent, pregnant and nursing mother, patient who have duloxetine or morphine allergy, pre-existing pain syndrome, and alcohol or drug abuse. My sample size 64 cases, which were included in the study, 32 in each group. Group A was oral duloxetine group and group B was identical matching placebo capsule group. Statistical analysis was performed using SPSS software. Patients were divided into two groups of 32 each. Group A received oral duloxetine. Group B received identical placebo matching capsules 2 hours before surgery. Study was marked with consecutive numbers according to computer-generated table of random numbers. General anesthesia was standardized for all the patient. Pain treatment consisted of patient-controlled analgesia via PCA pump. The above table shows the mean age, gender, BMI, operative duration of patient of group A and group B was statistically insignificant. The mean morphine consumption of patient of group A and group B at 12 hours and 24 hours was compared and the mean difference was statistically significant. The first mean rescue analgesic requirement time of patient of group A and group B was compared. The mean difference was statistically insignificant. The mean VASA score of patient of group A and group B at 0.4 hours, 1 hour, 6 hours, 12 hours, and 24 hours was compared, and the difference was statistically significant. The above table shows the satisfaction of patient. The mean difference was statistically insignificant. The above table shows the adverse event of patient. The mean difference was statistically insignificant. Coming to the discussion, in 2016, Castro Alves revealed that patients receiving duloxetine had a better post-operative quality of recovery than those receiving placebo following abdominal hysterectomy. In 2010, Ho et al. Reported that duloxetine had a significantly stronger opioid-sparing effect. In 2017, Asia et al. Concluded that preoperative treatment of etocoxib plus duloxetine increased analgesia and decreased opioid usage without causing severe side effects. My study relies on above mentioned studies and concluded that preoperative duloxetine medication increased analgesia and significantly decreased opioid usage without substantial adverse effects. My confounding factor is no analysis of psychological status of patient before use of duloxetine. Limitations are it's a small sample size, single-centric study, and patient only of open radical cholecystectomy were included and short follow-ups. Conclusion: the present investigation concluded that preoperative duloxetine medication increased analgesia and significantly decreased opioid usage without substantial adverse effects.
Hello. Actually,
Good morning, ma'am.
Good morning. What is duloxetine?
Ma'am, duloxetine is SNRI, selective norepinephrine reuptake inhibitors. It increases dopamine in prefrontal cortex and thus elevates the mood, and it is used in the treatment of anxiety and depression disorders.
Okay. And how it is available?
Ma'am,
which form
in my study, I have given it in tablet form. I have given 60 mg duloxetine preoperatively 2 hours before the surgery, ma'am.
Standard dosage of 60 mg irrespective of the weight, right?
Yes, ma'am.
In spite of wait. Okay, this is quite a new drug trial, I think. All right. If you have found that the dose of opioid is reduced,
Yes, ma'am.
so the side effects of
Side effect of duloxetine, ma'am?
no. Of the opiates. Naturally, the dose is reduced, so the side
Yes,
effects of
ma'am.
the opioid are
Ma'am,
reduced. That's the
ma'am,
advantage
most
of it, isn't it?
yes, ma'am. Ma'am, the side effect of opioids, ma'am, constipation, ma'am, gastric stasis, ma'am, sedation, delirium, and ma'am, if there is overdose, then ma'am, we can encounter with respiratory depression, ma'am. That's why I was giving opioids with the PCA pump, that patient control analgesic pump. So patient was conscious, and post-operatively patient was conscious, and he was able to press the button
pain.
whenever he feels that he's having pain.
Okay. So actually, how much is the reduction in the opioid dose on an average? Can you
Ma'am,
say in some percentage that this is the reduction in the opioid consumption in as compared to the other group?
ma'am, around 30%, ma'am, reduction.
30% reduction.
Yes, ma'am.
All right. Okay. Thank you.
Thank you, ma'am.
Divya, you want to say something?
Yeah, it is an group of antidepressant drugs, right?
Yes, ma'am. It is a SNRI.
So you need to exclude other patients. Like for those coming for hysterectomy, there are many patients who are like of 50s, 60s, who are on other chronic antidepressants also, especially with dealing with cancer, right? So in respect to answer, so you need to exclude those patients who are on chronic antidepressants or chronic opioids in your exclusion criteria. Because if other antidepressants are going on, you cannot really know the effect of your drug.
Yes, ma'am. Ma'am, I didn't include patients who were already on. Yeah.
Yeah.
Yes, ma'am.
We'll go with the next. It was a nice presentation. Yes.
Thank you, ma'am.
We go with the next presenter.
Divya, how many are there
yes,
still? How many candidates are there?
And we have 6 more.
6 more. And we have completed?
We have complete. This was our 17th presentation.
17. 17.
Yeah, we need to complete 23. So
20.
6.
Yeah, 6 are remaining. Okay.
So we
Yes,
call
please.
our presenter Akanksha Bigod.
Yeah.
Akanksha is being online. Pradeep, please start her presentation.
Hello. Good morning, ma'am.
Yes. Good morning.
Please start.
Yes, continue. Is that pre-recorded?
Respected judges, I am Dr. Akanksha Bigod presenting my paper on the topic of effect of single bolus dose of intravenous magnesium sulfate in attenuating hemodynamic stress response to laryngeal to nasotracheal intubation and laryngoscopy in maxillofacial surgeries.
Recording in progress.
All the maxillofacial surgeries are done in a general anesthesia and most of which require nasotracheal intubation. Nasotracheal intubation is associated with more hemodynamic stress than nasotracheal intubation. Due to high vascularity in maxillofacial region, these surgeries also require more hemodynamic stability. Nasotracheal intubation alters respiration and cardiovascular physiology by reflex response and by physical presence of nasotracheal tube, which is mediated by both sympathetic and parasympathetic nervous system. Most common response to intubation is hypertension and tachycardia, mediated by sympathetic efferent by cardioaccelerator nerves and sympathetic chain ganglia. Hypertensive response is due to the activation of renin-angiotensin system with release of renin from renal juxtaglomerular apparatus. Other effects are arrhythmia and increase in intracranial pressure. Different pharmacological agents have been used to attenuate this stress response, like fentanyl, aspinol, intravenous lignocaine, dexmedetomidine, nitroglycerin, oral pregabalin, oral gabapentin. Since a long time, magnesium sulfate has been used to prevent seizures in preeclampsia patients. Recently, it has emerged as an anesthetic adjuvant due to its different mechanism of action. Magnesium sulfate attenuates stress response by inhibiting catecholamine release from adrenergic nerve ending and adrenal medulla. Magnesium acts as an analgesia by reducing neuronal hyperexcitability by inhibiting NMDA receptor activity. It also inhibits release of acetylcholine from presynaptic nerve terminal and enhances the effect of non-depolarizing neuromuscular blocking agent. Administration of the intravenous magnesium increases cooling rate and comfort by using a surface cooling technique by reducing the smooth muscle tone and subsequent vasodilation, leading to the reduced incidence of post-operative shivering. The primary aim of my study is to See the effect of the single bolus dose of intravenous magnesium sulfate on hemodynamic stress response to laryngoscopy and esophageal intubation and maxillofacial surgery. And secondly is to see the intraoperative analgesic and muscle relaxant requirement to study the sedation score and post-operative shivering score. This prospective randomized controlled study was conducted in the Department of Anesthesiology, MGM Medical College and MY Hospital after approval of the Institutional Research Ethical Committee. 60 patients satisfying inclusion criteria were randomly allocated by state mandate into two groups with 30 patients in each group. Group M magnesium sulfate group receiving 40 mg per kg of the intravenous magnesium sulfate in 100 ml normal saline given over 10 minutes before induction of anesthesia, and group C control group received 100 ml normal saline 10 minutes before induction. Group M were given magnesium sulfate 40 mg in 100 ml normal saline over 10 minutes. In group C were given 100 ml normal saline over 10 minutes. Baseline parameters, heart rate, systolic BP, diastolic BP, and mean AT patient were taken just before the study drug administration. All the parameters were measured after giving the study drug normal saline just before induction and 1, 3, 5, 10, 15, 30 minutes after intubation and every 15 minutes till the end of the surgery. After exhibition, patients were also observed for sedation. Their arm sedation and swollen shivering was assessed by Cochlear margin. Ischemia in grade 3 and 4 will be considered significant. In our study, we found that heart rate, systolic blood pressure, diastolic blood pressure, and mean arterial pressure were lower in the magnesium sulfate group as compared to the control group. Analgesic and muscle relaxant requirements were also less in magnesium sulfate group as compared to the control group. Post-operative shivering was less in magnesium sulfate group, and post-operative shivering and post-operative sedation were more in the control group as compared to the magnesium sulfate group. After we conducted our study, we concluded that by giving injection magnesium sulfate at the dose of 40 mg per kg, attenuating hemodynamic stress response and relaxant requirement, intraoperatively reduces post-operative shivering.
Hello. Hello, can you listen? Can you listen?
Yes, madam, you are audible.
Yes.
Hello. Yes, ma'am.
Actually, you have taken the cases of maxillofacial surgery, isn't it? So most of the times needs a fiber optic one intubation. So what was that in your group? Hello.
Ma'am, I have performed nasal intubation. Hello. Ma'am,
Yeah,
am I audible?
yeah, that is true. That is true. Nasal intubation is required, but whether that is a fiber optic, I mean awake intubation.
No, ma'am, I have not done awake
You are not
intubation.
included those patients. Difficult intubation cases.
No.
Most of the times maxillofacial surgery.
No, ma'am.
The intubation is difficult and you require the fiber optic one. Okay. So you excluded those patients which needed fiber optic, isn't it?
Yes, ma'am.
Okay.
Yes, ma'am. Yes.
So what are the other drugs which can
because ma'am, fiber optic intubation.
What? Yes, continue.
Ma'am,
What
in
you
fiber
wanted?
optic in fiber optic. Ma'am, in fiber optic intubation, the intubation duration is usually increased, and the inclusion criteria in my study is intubation duration up to 30 seconds only.
Acha. So that was a clear-cut indication. Anyway, what are the other drugs which are used to suppress the response, hypertensive response to intubation?
Ma'am, we can use
What other drugs
propofol,
have been?
fentanyl, esmolol, dexmedetomidine.
Yeah. And lignocaine has been used?
Ma'am, yes, ma'am. Yes, ma'am. Lignocaine also has been used.
So what is the dose of lignocaine
fentanyl,
which is?
esmolol.
Yeah. What is the dose of lignocaine which is used for suppression of the response, hypertensive response?
Ma'am, it is used in 2 to 5 mg per kg.
Itna? Lignocaine? No. You are totally wrong. Anyway, okay, Divya, you can continue. Hello, Divya. Hello, Divya. Divya is disconnected.
Hello.
Hello, Divya. Divya is not connected. Hello.
Ma'am, she got disconnected probably.
Yeah. Okay. So, can you connect her? Just check it.
Yeah, she's back.
No problem. We can go on.
We can go for the next.
Yeah, I'm online now, madam.
Yeah.
Yeah.
Okay, we can then go for the next.
Yes, madam.
Because,
Pradeep, you can start the next presentation. There are probably network issues on my side. I'll just check
Okay.
it in 2 minutes. Till then, we can start with the next presentation.
yes. Continue with the next.
Anal Shah, probably.
Yes, ma'am. Hello.
Yes.
Hello. Yes, ma'am.
So title of the subject is an observation study to compare the effects of intrathecal magnesium sulfate 50 mg and midazolam 2.5 mg as adjuvants to 0.5
Can you hear me, ma'am?
bupivacaine in tibia fibula surgeries. Introduction. Intrathecal blocker is preferred mode of anesthesia for lower limb orthopedic surgeries. Use of intrathecal adjuvants has gained popularity. Intrathecal magnesium sulfate produces substantial anti-nausea substance without neurotoxicity, potential analgesia of bupivacaine. Intrathecal midazolam improved the intraoperative analgesia, prolonged duration of surgery, sensory and motor blockade, along with the sparing effect on postoperative analgesic consumption. Aim of the study is to compare the efficacy of intrathecal 2.5 mg midazolam 50 mg magnesium sulfate as adjuvants to 0.5% hyperbaric bupivacaine tibia fibula surgeries. Objectives: time of onset and duration, sensory motor blockade, hemodynamic changes, sedative effects, time of two-segment regression, duration of analgesia, side effect complications. Ethical issues written from consent taken from all the patients, permission taken from ethical committee. Patients did not spend extra for the purpose of study. Statistical analysis: difference between groups in demographic data and baseline values are analyzed in unpaired t-test. P-value of less than 0.05% was considered statistically significant. Material methodology: prospective observation study was conducted in the Department of Anesthesiology, SBKS MIRC. After institutional ethical committee approval, study was conducted in 64 patients, including both genders aged between 18 to 65 years of age, and divided into equal group BMS and group BM. The group BM midazolam group received 0.5% hyperbaric bupivacaine, 3.2 ml plus 2.5 mg preservative pre-midazolam made 3.7 ml. Group BMS received 0.5% hyperbaric bupivacaine, 3.2 ml plus 50 mg magnesium sulfate made 3.7 ml. Study site at Srimati Bikesha Medical Institute and Research Center, Srimati Vidyapit, Piparia, Vagodia, Vadodara, Gujarat. Study duration 18 months. Observation study design observation double-blind study. Sample size 64. Inclusion criteria: patients willing to sign informed consent. Elective emergency studies, surgeries including patient AS grade 1-2, undergoing lower limb surgeries, 18-65 years of the age. The exclusion criteria: patient refusal, patient's height less than 152, patient with systemic disease, anemia, septicemia, and decoagulation therapy, local infection site of anesthesia, spinal deformities, and known allergy to drug. Preoperative patient was assessed for weight, height, heart rate, blood pressure, respiratory rate, temperature, and complete systemic examination. Following investigations were done: CBC, RBS, serum electrolytes, serology, ECG, and chest X-ray. All patients were kept in orally overnight. Patient's informed written consent was taken on allopathic patient. The 18 gauge IV line was secured in unaffected limb and renal activity was started. A multi-monitor monitor was attached with record heart rate, blood pressure, continuous ECG monitoring, and SpO2. All patients were pre-medicated with injection glycopyrrolate 0.2 mg, injection ondansetron 4 mg, injection pantoprazole 40 mg IV. All patients were preloaded with ringalactate before IV, before spinal anesthesia. Patients are divided into equal group, with patient sitting position. After painting draping, 23 gauge spine needle was inserted in midline LTL4 space. After pre-flow of CSF, study drug was injected over 0.2 ml per second. Following things were measured intraoperatively: heart rate, blood pressure, arterial oxygen, sensory block in their onset, duration sensory block, and level. Level was assessed using pinprick test. Motor blockade in their onset, time of onset, duration of motor block, and level of motor block assessed using modified Bromad scale. Sedation, onset and duration of sedation using Ramsey sedation scale. All hemodynamic parameters were recorded for 0 to 5 minutes, then at 10 minutes interval till 30 minutes, and then at 15 minutes till the end of surgery. Then post-operatively, every 30 minutes to rescue analgesia. Post-operatively, pain was assessed using visual analog scale, and for rescue analgesia, injection diclofenac 75 mg IV was given. Following other results, onset of sensory motor block is significantly faster with the midazolam group. On duration, sensory motor block is also longer with midazolam. Duration of post-operative analgesia is significantly longer with midazolam. Hemodynamic stability is better with magnesium sulfate. Discussion. Efficacy of spinal initiation study assessed in terms of sensory and onset and duration of sensory motor blockade. Various studies show the intrathecal mechanism of free of neurotoxicity or other adverse effects up to 2 mg dose and continuous infusion up to 6 mg. So in our study, 2.5 mg dose was being chosen as it produced faster onset of sensory motor blockade. Magnesium exerts its analgesic action as a non-competitive NMDA receptor antagonist, blocking ion channels in voltage dependent manner, offers some degree of protection against hypoxia ischemia through a combination of spinal cord vasodilation, calcium antagonism, and blockade of NMDA channels. Conclusion: intrathecal midazolam 2.5 mg and 8 to 0.5% hyperbaric bupivacaine provided faster onset of sensory motor blockade, longer duration of analgesia compared to intrathecal magnesium sulfate in patients undergoing tibial fibrosis surgeries where hemodynamic stability was better with intrathecal magnesium sulfate. Following other references. Thank you.
Hello.
Hello. Yes, ma'am.
So this was the intrathecal midazolam compared with the magnesium sulfate, isn't it?
Yes, ma'am. Yes, ma'am.
Okay. So magnesium sulfate is also preservative free?
Yes, ma'am. Preservative free magnesium sulfate. 2 ml ampule was being used, and that 50% weight by volume magnesium sulfate was there. It was prepared in such a way so that we can deliver. In my study, we have to deliver 50 mg. So it was been diluted with normal saline, and then it was mixed with intrathecal bupivacaine, and then given.
Because we have to be very particular when we give the drug intrathecally, isn't it? So we have to think about the
yes,
stability.
Yes, ma'am.
And
yes, ma'am.
Preservative free, we have to consider.
Yes, definitely.
So can you highlight the result of it? I mean, it was too fast presentation, so to assimilate.
Sorry, ma'am. Ma'am, comparing midazolam and magnesium sulfate, the time of onset for sensory and motor blockade both was significantly higher with the midazolam group, and even the duration of the blockade was also higher for midazolam. But just the hemodynamic stability which we see after the spinal, it was better in magnesium sulfate group. After spinal immediately the blood pressure and heart rate doesn't fall immediately. Stability is been maintained. So
and what about the post-operative analgesia and duration of everything?
Ma'am, post-operative analgesia and duration is better with midazolam. Rescue analgesia. Yes, ma'am. Yes, ma'am.
So what is the average duration of motor relaxation or sensory?
Ma'am, for a sensory blockade, duration is average for midazolam, ma'am, 3 hours, 3 to 3.5. And for magnesium is 2.5 to 3 hours. And ma'am, for motor blockade, it is 4 to 5 hours for midazolam and 3.5 to 4 hours for magnesium sulfate. And ma'am, post-op analgesia, in that also, ma'am, midaz is better. In that around 5 hours, like 4.5 hours is there for yes, 5 hours.
So there is a with midazolam, there is a prolongation of the sensory and motor.
Yes. Yes, ma'am.
As compared with the plain bupivacaine.
Yes,
so
plain bupivacaine.
That is by almost 2 to 3 hours on an average.
Yes. On an average.
Okay, and it is less with the
magnesium sulfate. Yes, ma'am.
And only plus point is hemodynamic stability.
Hemodynamic stability, yes.
So no patient required any vasopressor to.
No, ma'am. In the magnesium sulfate group, magnesium sulfate group, no patient required any support, any vasopressor agent. Whereas in midazolam group, it was required in few patients.
So it was a short hemodynamic stability with the.
Yes, ma'am.
So how many patients were there in each group?
Ma'am, my study total patients 64 and 32 in midazolam group and 32 in magnesium sulfate group.
Nice presentation.
Thank you.
Which class of drugs does magnesium sulfate belong to, Anand?
Ma'am, it is actually NMDA blocker. So, ma'am, it is used for basically used for seizure activities. Also, we can use in pregnancy patients. And apart from there, ma'am, it is used in to reduce the sedation. Also, it is being used also for analgesia. Magnesium sulfate is being used, and it is also calcium channel blocker. It comes in. Activity includes calcium channel.
What are the doses intrathecally magnesium sulfate can be used?
Ma'am, doses 1 to 2 mg
use
per
50
kg.
mg, right?
50 mg, yes, ma'am. 1 to 2 mg per kg. So I've used 1 mg per kg.
Okay, and you can use up to 2 mg. So you can also standardize it 100 mg.
Yes,
Very
definitely.
common side effect of magnesium sulfate when given intrathecally is also pruritus. Did any of your
Yes, ma'am,
patients have
pruritus.
pruritus?
No, ma'am. Yet, 32 patients I have studied, but
Keep it
none
in
of
your observation criteria.
Yes, ma'am. Side effects was there in observation criteria.
So did you develop any grading scale or anything for pruritus?
No, ma'am. Any grading scale I have not yet seen, but no patient developed actually pruritus. So.
Okay, what are the intrathecal adjuvants you can use?
Ma'am, magnesium sulfate, midazolam, dexmedetomidine.
Dexmedetomidine is used nowadays.
Ma'am, it is actually used. I have, yeah, it is controlled, but some yes, ma'am. Nalbuphine is used. Then, ma'am, another you can use
fentanyl.
Tramadol. Ma'am, tramadol is used. Clonidine is used. Tramadol is used.
Fentanyl is also used.
Yes, ma'am.
Yes. Okay. Ma'am, we can proceed with the next presentation.
Yes, yes, definitely.
Yeah. Okay. So thank you, Anand. Now we have Amrit Kumar, who is our next presenter.
Acha, from Patna. At last.
No,
It's
Amrit
different.
That was Amrut. Yeah, okay.
Amrut.
Yes, Madam Patna, the one who has been calling.
Okay. He was very
My title
frantic.
is Study on Efficacy and Safety of Intravenous Lignocaine for Post-Operative Analgesia and Recovery After Surgery. Author Dr. Amrit Kumar, co-author Dr. Professor Vinod Kumar Verma, IGMS Patna, co-guide Dr. Mumtaz Hussain, additional professor, IGMS Patna. Introduction: Intravenous lignocaine infusion increasingly used to provide perioperative analgesia in clinical practice. Anti-nociceptive, anti-hyperalgesia, and anti-inflammatory action. It is presumably this action rather than a direct local anesthetic effect, which explains the apparent prolonged effects hour after an infusion has been completed. Aims and objective. The study aims to assess the effectiveness of perioperative intravenous lignocaine infusion on post-operative pain intensity and analgesic requirement. Material method: inclusion criteria: patient of ASA physical status 1 and 2, age between 18 to 16 years, of either sex, willing to participate, undergo elective surgery. Exclusion criteria: refusal to participate, known hypersensitivity to lignocaine, in whom lignocaine is contraindicated. A standard monitoring attest and IV line secure IV lignocaine group 1.5 milligram per kg given bolus over 10 minutes, 30 minutes before the skin incision, and followed by continuous IV infusion at the rate of 1.5 milligram per kg per hour via infusion pump. In saline group, 0.9% normal saline in equal volume and it's a minute. The infusion was continued throughout the surgery and terminated 60 minutes after the skin closure. In all patients, anesthesia was induced with a standard technique and orotracheal intubation done. After intubation, anesthesia was maintained with isopropyl oxygen with intermittent IV bolus of beclonium 1 milligram agitated. In all patients, pain was assessed on the basis of visual analog score. Result: in 100 patients, 92 were female and 8 were male. In all 92 patients undergo the open cholecystectomy and 7 underwent for open cholecystectomy with CVD exploitation and 1 for exploratory laparotomy. Comparison of general characteristic of the study population. Both the group is given in table first. No statistical difference were observed. However, the time of extubation was longer in lignocaine group, 14 minutes, than in normal saline group, 6 minutes. Intensity of pain in PAC with the mean pain VASA score in lignocaine group retained significantly less in normal saline group until 30 minutes, but in higher at 60 minutes. The mean pain VASA score at rest, as shown in the figure first, a similar value of on movement also on the figure 2. Mean VASA score in both the group were less in the lignocaine group than in normal saline group, with exception at 45 minutes and 1 hour after surgery. Okay, this is the table first. This show the comparison of mean VASA score at rest, and this show the comparison of VASA score on movement. And analgesic requirement. The mean time for the first dose of analgesic was significantly longer in lignocaine group, 60 minutes, than in normal saline groups, 15 minutes. The total mean analgesic diclofenac requirement in lignocaine group 142 milligram and significantly less than in normal saline group 185 minutes. Nausea and vomiting was observed in 11% in lignocaine group, 8% in normal saline group. Light headache was reported by 3 patients. In lignocaine group. Discussion: our study saw significantly less total post-operative analgesic requirement in lignocaine group than in normal saline group. In our study, all the procedures were major upper abdominal surgery, and we did not use any additional regional anesthesia for pain relief. Coparts et al. And Grudin et al. Done similar experiment and found a prolonged PACU stay, which leads to the use of IV lignocaine impractical and more expensive. Conclusion, it can be concluded that the perioperative infusion of non-toxic dose of lignocaine decrease the intensity of post-operative pain, reduce the post-operative analgesia requirement, and blur the hemodynamic response during laryngoscopy and endotracheal intubation without causing significant adverse effect. Therefore, it can be considered as an inexpensive, as a relatively safe and effective modality as a part of multimodal approach for post-operative analgesia undergo the upper abdominal surgery. References are these. Thank you.
Okay. So you have used intravenous lignocaine in the dose of how much you used? Hello, Amrit. Hello.
Amrit, are you audible? Amrit Kumar.
Ma'am, I think he is not joined yet.
Yeah, we have just sent the presentation.
Yes, I called him and he said that he will be joining soon.
Okay.
Then we'll go for the next.
Is it possible that we can ask him questions later and we can proceed with the next presentation if Madam is fine?
Yes, ma'am.
Yes.
Madam, we
We'll
could go like
proceed
that?
with.
Yeah. So our next presenter is Amulya.
Okay.
Today I'll be presenting a paper titled Comparative Evaluation of Two Different Doses of Intravenous Dexmedetomidine Infusion for Sedation Patients Undergoing Lower Abdomen General Surgical Procedures Under Spinal Anesthesia. Coming to the introduction, subarachnoid block is a widely used regional anesthetic technique, particularly advantageous for lower abdomen surgeries, have failed due to inadequate intravenous sedation and anxiolysis more than due to technically faulty block. Adequate sedation is therefore important if the benefits of spinal anesthesia had to be fully realized. The aim of the study was to evaluate the appropriate dose of intravenous dexmedetomidine infusion for sedation, to evaluate the drug effects on hemodynamic parameters and any side effects. A prospective randomized controlled double-blinded study was done from July 2021 to September 2021 in Saptagiri Institute of Medical Sciences and Research Center. Sample size calculation was done based on previous study and the above-mentioned formula. 25 patients were allocated into group A, B, and C. ASA physical status 1 and 2, aged 18 to 16 years, were included in the study. Patients undergoing laparoscopic surgeries, having heart failure, renal failure, on calcium channel blockers and beta blockers who refused to give consent were excluded from the study. The study included 75 patients. Randomization was done using simple random sampling method and concealment by sealed opaque envelope method performed by an anesthesiologist involved in the study. The study participants were allocated to either group A to receive a maintenance infusion of dexmedetomidine at 0.2 microgram per kg per hour. Group B received an infusion of at 0.4 microgram per kg per hour. Group C received normal saline infusion throughout the surgical procedure. Procedure and recording were performed by another investigator who was unaware of the group allocation, thus ensuring double blinding. Written informed consent was obtained from all the participants considered for the study. The patients were preloaded with 15 ml per kg of ringer lactate. A loading dose of 0.5 microgram per kg of dexmedetomidine was administered to all the study participants over 10 minutes duration. In the preoperative room, on the operation table, multi-para monitors were connected and baseline parameters recorded. The SAB was administered at L3, L4 interspace. 0.3 ml of 0.5% hyperbaric bupivacaine was administered intrathecally. Immediately after positioning, the study participants were given the study drug. Intraoperative maintenance of intravenous administration of all groups was discontinued as soon as the surgeon began suturing the skin. The time at which the SAB was administered was regarded as time zero. Hemodynamic parameters were determined both intra and post-operatively. The degree of sedation was assessed with Ramsay sedation score at an interval of 15 minutes both intra and post-operatively. The time for the first request for analgesia was considered to be duration of analgesia and was noted. A descriptive statistical analysis was carried out. Chi-square test and Fisher's exact t-test, paired t-test and student t-test were used for the analysis. All 75 patients enrolled in the study have completed the study protocol. There is no spinal anesthesia failure. The Ramsay sedation score was significantly higher in dexmedetomidine group than in control group. In our study, there was no significant difference in respiratory rate between the groups during surgery and a post-operative period. The time until the first request for post-operative analgesia was significantly longer in dexmedetomidine group compared to control group. The mean intraoperative heart rate is significantly lower in dexmedetomidine group compared to control group. The intraoperative and postoperative mean arterial and diastolic blood pressure values in dexmedetomidine group are significantly lower compared to the control group. In our study, there is lower incidence of postoperative shivering and postoperative nausea and vomiting in dexmedetomidine group. In our study, the maximum mean sedation score was reached 30 minutes after start of the dexmedetomidine infusion, which is similar to previous studies.
In our study, the incidence of bradycardia was transient and respond well to atropine. The changes in blood pressure had no significant clinical effects, and hypotension could be easily treated with a bolus of IV fluids and ephedrine. There was no significant difference in the need for ephedrine between the group as compared to previous literature. We conclude that a loading intravenous dose of dexmedetomidine 0.5 microgram per kg followed by continuous administration at an infusion rate of 0.4 microgram per kg per hour may be an appropriate dose to ensure adequate sedation, reducing the risk of hemodynamic instability. It also has the added benefits of extending postoperative analgesia, preventing postoperative shivering and postoperative nausea and vomiting. Thank you.
Hello.
Hello. Good morning, ma'am.
So this is a study regarding giving a dexmedetomidine.
Yes, ma'am.
In a loading as well as a continuous
infusion. Yes,
to
ma'am.
have a hemodynamic stability, isn't it?
Yes, ma'am. Yes, ma'am.
And the added advantages were?
The added advantages were we could extend the postoperative analgesia was also extended, and postoperative nausea and vomiting were prevented, ma'am, with this loading dose and maintenance infusion, ma'am.
And shivering also.
Postoperative shivering also, ma'am.
So you have studied all these separately, I mean, compared with the...
yes, ma'am. Yes, ma'am.
So what was the incidence of shivering in control and this, I mean, how far it is controlled?
Ma'am, with dexmedetomidine group of who are receiving 0.5 microgram per kg per hour, they had a lesser incidence of postoperative shivering when compared to a dexmedetomidine group who received 0.2 microgram per kg per hour. When compared to normal saline group, ma'am.
Okay. So nice one. I mean, most of the times dexmedetomidine is given intraoperatively.
Yes,
so it's quite a common topic. Nice presentation. Okay.
Thank you,
ma'am. Nice presentation. Madam, can we proceed with the next one?
Yes, yes.
Yeah. Our next participant is Anamitra. 1 second. We have Amrit Kumar with us. Is he online? I probably saw him in one of our boxes.
Yes, ma'am. He's online. He's online.
Yeah, so we'll finish with him first. Yeah. Is it fine with you, Pradeep?
Yes, ma'am. Fine.
Yeah. Yeah. Amrit?
Hello.
Amrit, are you audible? Are we audible to you? Okay, he's probably gone again. No problem. We will start with Anamitra Podar, our presenter. Thank you.
Hello, myself Dr. Anamitra Poddar, resident of Department of Anesthesiology from Bankura Sammelani Medical College and Hospital of West Bengal. My topic is comparison of efficacy of dexmedetomidine and sevoflurane on the hemodynamic parameters in patient undergoing laparoscopic cholecystectomy. Laparoscopic cholecystectomy is a daycare planned surgery involving suppression of carbon dioxide into the peritoneal cavity. Despite many benefits, these surgeries are challenging from anesthesiologist's perspective. The aims and objective of our study is to compare the hemodynamic alterations between the two groups of patients who receive dexmedetomidine and sevoflurane. Our aim is also to compare ETCO2 between the two groups of patients. In our study, 20 to 50 years of age 6 match, ASA grade 1, grade 2 patients were included who are scheduled for elective laparoscopic cholecystectomy. Annually, patient with comorbidity with anticipated difficult intubation with known allergy to study drug, pregnant lactating mother are excluded from the study. Committee, our prospective randomized study was taken place in the Department of Anesthesiology BCMCH, where group D patient received IV dexmedetomidine and group B patient received inhalational sevoflurane. Data tabulation done by Microsoft Excel and SPSS version 22 done statistical analysis. P-value less than equals to 0.05 considered as significant. In our procedure, after getting consent, patients were shifted to operative room and IV lines secured. After induction intubation, maintenance of anesthesia by IV dexmedetomidine or inhalation of sevoflurane, along with nitrous oxide injection atracurium. Hemodynamic alteration in ETCO2 were compared during pneumoperitoneum at the time of extubation. Study drug was off at the removal of the shocker. This is the dexmedetomidine ampoule we used in our study. This is the infusion pump and insulin syringe for draw dexmed. This is the sevoflurane vaporizer. This is the table and line diagram showing heart rate, SBB, and map between the two groups. which showed statistically insignificant value. Only in case of ETCO2, dexmedetomidine maintains a higher range, but this is the normal value with fixed respiratory rate in a circle absorber with closed circuit. This study showed that both the treatment groups D and S did not differ statistically in hemodynamic parameters in SBP, DBP, heart rate, and MAP due to pneumoperitoneum. Ayman A. Mohammaditan concluded that TIVA with dexmed provided hemodynamic stability. These results are according to our study. Subramaniam Harirao et al. In 2012 analyzed the effect of dexmed on hemodynamic stability in the intraoperative. B.L. Scott Warren et al. In 2015 showed use of dexmed in anesthetic practice the maintenance infusion. All these results are according to our study in controlling hemodynamic response. Seri Babdo et al. Concluded that TIVA with propofol and with dexmed are more effective and favorable than inhalational sevoflurane. Vandenberg et al. In 2005 investigated the choice between inhaled or IV induction of anesthesia. How et al. Studied the usefulness of IV dexmed infusion for maintenance of anesthesia and diminishes the isoflurane requirement by more than 90%. So from the study, we came to the conclusion that either IV dexmed alpha-2 adrenergic agonist or inhalational sevoflurane in laparoscopic surgery can be used for controlling hemodynamic stress response. Dexmed is an easily available and cost-effective drug and it does not cause devolution like the sevoflurane. Limitation of a study that BIS monitoring was not done. This is single center BIS study. This is the reference of a study. Thank you.
Hello. There is a constant disturbance at the background. Hello, throughout the presentation also. Hello.
Hello, ma'am.
There is a constant disturbance at the background just now. So the technical team. Good morning. Yes. But
Hello,
then
ma'am.
I am listening to the another disturbance constantly. Maybe that this is some technical error. Hello, Divya.
No, ma'am, it's not technical error. Some Dr. Abdul Latif is there. Maybe background noise is coming.
Can it be muted, because throughout the presentation I could listen to the sound.
Yeah, now it is better, madam.
Yeah.
Yes.
So, hello. So
Yes,
in your
madam.
presentation, it was actually dexmedetomidine, no, and compared with the sevoflurane. So in the group in which you are given dexmedetomidine, the sevoflurane, the volatile anesthetic agent used was isoflurane. That is what I think. Hello, the present sevoflurane along with the dexmedetomidine.
Yes. Right, Amrita?
Where is she?
She's gone. 1 second. Pradeep, can you get her online for us, please? Anamitra, you can hear us? 1 second, I'll just check. Yeah, she's mute. Anamitra, you need to unmute yourself. Probably that is the reason we can't hear you.
Yes, ma'am. Yes, ma'am. I can hear you.
Now you're better. Yes. Madam,
Hello. Anmitra. So in your study, you compared the dexmedetomidine.
Good morning, ma'am.
Good morning. In your study, can you listen to me? Am I audible?
Yes, ma'am. Yes, ma'am. I can hear you.
Yes,
Dexmedetomidine group.
Except for Anamitra, everybody needs to unmute themselves, please. To mute themselves, sorry. Yes, thank you. Yes, madam, now it is better.
So in the dexmedetomidine group, so what is the volatile agent that was used for anesthesia? Hello.
Anamitra, you unmute yourself. We can't hear you. Yes, now you can.
I unmute myself.
Yes.
Ma'am, no inhalation agent was used, ma'am, during dexmedetomidine group. Only anesthesia was maintained for dexmedetomidine, nitrous oxide, and injection atracurium.
And atracurium. So no volatile was given in dexmedetomidine group.
Hello, ma'am.
Okay.
Can you hear me?
Yes. So no inhalational was given in the dexmedetomidine group. Okay. So this is purely volatile against intravenous comparison. So which was the better? Hello, Anmitra.
during hemodynamic. Hello, ma'am.
हाँ,
Yes, ma'am.
बोलो बोलो.
Yes, ma'am.
हाँ.
Can you
So
hear me,
what
ma'am?
is your conclusion?
Ma'am, hemodynamic alterations. Ma'am, we can use dexmedetomidine as an alternative to sevoflurane because it does not cause OT pollution and it is easily available because there is no hemodynamic alterations between the two groups. The only ETCO2 was in a higher range in dexmed group, but it's in a lower range with a circle absorber closer to.
Okay.
So, ma'am, from conclusion, we can easily use dexmed as an intravenous
Dexmedetomidine.
anesthesia.
What is the side effects of this group, dexmedetomidine? Any adverse effect of this infusion? Adverse effect in the dexmedetomidine group, there is a lot of disturbance.
Sometimes during the OT, yes, ma'am. Sometimes in the OT, we notice bradycardia, and for sometimes we switch off the dexmed, and then we also switch on the dexmed on.
Okay, okay. And hypotension as compared to the other group, incidence of hypotension.
Hypotension also, ma'am. I have noticed, ma'am.
So you have to control.
Yes, ma'am. Hypotension also there, and hypertension also I have noticed.
So you have to
Yes,
control
ma'am.
it
During the
by
hypotension, we give mefentormin, 6 mg.
Discontinued infusion.
No, ma'am. I have to control it by giving mefentormin 6 mg IV bolus. Discontinue infusion, ma'am. Sometimes I discontinue infusion. Sometimes I gave them mefentormin 6 mg IV bolus.
Okay.
But ma'am, not so much hypotension, not so much hypertension, because I also
Which
switched on
needed.
the dexmed infusion and it continued, ma'am.
Okay.
Yes, ma'am.
All right. All right. Nice one.
Anamitra, there is a dexmedetomidine is usually given over 10 minutes or over 20 minutes as per the prescribed guidelines is an infusion. So there is rebound hypertension, if you're aware of it, the side effect. That would be greater in
that
which?
Is, 0.5 microgram per kg.
No, that would be higher in which
sorry, ma'am,
group of? You get what I'm asking you?
What, ma'am? What was that?
Okay, I'll tell it to you. When given over a prolonged period of time, there is less side effect of rebound hypertension, which is a common manifestation of dexmedetomidine, which affects the hemodynamic stability also and might lead to misinterpretation in your observations also. Okay. And moreover, you can always give a glycopyrrolate in a pre-medication to avoid your bradycardia as a prophylactic measure whenever you're dealing with dexmedetomidine, unless until it is not a contraindication, which is very rare. Okay. So these two things will help you to give a non-biased result.
Ma'am, I have mentioned it in my slide.
Yes, okay, okay.
Okay, sorry.
I have
then
given injection glycopyrrolate, ma'am. I have mentioned it in my slide.
Okay.
And ma'am,
I
have given
that you have given in all cases, right, as a baseline. Okay.
Okay. Yes, so ma'am. I have given all cases as baseline for glycopyrrolate.
Okay. So my next and final participant would be Anurit Kaur.
Hello.
Yes, yes. Good morning, Anurit. Good afternoon, actually. Pradeep, can we have a presentation, please?
Yes, 20 minutes for afternoon.
A comparative study of motor scissor duration, hemodynamic effects, and recovery pattern of etomidate and ketofol in modified electroconvulsive therapy. Introduction. Modified electroconvulsive therapy is a widely used and safe evidence-based intervention in modern psychiatry as a treatment for a variety of psychiatric disorders in which scissors are electrically induced in anesthetized patients for therapeutic effects. It is used primarily in severe illnesses when there is an urgent need for treatment or secondarily after failure or intolerance to pharmacotherapy. Various anesthetic agents used for induction in electroconvulsive therapy are methotrexate, thiopentone, sodium, ketamine, propofol, and etomidate. Propofol has been reported to be associated with favorable recovery pattern, but there has been concerns that it is associated with shorter scissor duration because of its strong anticonvulsive properties and may compromise ECT efficacy. Ketamine lacks anticonvulsive properties, but ketamine has been a less preferred
anesthetic agent because of concerns about the risk of excessive cardiovascular system response, elevated intracranial pressure, and untoward psychological reactions. Etomidate causes a decrease in the cerebral metabolic rate, cerebral blood flow, and intracranial pressure. It has been suggested in the past that etomidate has neuroprotective properties also. So the choice of induction agent may influence the recovery parameters, hemodynamic parameters, scissor activity, cognitive functions, and cost effectiveness of the procedure. Given this regard, the present study aims to compare the effects of etomidate and ketofol in view of motor scissor duration, hemodynamic effects, and recovery pattern in modified ECT. The aims and objectives are to study the effect of ketofol and etomidate in terms of induction time, motor scissor duration, hemodynamic parameters, recovery time, and adverse effects, and comparison of the two. The materials and methods. A comparative study was done in the Department of Anesthesiology, GGS Medical College, Faridkot. 80 patients were taken. They were divided into two groups of 40 each. And group A patients were given ketofol in the dose of 2 mg per kg as IV induction agent. Group B patients were given etomidate in the dose of 0.2 mg per kg as IV induction agent. After proper PAC, patients were taken in the OT. After starting the IV line, the patients were given the pre-medication in the form of glycopyrrolate, MSET, and injection fentanyl. Then the patients were pre-oxygenated, and then the general anesthesia was given with the IV anesthetic agent as per the group allocated. Then ECT was given to the patient, and after that, the patient was put on bag and mask ventilation till the patient regained consciousness. And the results which were seen were that the induction time was shorter in group ketofol as compared to the etomidate group, and the motor scissor duration was significantly longer in the etomidate group as compared to the ketofol group. So from the current study, we conclude that there are individual advantages of the two induction agents. Ketofol has the advantage of having shorter induction recovery as compared to etomidate. So ketofol can be especially useful in elderly patients since it provides a more rapid recovery of cognitive function. Etomidate has the advantage of a longer scissor duration and stable hemodynamics. It may be indicated when scissors are too short and possibly subtherapeutic despite maximum stimuli. It can be a useful alternative in patients achieving suboptimal therapeutic responses to ECT. Thank you.
Some new topics out of all now.
Yes,
After a long duration, ECT is not frequently covered. So this is comparison between ketofol and etomidate. Okay.
Yes, ma'am.
So what was the advantages of the ketofol? You said ketofol.
Ketofol had the patients who were given ketofol, there was rapid induction, and ma'am, there was rapid recovery in case of patients who were given ketofol.
And with the etomidate, the recovery was little prolonged, isn't it?
Yes, ma'am. Comparatively, in comparison to the ketofol group, with etomidate, the induction was prolonged and the recovery was also prolonged.
And what about the convulsive effect?
Sorry, ma'am.
For the
anticonvulsant effect.
Anticonvulsant.
Yes, ma'am. Anticonvulsant effect was, ma'am, it was statistically there was no big difference among both the groups.
Yes. Okay. Nice presentation. Something different. Oh.
Anirudh, I would like to ask you one question in general. When etomidate is used as an induction agent, it is primarily indicated in one of the cases, and there is one significant side effect for the same. Etomidate as a newer agent. Can you please explain me? Both of them would be single answers.
Ma'am, can you please repeat the question, ma'am?
My question is, etomidate is a newer induction agent which is used nowadays. There is one class of patients where we close your eyes and say use etomidate. Which class of patients is that?
Cardiovascular patients, ma'am.
Okay.
Patients who
And what is the main side effect of etomidate?
Ma'am, adrenal
which many
suppression.
researches are published.
adrenal suppression it can cause myoclonus also, ma'am.
Yes. Okay. 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 And we also used thiopentone earlier, also was used in ECT.
Yes, ma'am.
Significant anticonvulsant action, no effect on EEG of the brains or any interactions. Okay. It was a good presentation on a different one, only one which we had in ECT. Thank you. We have Dr. Amrit from Patna.
Thank you so much, ma'am.
Yes, ma'am.
His presentation was played earlier. Amrit, please can you repeat the title of your study?
Yes, ma'am. Ma'am, my title is a study on efficacy and safety of intravenous lignocaine for post-operative analgesia and recovery after surgery.
Okay. Over to you, madam. If you could.
So that is the intravenous lignocaine.
Yes, ma'am. Yes, ma'am.
It is given at what time?
Yes, ma'am. Before skin incision, 30 minutes, 1.5 milligram per kg, loading dose over 10 minutes, then 1.5 milligram per kg per hour infusion after the 1 hour after the skin closure. स्किन इंसिजन के 30 मिनट पहले से लेके स्किन क्लोजर के 1 घंटा बाद तक मैम चलाएंगे मैम पोस्ट ऑप में.
अच्छा, पोस्ट ऑप एनालिसिस.
Yes, ma'am. Post op.
What is the infusion rate?
Infusion rate mean 1.5 milligram per kg per hour.
Per hour. So what are the side effects you observed in this? Any adverse effect?
पोस्ट ऑप मैम पेशेंट मैम सेडेटेड मैम ज्यादा देर तक रहा था मैम और एक्सट्यूबेशन टाइम मैम प्रोलॉन्ग हो गया था और एस मैम नोजिया एंड वोमिटिंग आल्सो ऑब्जर्व in 11 patient मैम टोटल. और
post-operative nausea and vomiting.
Nausea and vomiting, ma'am. Yes, ma'am. 11 patient, ma'am.
Madam, you need to unmute yourself. Probably by mistake it has gone mute.
Hello.
Yes, Amrit.
Yes.
So you have blinded your study?
Yes, ma'am.
What blinding you have done?
Double blind, ma'am.
How have you double blinded it?
Double blind, ma'am. Subject or investigator both not known.
Okay, madam is back. Yes, madam.
Yes, yes.
Nothing I want to say. Anyway, all right. Presentation is all right.
Thank you.
So the blinding portion needs to be more clarified, and you should know the difference whenever you are doing it with drugs in your study. Okay.
No, ma'am. Message no.
Yeah. Okay. This was our last participant. I would like to thank Vijayante madam for taking out her precious time at end moment. There was some miscommunication or thing. Thank you, madam, so much. Thanks to all participants, and thanks to Pradeep for the IT team. It was unexpectedly virtual, but yes, an interactive session. Had not expected, frankly, that it would be such interactive and convenient to handle on a first platform on day one. We would like to thank Isacon organizing committee, Dr. Ashish Jivan, Dr. Hina Chanwal, the organizing scientific entire team. And madam, if you wanted to conclude with anything, all participants, your topics are very of different variety. Yes, we dealt a lot with dexmedetomidine and probably devised all of us in various routes today. And we learned many innovative things also for the LMA insertions, for new drugs and everything. So everybody, it was a much diversified as compared to the expected session. Madam, now if you would like to say anything.
Actually, there was a short notice for this, so it was not possible for me to join earlier. But anyway, I can understand the load and I mean a lot of entries and management of it. It must be a difficult task. So nice to participate in this way, and to thank you everybody for all this nice session. And I would like to have a certificate regarding participating as a chairperson on email.
Yes,
and
madam. Whenever I will get through it, I will also make it sure that it goes to you too.
Yes, yes. You are actually Divya, you are from?
Madam, I'm assistant professor at GCS Medical College, Ahmedabad, Gujarat.
Acha, you are from the team only. You
Yes,
are
ma'am.
from this organizing team. Organizing
Yes,
team.
ma'am. Madam. I'm trying. We are trying to help them, but they have been more active throughout. So.
Okay.
Yes, madam. Thank you
nice
so much.
To meet
Thank
you.
you.
And we had
Yes,
a nice
madam.
session.
Same here. You'll be coming to the conference.
Yeah. No, not actually.
Okay, madam. Okay.
So I
Thank
would
you,
like
everybody.
to have from the invitation as a chairperson as well as the participation.
Yeah, madam. I'll convey it to my team.
Yes.
Thank you, Pradeep. And sorry for the delay in completion. Thank you for being on toes.
Okay, ma'am. Thank you.
Excuse me, ma'am.
Thank you. Yes.
Ma'am, my presentation has not been done, ma'am, yet.
You probably might not be in the session. You can ask Pradeep or anybody, because whatever list we have got it, we have gone through thoroughly.
Yeah, we are actually a bit delayed. So the 11th session is not started yet.
Okay. Sorry. Please, we'll leave the session. Yeah.
Okay, ma'am. Okay, ma'am.
Okay.
Yeah,
Thank you, Pradeep.
Thank you,
welcome.
everyone. Bye.
Yeah, thank you.
Hello. Hello.
Yes, please wait.
Actually, my video has not been played ना, तो मेरा session था अभी, तो उसके regarding पूछना था मेरे को.
Yes, your session will be from now onward for the 11 to 1 session. Okay.
Oh, thank
Please
you.
be on this link only. Thank you.
Okay. वो बोलते हैं आपका नेक्स्ट सेक्शन में बोल रहे हैं। हाँ। हाँ रीमा जी, मैं कह रही तैयारी वाली सब हो जाएगी, उसकी कोई टेंशन नहीं है। आप दोनों आके आ जाके बस थोड़ा सा आ जाए। हाँ
Yeah, hello, Dr. Prashant. You can start. Or else we can present the e-paper and followed by the QA by you. Am I audible? Dr. Prashant, you are not audible. You need to unmute yourself.
Now?
Yeah, you are audible, but you need to rotate your screen. Yes. Okay.
Good morning, everyone. So myself, Dr. Prashant, HOD of Anesthesia from Srinivas Medical College. We can start with the first presenter. Hello.
Okay, sir.
Yeah. Yeah, please go ahead.
Yeah, please share the Anusha slide first.
Yeah.
With desflurane combined with esmolol or dexmedetomidine during mastoidectomy in adults. Middle ear is a closed air-filled cavity between tympanic membrane and oval window. Surgeries done under operating microscope need bloodless field for better visualization of important structures to avoid complications. Anesthesiologists have devised various techniques to prevent this bleeding, of which induced hypotension has stood the test of time. The aim of this study was to compare the effects of desflurane combined with esmolol on dexmedetomidine during mastoidectomy under general anesthesia to provide bloodless surgical field, and the primary objective of this study was to compare the effects on the amount of blood in the surgical field, recovery time, and tolerability in adult patients undergoing mastoidectomy. This clinical study was conducted in the Department of Anesthesiology, Tanjore Medical College, in association with Department of Otorhinolaryngology during the period 2019 to 20. Clearance was obtained from Hospital Ethical Committee. Inclusion criteria were age 18 to 60 years of either sex, ASA class 1 and 2, patients posted for mastoidectomy. Exclusion criteria were patients with significant dysrhythmias, ASA class more than 2, uncontrolled hypertension, cardiovascular, cerebrovascular disease, and bleeding disorder. A total of 52 patients were needed to get enrolled. Before induction of anesthesia, baseline measurements of heart rate, blood pressure, mean arterial pressure, and saturation were made. After intubation, esmolol infusion was initiated at a rate of 1 mg per kg as loading dose over 1 minute, followed by a maintenance infusion rate of 0.4 to 0.8 mg per kg per hour to achieve controlled hypotension in Group E. In Group D, a loading dose of dexmedetomidine was infused intravenously over 10 minutes at 1 microgram per kg, followed by a maintenance infusion rate of 0.4 to 0.8 microgram per kg per hour. And the infusion rates were then titrated to maintain mean arterial pressure between 65 to 75 mmHg. General anesthesia was maintained with desflurane at 4 to 6%. In both the group, signs of inadequate anesthesia or somatic responses were treated with additional titrated doses of fentanyl. Parameters analyzed were amount of bleeding in the operative field, time taken for total recovery from anesthesia using modified Aldrich score, sedation scores at 15, 30, and 60 minutes after extubation, and intraoperative fentanyl consumption. Statistical analysis were made using independent sample t-test, chi-square, and Fisher-Exact test. P-value of less than 0.05 was considered as statistically significant. There was no significant difference in demographic parameters between the groups in our study. There was no statistical significant difference between heart rate in both the groups till 40 minutes of surgery. Thereafter, the heart rate was comparatively lower in esmolol group. And systolic, diastolic, and mean arterial blood pressure were more or less similar in both the groups during the initial 15 minutes. Thereafter, all the three measurements were lower in dexmedetomidine group. Almost all the patients in both the groups had a 6-point bleeding scale of less than or equal to 2, which was statistically not significant. The additional fentanyl consumption was higher in esmolol group. At 15 minutes, all the study population in Group E had an Aldrich score of 10, while only 69% of the patients in Group D had an Aldrich score of 10, and the results were statistically significant. Sedation score at 15, 30, and 60 minutes were higher in dexmedetomidine group. These results were comparable to a study by Shamsky et al. And Cole et al., which showed significant difference in heart rate, and the need for additional hypotensive agents like intravenous fentanyl, NTG, and inhalational agents were higher in esmolol, and the 6-point scale values were comparable in both the groups. And the time to achieve Aldrich score of more than 9 was longer in dexmedetomidine group. Sedation scores were higher in dexmedetomidine group. And we have concluded that dexmedetomidine or esmolol combined with desflurane provided an equally effective method for achieving controlled hypotension during mastoidectomy. These are my references. Thank you.
Good morning, sir.
Good morning. What are exclusion criteria used?
Sir, ASA class more than 2, sir, and the patients with cerebrovascular and cardiovascular diseases, sir, and the patients with uncontrolled hypertension, sir. And age is only 18 to 60 years of age, sir.
So the one drug category is basically it increases the depth of anesthesia, isn't it? Like dexmedetomidine.
Yes, sir. Yes, sir.
The other one is a beta blocker, isn't it?
Yes, sir.
It's got
Yes,
nothing
sir.
to do with the depth of anesthesia.
Yeah, sir.
So you maintain. Did you monitor ETCOT?
Yeah, sir. It is kept in the range of 30 to 35 mmHg, sir, throughout the surgery.
So basically, bleeding depends upon the hemodynamics and these things.
Yes, sir.
Isn't it?
Yes, sir.
So that will maintain normal, isn't it? I mean, like same in both.
Yeah, sir. More or less equal hemodynamics, sir. But mean arterial pressure is achieved early with dexmedetomidine, sir, compared to esmolol, sir. It took around 15 minutes, sir, in dexmed group, and in esmolol group, it took around 35 minutes, sir, to achieve that map. We kept in a study at 65 to 75 mmHg, sir. After that, it was maintained, sir, with a minimum difference of 3 to 6 mmHg, sir, with difference in both the groups, sir, with the lower values in dexmedetomidine groups, sir.
They're basically SA1 and 2 patients, isn't it?
Yeah, sir.
So what is the recommendation for hypotensive anesthesia in this group? How much you can reduce? Basically,
sir,
if you keep MAP at 75, it is almost normal. They will bleed like normal.
We can reduce up to 50 mmHg of MAP, sir. 50 to 65, sir. Or 30%
keep around 75,
reduction from baseline, sir.
Yeah. According to Miller, if you keep diastolic, say pre-op diastolic, you keep whatever the pre-op diastolic, you keep that systolic intra-op, okay, for A1 and 2 patients.
Yes.
That should be your target. Okay.
Yes, sir. Okay, sir.
Okay, right. Okay. Thank you. Any other questions from other moderators? Good presentation.
Okay, thank you, sir.
Thank you.
Yeah, next slide, please.
Yeah, next person, please.
My topic, a comparative study between dexmedetomidine propofol versus fentanyl propofol for LMA insertion. LMA is a supraglottic airway device which allows both spontaneous as well as positive pressure ventilation. It's easy to use, quick to place, and also a good alternative to bag mask ventilation. It results in less gastric distension and also reduces the risk of aspiration. And intravenous agents like propofol are commonly used, which have a short duration of action and also adequate suppression of laryngeal and pharyngeal reflexes, but it can cause a dose-dependent cardiorespiratory depression. To prevent this, adjuvants such as opioids, benzodiazepines have also been used to improve the insertion conditions of LMA with less dose of propofol. Fentanyl is a potent opioid receptor agonist, but it has side effects such as respiratory depression and may potentiate hypotension caused by propofol. Dexmedetomidine, on the other hand, is a centrally acting alpha-2 adrenoceptor agonist that has sedative and analgesic properties. It is devoid of respiratory depressant effects. It also reduces the induction and maintenance dose of propofol. These are my review of literature. And the aim of the study is to compare the respiratory and hemodynamic effects of IV dexmedetomidine versus IV fentanyl with propofol co-induction for classic LMA insertion for short surgical procedures under GA. And the primary objective was to compare and evaluate the hemodynamic and respiratory effects in the two groups by comparing the heart rate, non-invasive blood pressure, oxygen saturation, Young's criteria of jaw relaxation, modified scheme of Lund and Stagner grading of LMA insertion conditions. The secondary objective is to know the total dose of propofol in both the groups. And this study was conducted in MedCity. The study design is a prospective randomized comparative study. We've included 60 patients of both the genders of ASA grade 1 and 2 of between 18 to 60 years of age, posted for short surgical procedures under GA. And this is the inclusion criteria. Exclusion criteria. We've excluded patients not giving consent, those with neck and facial burns, and those with restricted mouth opening, and those on beta blockers, and also those with known egg allergies. In methodology, after written informed consent, Group D and Group F have been divided into 30 patients each using a random number table. The baseline heart rate, mean arterial pressure, oxygen saturation, and respiratory rate were recorded for all the patients. And group F received injection fentanyl 1 microgram per kg IV in 10 ml normal saline over 10 minutes. Group D received injection dexmedetomidine IV 1 microgram per kg in 10 ml normal saline over 10 minutes. And propofol and nitrous oxide is to oxygen and sevoflurane were used commonly for all. And lungs criteria, like I said, what is used? Jaw relaxation. Lungs criteria. More patients in fentanyl group, 25 patients had lungs criteria of grade 1 compared to dexmed, that is 14 patients. Grade 2 relaxation was seen in 5 patients in fentanyl group and 16 patients in dexmedetomidine group, respectively. There is a significantly better jaw relaxation in fentanyl group compared to dexmed group. This is the graphical representation for the same. In modified scheme of London-Stubner, more patients in fentanyl group had excellent ileemic insertion conditions and 25 patients and as compared to dexmed group. And good conditions for ileemic insertion were observed in group F and group D more than group F. It's an actual representation for the same. And the heart rate, there was a significant decrease in heart rate in both the groups, but more in group D. Systolic blood pressure and systolic blood pressure, actually there was a significant decrease in systolic BP in group F after 10 minutes of induction. And diastolic blood pressure and mean arterial pressure, there was no significant difference in both the groups. So peripheral saturation of oxygen was also measured. It was not significantly different in both the groups. In dose of propofol, 79.5 milligrams of propofol was required in group D, whereas in group F, it was only 98 milligrams. Complications observed, such as oral cavity injuries and bradycardia, hypotension, desaturation, were all noted. And coming to the summary, the hemodynamic profile of both the groups intraoperatively at each time were comparable. There was a significant reduction in heart rate in group D. Group F required significantly more dose of propofol for induction compared to group D. Young's criteria of jaw muscle relaxation was better in group F, and modified scheme of London-Stubner was also better in group F, and higher instance of bradycardia was seen in dexmedetomidine group. Injuries to oral cavities was similar in both the groups. To conclude, 1 microgram per kg of dexmedetomidine when used 30 seconds before propofol induction provides successful ileemic insertion, and it's comparable to fentanyl without the respiratory depressant effects of fentanyl, so it may be used as an alternative to ileemic insertion. Ours is not a dose ranging study, and pain recovery and sedation scales were not included in our study. Thank you.
Hello. 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 Can you hear me?
Sir, she is not present right now. She has other presentation. So we will continue with the next presenter. Okay.
What's her name?
She is not present right now.
What's her name? Nidhi, yeah? Okay, go to next.
Okay. Please change the next presentation.
Is clinical and ultrasonographic assessment of airway indices in non-pregnant and normotensive pregnant patients. Airway management is the most crucial and important role of an anesthesiologist. Their anticipation and management of airway becomes more important and difficult in OBS patients, and there are various anatomical and physiological factors that place pregnant females at a furthermore greater risk. The first and foremost step in the management of airway is the assessment of various airway indices and prediction of airways easy or difficult. In routine practice, there are quick, easy, and bedside assessments done preoperatively to evaluate the airway. Nowadays, the role of ultrasound in airway assessment is encouraging. The present study was planned to compare airway indices among non-pregnant and normotensive pregnant females with the help of clinical parameters as well as ultrasound. We conducted a prospective non-randomized study in the Department of Anesthesiology in collaboration with the Radio and OBS department, We enrolled 110 female patients of age group 18 to 40 year belonging to ASA grade 1 to 3. Patients were divided into two groups. Group 1 consisted of 55 non-pregnant patients and group 2 consisted of 55 normotensive pregnant patients. Clinical assessment of airway was done with Wilson score, modified Mallampati score, thyromental distance, hyomental distance ratio, sternomental distance, neck circumference, chest circumference, and ratio of chest circumference to neck circumference. Parameters noted with ultrasound were tongue width, tongue cross section, tongue volume, skin to higher distance, skin to epiglottis distance, skin to vocal cord distance, and the ratios and the subglottic diameter. Demographic profile of the patient was found to be comparable. Among the clinical parameters, the significant values were found to be Wilson scores, which is attributable to the weight gain in the pregnancy. Hyomental distance ratio was found to be significant with mean value of 1.3 in group 1 and decreased, that is 1.23 in group 2. Neck circumference was found to be significant with the mean value of 32.64 centimeter in group 1, 36.93 centimeter in group 2. Chest circumference was found to be significant with mean value of 82.93 centimeter in group 1, 92.65 centimeter in group 2, and the ratio, while the other parameters were found to be non-significant. Among the ultrasound parameters, tongue width was found to be significant, to have significant difference among group 1 and group 2. And skin to higher distance was found to be significant with mean value of 6.41 mm in group 1, 7.34 mm in group 2, while other skin to epiglottis distance was also found to be significant with value increased in group 2. Skin to vocal cord distance was also found to be significant with value increased in group 2. Subglottic diameter had a mean value of 7.62 mm in group 1 and 6.91 mm in group 2. The ratios were also found to be significant. Routinely used clinical methods for assessment of airway are associated with inter-observer variation and low sensitivity and predictability. Hence, improved methods of airway evaluation might be beneficial. Ultrasound helps in the rapid assessment of the airway anatomy and helps to assess the concealed volume of the airway, it being non-ionizing, non-radiating, portable, quick, and non-invasive is gaining importance in airway assessment as it helps in visualizing the concealed structures. Thus, we suggest use of ultrasound to assess airway parameters in order to avoid anesthesia-related morbidity and mortality, especially in OBS patients. Thank you. Good morning, sir.
Hello.
Good morning,
sir. Good afternoon. So, good morning. So you have done this one in non-obese patient?
Yes, sir. Non-obese patients.
So you have found the changes using ultrasound, which are not found in the normal physical examination, isn't it?
Yes, sir. On ultrasound measurements, the skin thickness at various levels, like at the level of hyoid, at the level of epiglottis and vocal cord, was found to be increased in comparison with non-pregnant females, sir.
Okay. So how did it change your airway difficulty? Have you assessed that?
No, sir. Actually, this was the limitation of my study, as it is just an observational study. Mostly studies that have been done have compared it with the CL grading intraoperatively. But we haven't done that, sir, in my study.
Okay. So the thing is whether it is really useful on the practically we don't know, isn't it?
Yes, sir.
Or any other studies are done?
Sorry, sir.
Is there any other study showing that these parameters are more helpful in in predicting the difficult airway?
Yes, sir. There
practically
have.
Whether they
Yes, sir.
There
have been very few studies actually, sir. In literature, there are very few studies, and in OBS, there are not such studies, but few studies in other countries have been there who have compared the this distances and the compared with the CL grading, and they have found a correlation of increased distances with the difficult laryngoscopy and intubation, sir.
Okay. So basically, with the pregnancy, it is especially if you expect difficulty, better to do pre-op ultrasound assessment, isn't it?
Yes.
So may not be for all the patients is feasible, but if you expect difficulty, you may go ahead and do an ultrasound assessment, isn't it?
Yes, sir.
Another problem is most of the time we'll end up giving some regional with the pregnant patient.
Yes, sir. Yes, sir.
So that is a
That's
limitation
also
to
limitations of our studies.
we
Yes.
cannot assess. I mean, we don't give general anesthesia, very common, isn't it?
Yes, sir.
Okay, right. Thank you. What's
Thank
your name? Next, please.
Hello.
Yeah, next, please.
Hello. Dr. Prashant.
Greetings to everyone present over here.
How do
Here. This is Dr. Dilakshika Lachmal Reddy from Sri Ramchandra Institute of Higher Education and Research. I'll be reading about efficacy of 0.5 mg per kg of propofol at the end of anesthesia to reduce the incidence of emergent agitation in children undergoing general anesthesia with sevoflurane as my paper discussion topic. My moderators will be Dr. Akhilandeshwari M as my guide. Introducing this topic, emergent delirium is a complex of perpetual disturbances and psychomotor agitation that occurs most commonly in preschool age children in the early post-anesthetic period, and the incidence varying from 10 to 80%. Sevoflurane inhaled anesthetic use has commonly been increased in pediatric population, though emergent agitation is a temporary and self-limiting condition. It causes a high degree of self-injury and delayed discharge from the PACU and increases the medical care costs. So this is why it is a concern to us. There is a less amount of literature or studies assessing the effectiveness of doses less than 1 mg per kg of propofol given at the end of sevoflurane anesthesia to decrease the incidence of emergent agitation. So here, my aim of the study is efficacy of 0.5 mg per kg of propofol at the end of anesthesia to reduce the incidence of emergent agitation in children undergoing general anesthesia with sevoflurane. This study took place in Sri Ramchandra Institute of Higher Education and Research, and 96 patients were included in this study with 48 patients in each group, and we used a computer-generated random sequence number randomization. And ASA 1 and 2 children of aged 1 to 5 years undergoing general anesthesia for a surgical procedure using sevoflurane were included, while exclusion criteria being emergency procedures, ophthalmic procedures, ICU recommendations, psychology and neurological deficit patients, history of allergy to propofol, and patients with predicted difficult airway, and patients with cardiovascular disorders. After shifting the patients into the operating room, standard ASA monitors were connected. Pediatric anesthesia behavior score was recorded, and anesthesia was infused with sevoflurane 8% and fentanyl and atracurium according to the weight. And they used to facilitate the endotracheal intubation and laryngeal mask airway insertion. Sevoflurane was titrated to 1 to 2 mg for maintenance of anesthesia. At the end of the surgery, 15 mg per kg for paracetamol was given for all the patients for postoperative pain relief, and sevoflurane was stopped at the end of the surgery when the last skin suture was applied. Administration of propofol was performed according to the group allocation, where propofol group received a propofol bolus of 0.5 mg per kg after sevoflurane was stopped, while control group did not receive any medication. At the end of the surgery, following the intervention, neuromuscular blockade was reversed, and the endotracheal tube or supraglottic airway device was removed, and the patient was shifted to the recovery room. And upon arrival to the recovery, up to 30 minutes, it was the children were assessed for assessment for emergency sedation occurrence, and it was assessed using ANO scale and also pediatric emergency sedation scale when the ANO scale was more than 3. So they were determined to have emergency sedation when the ANO scale was more than 3, or pediatric emergency delirium assessment scale was more than 10. After the statistical analysis from the received data, we can find that the cases out of 48 population, 12 cases recorded emergency sedation in the propofol group, while out of 48 children, 23 children, that is 47.9% recorded emergency sedation in the control group. So the results will be that the emergency sedation was observed to be significantly lower in the propofol case group compared to that in the control group, which is 25% in the propofol group, while as 47.9% in the control group.
And the most significant thing to be discussed here is that we can find that the subhypnotic dose of propofol, which is 0.5 mg per kg, was effective enough to reduce the incidence of emergency sedation in children aged 1 to 5 years compared to the usually practiced 1 mg per kg per dose. The only significant thing which was important was that the transport time from the OR to the PACU was increased in the propofol group with 2.1 minute difference between each, which was not statistical or clinically significant. And my limitations were that the variety of procedures and the amount of pain depending upon the variety of procedures performed being a bias in my study. So I would like to conclude saying that the use of propofol of 0.5 mg per kg at the end of general anesthesia reduces the incidence of emergency sedation in children after inhalation anesthesia with sevoflurane. These are my references, and thank you.
Good afternoon, sir.
Yeah, good afternoon. Was there any respiratory depression after this 0.5 milligram per kg of?
We didn't find any desaturating or respiratory complications. So we had only one incidence of hypotension in a single patient in the group. Otherwise, there was no respiratory or desaturating complication because it was just a 0.5 mg per kg. So we didn't have any respiratory issues with this dose, sir.
Because I used even less, the response was good. Like I used 0.2 mg per kg. Like say,
okay,
if it is 20 child, I give 5 milligrams without any problem.
Okay.
So, is there any study from where did you get this 0.5 milligram? Is there a 0.5 milligram per kg?
So it was published in European Journal of Anesthesia. Yeah.
Okay.
They have practiced 1 mg per kg, so we planned of reducing it to 0.5, and 0.75 also has been practiced. So we just tried in 0.5 mg per kg, and we found that yes, sir.
Yeah. Because for our population, it may be they are more sensitive. I think they do respond even for less.
Yes, sir. Just we had one few incidents of hypotension which had to be treated, sir, with the fluid boluses, but otherwise that respiratory complications were not recorded in the study, sir.
Okay. Right. Okay. This was given at the time of just before the extubation or after reversal?
So the sevoflurane was cut during the last skin incision, like suturing was done, sir. So we cut the sevoflurane at that minute, and when we cut the sevoflurane, give 0.5 mg per kg, sir. So you get a time period, they finish the dressing and everything. When the patient starts breathing, that sedative effects will be there. At the same time, you won't find the patient in much a deep plane for you to have a time to wait to extubate, sir. Yes.
So was there any extubation criteria problem, like the like if you follow the exact objective and subjective criteria for extubation?
So the only issue was
the issue was we couldn't actually find that eye opening as per se was not present, but we can see that the patient was spontaneously breathing and the patient was sedated. But you can see that he's having adequate spontaneous efforts that you can go ahead with extubation, and the patient was calm and composed while trying to move with the patient from or till the patient reaches the mother or the caretaker who is in the post anesthesia care unit.
It's basically not recommended, isn't it? Especially in children.
It is not, sir, but the fact is that you can see the child opens the eye completely, but you feel that he opens and the response is received, but then you find that the child goes into a calm nature. But it's not like he's not at all in a spontaneous thing, so he has adequate efforts.
Okay. Now what I do is I extubate first, okay? Then
okay, sir.
Then I give them a very low dose of propofol, very low dose. Just they sleep off well. But I have not done any study regarding that. But that is what I do. Okay, good question.
Sure, sir.
Okay. Yeah. Any other question?
What are the procedures that were done on the children, doctor?
So we had short and long procedures, sir. So that was the only bias we had.
Okay, like can you name some procedures?
Sir, probably
Hello?
her internet
sir.
connection
Am
is
I
not
audible?
working.
Yeah.
Yeah, you are audible. I think, sir, you need to repeat the question to her.
No,
So
no,
I heard the question. We
Okay.
had a hypospadiasis repairs. We had Duhamel's surgery, Duhamel's pull-through, colonic pull-throughs for Hirschman's disease, and then we had a few laparoscopic appendicectomies, cystectomies, herniatomies, open and laparoscopically performed, sir.
Okay. The
Yes.
post-op analgesia was similar in both groups. Post-op analgesia.
Sir, the duration was an issue. Duration of the surgery did matter, sir, because the longer the procedure was, the child needed further analgesics. But regarding that emergence agitation period and the crying and consolability was better with the group which was using propofol, sir.
Okay, right.
Yeah.
Right.
Thank you, sir.
Yeah, please, next slide, please. Thank you.
Hello, my name is Dr. Shrika Sangeeta. I'm from BGS Global Institute of Medical Sciences. I'll be speaking on effectiveness of bilateral tap block for early mobilization in women undergoing elective LSCS under subarachnoid block. Post-operative pain from an LSCS can cause delayed recovery and poor mobilization post-operatively, wherein we use a multimodal approach to mitigate this pain. Tap block, which was introduced by Rafi in 2001, is one such technique wherein in combination with ultrasound increases the precision and now is a part of multimodal approach. Early mobilization reduces the risk of thromboembolism, improves pulmonary function and mother-child bonding. The aim of my study is to study the effectiveness of bilateral ultrasound-guided tap block with 20 ml of propofol 20.5% versus no tap block for the time to first mobilization after LSCS using sinus incision the subarachnoid block. This is a prospective randomized clinical study wherein we select women undergoing LSCS under sinus incision at BGS Global Institute of Medical Sciences and Hospital, Bangalore. Inclusion criteria being ASA physical status 2, appearance between the ages of 19 to 40 years, and patient refusal with known allergy to study drugs will be exclusion criteria. Randomization will be done using open envelope method into two groups, wherein group A will receive the tab block with 20 ml of 0.5% ropivacaine at T10 dermatomal level, and group B do not receive the tab block. Sample size was found to be 60 with 95% significance level, 80% power, and addition of 10% attrition derived from previous literature. After obtaining the institutional ethical committee approval, 60 women satisfying the inclusion criteria were selected and a detailed pre-anesthetic evaluation done, consent taken, and increased status. In the preoperative holding area, preoperative medications were supported. Subarachnoid block performed with 10 mg of bupivacaine in sitting position. Intra events and vitals were recorded. At the time of closure, injection paracetamol was given to both the groups. Ultrasound-guided tab block was performed in the operation theatre post-operatively for group A patients, and no tab block was given for participants in group B. Both the groups received injection paracetamol IV 8th hourly post-operatively. Transfer of spleen block was performed using an ultrasound probe linear probe with an imaging depth of 3.3 to 4 centimeters between the anterior and mid-axillary line at the T10 dermatomal level using a 23-gauge Quincke canal needle. Needle tip placement confirmed real-time hydrodissection and 20 ml of drug injected in 3 ml increments. Procedure repeated on both the sides. Time for first mobilization was measured as the time taken to stand with support at the bedside for the first time after surgery. Other hemodynamic monitoring was done. Analysis was done using SPSS software version 22. After data obtained was entered into Microsoft Excel spreadsheet and the following statistical tests were used. P-value less than 0.05 was considered significant. Demographic parameters with respect to age and BMI were comparable between both the groups. Time to first mobilization was found to be 20.4 hours in the group receiving tab block and 24.86 hours in the group not receiving tab block. P-value less than 0.001 means women receiving tab block significantly early mobilization time as compared to without the tab block. All women in both the groups did not have any complications. In our study, the ultrasound tab block 10 ml of 0.5% was statistically significant for early mobilization, where it improves pulmonary function, insulin resistance, reduces the risk of thromboembolism, and shortens the length of stay, and also improves the bonding of mother and child. Other studies conducted in the past proves that tab block provides longer analgesia and lessens the associated side effects with the opioids. And a lesser concentration of ropivacaine is also comparable with the 0.5% ropivacaine. Previous studies provide comfortable and feasible methods of postoperative analgesia with minimal complications, that is tab block. So in conclusion, ultrasound bilateral transfers of the plain block with 20 ml of ropivacaine 0.5% is a safe and effective useful tool for early mobilization of women undergoing LSCS under subarachnoid block as a part of multimodal analgesia. These are my references. Thank you.
So good afternoon, sir.
Hello.
Hello, good afternoon, sir.
So after how many hours of surgery you started mobilizing?
Sorry, sir.
When did you start mobilizing the patient after surgery?
Sir, we have advised for the patients to, whenever they can be able to stand next to the bed with support. That time we have taken as time to mobilization. So when we divided the patients into two groups, Group A and Group B, Group A received the tab block and Group B did not receive the tab block, sir. So on the result, we found on an average around 20 hours it took for Group A patients to stand with support at the bedside, whereas 23.5 hours for Group B patients.
$3.5, so much difference.
Sir?
They said even tab block they can mobilize in 3.5 hours.
So 20 hours.
Yeah, it seems there is
20 hours after 20 hours.
There is a 3-hour difference, it seems.
Yes, sir. On an average, 3 hours difference.
So the tab block is only ropivacaine. It will act for a maximum 6 hours. It's a single dose, isn't
Sir.
it?
Yes, sir.
So what is the point after 20 hours? How do you assess that?
Sir, it was assessed by using visual analog score pain score, sir. Post-operative pain scores were
Pain
generally
score,
found to be.
okay. It's about mobilization, isn't it?
Yes, sir. Mobilization. Yes, sir. So with ropivacaine, when the patients
Patients are
experience
mobilized
better.
after 20 hours.
Yes, sir.
The ropivacaine.
Sir, sorry, sir. I was not able to hear the question.
So how do you relate the tab block with mobilization?
Sir, since it provides better analgesia, the patient satisfaction score was better, sir.
I agree. Pain is less. With mobilization started after 20 hours, isn't it?
Yes, sir.
Your aim of the study was mobilization, isn't it?
Yes, sir. Sir?
I think Dr. Prashant is disconnected due to some poor network coverage. Okay. So, sir, you can ask some question if Dr. B. Yeah.
Yes. See,
Sir, good morning. Good afternoon, sir.
Good morning, doctor. See,
Yes,
your idea is about mobilization.
Yes,
but
sir.
the thing is, the duration of action of ropivacaine, which Dr. Prashant was talking about.
Yes,
so after 20 hours, now we cannot say that it is because of the tab block only that by ropivacaine that effect is there. Or could it be due to placebo effect?
Sir, we are giving tab block as a part of multimodal analgesia, sir. We have been giving 8-hourly paracetamol as well to the patients. So the initial pain scores were better with the tab block, sir. So it improved the patient satisfaction and helps in the early mobilizations and early recovery after surgery.
There are other modes of an post-op analgesia, no? Like spinal opioids.
Yes, sir. Intrathecal opioids, since tab block can avoid all the side effects of the opioid use, sir. So there have been studies where it has been shown that the tab block is analgesically more equally efficacious as intrathecal opioids, but it avoids the side effects of the opioids.
Is it statistically significant 20 hours and 23 hours?
Yes, sir. We got a p-value of less than 0.001. So result has come as statistically significant.
Okay. Right.
Okay. Thank you, sir.
Next, please. Next.
Yeah, next, please.
My topic is comparative study between dexamethasone and dexmedetomidine added to bupivacaine in supraglycemic supraclavicular block approach in a brachial plexus block.
इसमें दिखाई किसी
Introduction brachial plexus block is a regional anesthesia technique employed sometimes as a safe and a valuable alternative to general
background
anesthesia
noise,
for
please.
upper limb surgery. In this technique, injection of local anesthetic agent near brachial plexus block is given, which temporarily blocks sensation and movement of the upper limb. Among several supraclavicular is considered the most effective, easiest, and can perform very quickly than the all other approaches. In this, single injection can lead to rapid onset of anesthesia of the arm and the forearm, and it is given at a level of
Can
C5 to
please,
T1 nerve
please.
roots. Many
Hello.
reports suggest that this method can be given by the
Please.
combination of the both techniques to locate the nerves more effectively to hit the supraclavicular block. Most commonly used local anesthetic for this block are morphine, pethidine, clonidine, dexmedetomidine, butorphanol, and buprenorphine, etc. Most of them are associated with side effects like heavy sedation, respiratory depression, psychomimetic effects. Combination of 0.5% bupivacaine or 0.5% bupivacaine with different drugs prolong the analgesia during and also lower the anesthesia onset time. Dexmedetomidine is a potent alpha-2 adrenoreceptor agonist and is approximately 8 times more selective than the clonidine. Other drug, dexamethasone, is a very potent, highly selective glucocorticoid which can prolong the anesthetic duration of supraclavicular block. Combination of both can be given. Material and methods. Study population. Patient range from 18 to 60 years who underwent forearm surgery in the Department of Orthopedics in Medical College, Muzaffarnagar. Study was performed with permission of the ethical committee. 30 patients were recruited in each group. 3 study groups were taken. Total 90 patients were there. Inclusion criteria included patient scheduled for the elective forearm surgery, patient with ASA physical status of 1 and 2, and age between 18 to 60 years. Exclusion criteria included patient refusal, patient undergoing emergency surgery, allergic to any drugs, inadequate block, previous neurodeficit, patient with bleeding disorder or local infection, BMI than 30. With severe system like was as a loss of inflation loss to
इसमें इधर से इन्होंने म्यूट कर दिया म्यूट भी हो रखा है हाँ अभी दोबारा से स्क्रीन शेयर कर दूँगी मे बी उनकी तरफ से कोई दिक्कत है उधर से उनकी में वो आ रहा था म्यूटेड आ रहा था उधर साइन बना उनकी ये अनम्यूट कर दिया हाँ मेरा तो वीडियो भी ठीक कर दी है बट फिर नहीं हो रहा
Yeah, Dr. B. Srinivas, are you there?
हेलो
Yes, yes.
आपको आवाज आ रही है सर? मुझे आप दिखाई नहीं दे रहे हैं.
No, I'm audible. We are the backend team, but doctor is on mute, and I think he's not available. Please be online, okay?
Okay, okay, okay.
Or we can resume. Just a moment.
Okay, sir.
Yeah, doctor, please continue.
Yes.
Sir, you can ask some question.
Yeah, yeah. Hello.
Good afternoon, sir.
Yeah. So what is your inference?
Sir, my inference from the study was or dexamethasone and dexmedetomidine both have the similar effects, but dexamethasone has more effect as compared to dexmedetomidine. क्योंकि वो मोस्टली हम डेक्सामेथासोन ही प्रेफर करते हैं क्योंकि मतलब स्टेरॉइड भी है तो एंटी इन्फ्लेमेटरी भी है तो उसका जो एक्शन है वो ज्यादा बेटर था डेक्सामेथासोन के कंपैरिजन में पेशेंट्स में, तो मोस्टली वही यूज होता है स्टडी में.
Right. Okay. Please. Next.
Hello.
Yeah. Please. Next option.
Sir, I
So
cannot hear you. Sorry.
it's okay. It's okay. Nice. Fine.
Okay, thank you so much. We can move to the next session.
उसने तो एक ही क्वेश्चन पूछा मुझसे.
तेरा चेहरा देख के नंबर दे दियो.
Yeah, Avi, please. Yeah, mute yourself.
Okay.
Yeah, please resume the video.
Hello? Hello? Hello?
Hello.
Yeah. So not able to share.
Yes, actually, there is some glitch in the network, so we are just
Okay.
trying to fix. Give me 2 minutes, sir. Okay.
We compare mean heart rate and mean arterial pressure in study. In our study, 2 patients in Tramadol group require additional rescue and T-sibling drug, while in dexmedetomidine group, none of the patients require rescue drug. The p-value for this 0.49, which is not statistically significant. We recorded that out of 60 patients, 80 patients had developed grade 1 sibling, 8 patients had grade 2 sibling, and only one patient developed grade 3 sibling, which is required rescue. There was no significant difference among the group. Both the groups are equally effective for the prevention of the sibling. Hypothermia is associated with sibling and so many complications. So surgical patients should kept normothermic unless hypothermia
Yes,
is
sir.
indicated.
Yes, sir.
Both the drug in this study can cause sedation to varying degree.
Yes,
Group D
actually,
has more
there
sedative
is some
effect
glitch
than
in
group
the network,
D
so we are
without
just
any
trying to
respiratory
fix.
depression.
Give me
In
2
our
minutes.
study, we concluded that dexmedetomidine and tramadol are equally effective in the prevention of the sibling during the spinal anesthesia. Dexmedetomidine has added advantage of the adequate, reliable sedation without any respiratory depression and fewer side effects. The incidence of the adverse effect like nausea, vomiting is higher in patients receiving tramadol. Hemodynamic profile remains stable in both groups. Here are some reference of our study. Thank you.
Hello. 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 Can you hear? Hello.
ऐसे काम करो तो फिर काम चलेगा.
Hello. ಚೇರ್ ಕೊಡ ಕೂತ್ಕೊಳ್ಳಿಕ್ಕೆ ಇಲ್ಲಿ ಚೇರ್. ಹಲೋ. Hello.
Yes, Dr. Prashant. Thanks for joining.
Some network issues. I can't hear anything actually.
Okay. Am I audible right now?
Yeah, I can hear you, but from the presenter I couldn't hear much.
Okay. So we'll continue with the next presenter. Okay.
Yeah, please.
Yeah, please change the next presenter.
Hello, Dr. Pradeep. Hello.
I'm not doctor, sir. You can call me Pradeep.
Yeah, Mr. Pradeep.
Yes.
I can't share this thing screen. Screen is not visible to me.
Okay. Now, is it visible, sir?
No, it is not visible.
So you just log out and logged in again on the same link. Okay, please change the slide. Play the slide. Okay.
I'm going to present my paper on the topic, a comparative study of hemodynamic and end-tidal carbon dioxide changes during laparoscopic and open cholecystectomy. The study was conducted at a tertiary care institute, Jorhat Medical College and Hospital, Assam, under the guidance of Dr. Kanoj Sergei. The Greek origin word laparoscopy means looking into the flanks, achieved through the abdominal wall after creation of pneumoperitoneum. Laparoscopic cholecystectomy requires small incisions, shorter hospital stay, and shows faster recovery time. There is also less post-operative pain and less post-operative ileus due to reduction in manipulation of bowel and peritoneum. Laparoscopic cholecystectomy, however, also has complications due to increase in intra-abdominal pressure, carbon dioxide absorption from peritoneal cavity, and frequent change in patient position. This study was done to compare the hemodynamic, EtCO2, SpO2 changes during laparoscopic and open cholecystectomy, and also to evaluate any additional effects of insufflated carbon dioxide during laparoscopic cholecystectomy under general anesthesia. In this study, we included 70 patients of either gender, ASA grade 1 or 2, belonging to the age group 18 to 60 years, planned for elective cholecystectomy. The drugs used for anesthesia were standardized in both the groups. Patients were divided into two groups of 35 each, Group 1 open cholecystectomy and Group 2 laparoscopic cholecystectomy. The changes were recorded at baseline and at 10 minutes interval thereafter. EtCO2 changes were recorded at 10 minutes after intubation and is continued at 10 minutes interval. Coming to the results, we see that the two groups were comparable with respect to age, gender, weight, and ASA status, as there is no statistically significant difference. It was also observed that on comparison between the two groups, as shown in figure 1 and in figure 3, the difference in heart rate and systolic blood pressure were significant during the surgery till about 60 minutes, whereas the difference in diastolic blood pressure and mean arterial pressure were significant till about 50 minutes of the surgery, as shown in figure 4 and figure 2. After these parameters gradually become comparable to that of the baseline. It was also noted that there is significant rise in mean EtCO2 in group 2 when compared to group 1, which remains significant throughout the surgery as shown in figure 5. The mean values of SpO2 were also compared, but they were found to be statistically insignificant. Thus, we can conclude after this study that there are significant hemodynamic and EtCO2 changes even in ASA grade 1 and 2 patients during laparoscopic cholecystectomy when compared to open cholecystectomy. However, most of these changes are transient and lie within the normal range, which become comparable to each other by the end of surgery. Thank you.
Okay, can you hear me? Hello? Hello?
Sir, I think he's not joined yet.
Oh.
Okay, so we'll continue with the next presenter. Okay.
Okay.
Next slide, please.
Hello everybody, I am Dr. Ritma. I would like to present to you all my paper, High Mental Distance Ratio as a new predictor of difficult laryngoscopy in ICU patients and observational study. ICU patients often require intubation, but the risks is different from that in the operating room. Hence, it is required to find a parameter which is helpful in improving first attempt intubation success in ICU patients. But most of the studies consider multiple clinical parameters. We need one such good parameter which can predict difficult intubation, which reduces the time for evaluation and intubation, like high mental distance ratio. Most studies on HMDR is conducted in operating room settings. There are less studies of HMDR in ICU patients. Hence, this study is intended to evaluate usefulness of HMDR as a predictor of difficult laryngoscopy in ICU patients. The primary objective of this study is to assess validity of HMDR as a predictor of difficult laryngoscopy amongst ICU patients. The secondary objective is to assess validity of HMD in different head positions as a predictor of difficult laryngoscopy amongst ICU patients. The study was performed on patients admitted in ICU from December 2019 to October 2021 in Ramaya Hospital. Ethic committee approval was obtained. Written informed consent was taken. It was a cross-sectional clinical study design. Sample size was estimated based on Kasalik et al. Study. Our study included 104 patients. Age of 18 to 70 years and hemodynamically stable patients in the ICU requiring intubation were included in the study. Patients coming under exclusion criteria were excluded from the study. Each patient was made to undergo pre-procedure assessment. HMD in neutral and extended head position was performed and the high mental distance ratio was calculated. All patients were pre-oxygenated, sedated, induced, and relaxed using weight-adjusted dose of medications. Laryngoscopy was performed by anesthetist with intubation experience of 2 years who was blinded to HMDR value. Glottis visualization was graded as per CL grading mentioned without external manipulation of larynx. However, after the value was noted down, further airway management was as per ICU protocol. Descriptive and inferential statistical analysis was performed using chi-square test. Mean age of the study population was found to be 56.68 years. More number of male patients were included in the study. High mental distance ratio was found to be statistically significant. High mental distance in extended head position was found to be moderately statistically significant. High mental distance in neutral position was found to be having no correlation. High mental distance ratio showed accuracy of 86.5%, and while that of extended position showed 70.2% accuracy, there was no valid accuracy of neutral position. These were primary and secondary outcome variables. Our study showed that difficult intubation was more common in males than in females, but the number of patients were also more males, hence this data was not statistically relevant. Based on the previous study, the incidence found, that is 25%, was similar to the other studies. Overall sensitivity, specificity, accuracy, and primary diagnostic predictor HMDR was highest with statistical significant p-value of less than 0.001 in assessing DVL. Diagnostic accuracy of HMD in extended position was found to be statistically significant, that is moderately significant. The results were similar to study by Kasalik et al. The disadvantage noted in the study was its low positive predictive value. High mental distance ratio was previously suggested as a new possible predictor with cutoff of cutoff point of 1.2 and was found to be statistically significant value. Patients were kept supine, which helped to prevent intersubject variability and also had an advantage because most of the ICU patients are supine. In COVID ICU patients, there might have been little difficulty with safety kit related issues, but aerosol box was not used by us, and also HMD values were noted much ahead of intubation to prevent disruption during emergency intubation. Application of external laryngeal pressure alters the CL grade and making difficult intubation easy in some patients. More studies with HMDR as predictor of deviance should be performed in ICU patients across the globe to make HMDR a commonly usable parameter. I conclude by saying that HMDR can be used as a reliable predictor of DVL due to significant diagnostic accuracy, and value less than 1.2 can be used as a test threshold. Optimal combination of tests can be performed if feasible rather than using it alone. Thank you. These are my references.
So she is also not present, as she is presented yesterday also, and question has been asked. Okay, so we'll go to the next slide again.
Okay.
Hello everyone, my topic is the effect of injection dexmedetomidine infusion in a cochlear implant surgery among the pediatric patients, age group of 1 to 7 years of age. It provides in this study, good results in this surgery are obtained by providing the bloodless surgical field with a controlled hypotension and post-operative smooth outcome. And dexmedetomidine, it's a active isomer of the medetomidine, and it's alpha-2 adrenoreceptor agonist. It provides a perioperative sedation, analgesia, thus decreasing the other general anesthesia drug requirement and reduces the post-operative pain score and post-operative delirium and complications. It uses as a sedation for the mechanically ventilated patient in ICU setting, as a local adjuvant, local anesthetic adjuvant for the prolongation of effect, for the sedation in a non-intubated patient, and monitored anesthesia care, or as a sole TBA agent. As an advantage, it has a minimal respiratory depression, cardioprotective, renoprotective, and cerebroprotective. As an adverse effect, it reduces heart rate and blood pressure, drive out diuresis, nausea, vomiting, irregular heart rate, and potential to effect of opioid sedative and anesthetic. Aims and objective of this study is to determine it's a suitable agent for the hypertensive anesthesia in cochlear implant surgery, to determine that this drug is suitable to stabilize the intraoperative hemodynamics, and to find out the postoperative outcome in pediatric patients. 60 patients of pediatric age group 1 to 7 years undergone cochlear implant surgery in last 3 years were studied. Patient was medicated with the ondansetron, glycopyrrole, and midazolam, and inducing with the injection propofol, fentanyl, and scopolamine according to the patient's weight, and intubated with the appropriate size ET tube cuffed. Injection dexmedetomidine infusion 1 microgram per kg IV over 10 minutes, followed by the dexmedetomidine infusion 0.5 microgram per kg per hour for the maintenance. Maintenance was used. For the maintenance, go-to-endo and sevoflurane and etraquinone were used. Reversal was given and extubated when the patient breathes spontaneously. Intraoperative monitoring of heart rate, non-invasive BP, and the SpO2 was done. And postoperative pain score and postoperative delirium emergence will be studied in this group. These are the inclusion criteria and exclusion criteria of the patient of this study. Statistical analysis, descriptive and qualitative analysis will be done. These are the different types of scores we have studied in this group. In this study, these are the this graph shows the comparison of heart rate and mean arterial pressure in group P and D at various time interval. Limitation of this study was the monitoring of the quality of surgical field visualization was done with a subjective scoring system, and we have to depend upon the assessment by the operating surgeon for this. And conclusion is that it provides dexmedetomidine infusion intraoperatively provides a good controlled hypotension, better surgical fit, and higher surgeon satisfaction score. And it reduces the consumption of propofol and fentanyl to achieve the hemodynamic stability, and It has a better recovery profile and lower incidence of post-operative complications like the emergent agitation, post-op pain, and nausea, vomiting. Thank you.
Hello. This presenter also not there?
Yeah, I just spoke with her and she said that she will be connecting. And now
No, Pradeep, you
Yes,
can do
yes,
one thing. See, if they are not there, there is no point in only just
playing
saying.
their presentation. Yes, yes. I think we must go with the person who is actually present.
Yeah,
In
if they are there, let them present. Otherwise, I think there is no point.
Okay, we
you
will
ask
do
other
that.
chairperson also about this.
Okay. Yes. Okay. Next video, please.
Yeah. If they are there, they can present. Otherwise, no.
Greetings all. My topic is safety and efficacy of ketamine nebulization to reduce post-operative sore throat in patients undergoing general anesthesia, a prospective randomized double-blind placebo-controlled study. Introduction. General anesthesia with endotracheal intubation is the commonest cause of injury to the area mucosa, resulting in post-operative sore throat with reported incidence of 21 to 65%. Post is a frequent complaint after endotracheal intubation, which results in significant patient discomfort and disappointment with the quality of care. Recently, quality assurance of anesthesia has become increasingly important for improving post-operative outcome. For this, various pharmacological and non-pharmacological methods have been used for attenuating post with variable success. It has been shown that NMDA receptors are present not only in the CNS but also present in the PNS. So, peripherally administered NMDA receptor antagonists like ketamine are involved in anti-nociception and anti-inflammatory cascade. Ketamine can be used for decreasing post as a gargle as well as in a nebulized form. Aim of the study is to evaluate the safety and efficacy of ketamine nebulization to reduce post after endotracheal intubation in patients undergoing general anesthesia. Primary objective is to compare the incidence and severity of post between the two groups, and the secondary objective is to compare any adverse events or any hemodynamic instability between the two groups. After approval from the IRB and informed consent from all the patients, study will be carried out in the Department of Anesthesiology at the Hospital Bhavnagar. After thorough pre-anesthetic checkup, 60 patients of either gender in the age group of 20 to 60 years with ASA grade 1 to 3 undergoing general anesthesia with endotracheal intubation were included in the study. Patients with a history of preoperative sore throat, oral surgeries, asthma, COPD, myelopathy grade greater than 3, non-allergies to study drug, NSAIDs medication, and those who requires more than one attempt at intubation were excluded from the study. Patients were randomized using computer-generated random number sequence method into two groups. In group K patients, nebulization was done with ketamine 50 mg 1 ml plus normal saline 4 ml. And in group N patients, nebulization was done with normal saline 5 ml. After shifting the patient to the pre-anesthetic care room, baseline parameters were recorded before and after giving nebulization at 5, 10, and 15 minutes. Patients were shifted to operation theatre after 15 minutes of giving nebulization. General anesthesia was given to all the patients. A brisk and gentle laryngoscopy were done by using a Macintosh laryngoscope blade size number 3 or 4, and trachea were intubated with a sterile single lumen cuff PVC and AT tube, and cuff was inflated with a volume of air until no air leakage was audible or palpable. At the end of surgery, oropharynx was suctioned with care using a soft disposable suction catheter, and the cuff was deflated properly and tube was removed after the patient regained complete consciousness. After shifting the patient to the PACU, post was assessed by the anesthesia resident at 0, 2, 4, 6, 12, and 24 hour post-operatively for the incidence and severity. For the severity, post was graded on a 4-point scale. In grade 0, no sore throat. Grade 1, complaint of mild sore throat only on asthma. Grade 2, complaint of sore throat on his or her own. And grade 3, severe sore throat, change in voice associated with sore throat. Observation and results. Demographic data in terms of age and gender were comparable in both the groups. The incidence of post at 0 and second post-operative hour was were comparable in both the groups. And the incidence of post at 4, 6, 12, and 24 hour was significantly less in group K as compared to group N. For the severity, at 0 and second post-operative hour, the post were comparable in both the groups. And at 4, 6, 12, and 24 hours, the severity of post were significantly less in group K as compared to the group N. Discussion. The incidence and severity of post were comparable at 0 and second post-operative hour, while at 4, 6, 12, and 24 hours post-operatively. The incidence and severity were significantly less in group K as compared to the group N. This may be due to the anti-inflammatory and anti-nociception effects of ketamine through NMDA receptors. The hemodynamic parameters like pulse rate and mean arterial pressure were comparable in both the groups. From the study, it is concluded that preoperative administration of nebulized ketamine effectively attenuates the incidence and severity of post in patients under general anesthesia with intraocular intubation with no significant hemodynamic changes. Thank you.
Yeah. Hello.
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 Good afternoon, sir.
Yeah.
Hello.
Yeah,
Good afternoon, sir. Yes, sir.
This is something new. First time I'm hearing about this ketamine
Yes, sir.
nebulization.
Yes, sir.
Thing is, they were all adult patients, isn't it?
Yes, sir.
Adult patients.
22 between 20 to 60 years old.
Okay, okay. How it acts actually as a local and this thing? What is the
Yes, sir.
mechanism?
The
Proposed
NMDA
mechanism?
receptors are present in the CNS as well as in the peripheral nervous system, sir. So
Oh, okay.
it also acts through the. Actually, in this case, through the nebulization, act through the local effect.
So NMDA receptors are there in the airway also?
Yes, sir. In the airway also, in the upper respiratory
Okay.
tube.
Okay. Okay, right. Okay. Any other question from other chairperson, sir?
Sir, you are muted, sir. Unmute yourself.
I am unmuted.
Yeah. Hello.
Hello.
Sir, any question you can ask.
What is the timing of nebulization?
Sir, around
Timing.
15 minutes before the intubation, sir.
15 minutes before extubation.
Before intubation, sir. Before intubation.
Okay. Right. So
Was there any? Excuse me. Yeah, one second.
So it decreases the inflammatory response.
Yes.
That is okay.
Was there any psychomimetic effects or anything up to that?
No, sir, because the chances of systemic absorption are very less, sir. So there is no any significant side effects.
Okay. From where you got this idea? Any previous studies were there?
Sir, actually, I have got this idea from my PG guide, sir. Only 2 to 3 studies were there, and that too with the ketamine gargles, sir. So.
Okay. Okay.
Sir, any other question? Or will we
No, you can go
move
ahead.
to the next slide?
Yeah,
Okay.
next.
Yeah. Thank you.
Thank you, sir.
So, next slide, please.
This is Dr. Mayuresh Hansal. My topic is the effect of intraoperative ketamine on postoperative catheter-related bladder discomfort in abdominal surgeries under the guidance of Dr. Gaurav Sharma, sir. Introduction. Urinary catheterization is one of the most common procedures performed in indoor settings, wards, and operation theatre to measure the accurate urine output. Urinary catheter insertion perioperatively may result in feeling of elevated urinary urgency, frequency, and discomfort at suprapubic region. Collectively, these symptoms are referred as catheter-related bladder discomfort bar CRBD. The mechanism of CRBD is found to be similar to that of overactive bladder. CRBD is resistant to conventional opioid therapy and may result in increased incidence of postoperative complications. The primary aim of this study is to evaluate the effect of intraoperative ketamine on incidence and severity of CRBD in postoperative period. Secondary objective is to evaluate analgesic effect of ketamine in presence of any side effects. Material and methods. The study was conducted in 90 patients undergoing electroabdominal surgeries at SMS Hospital, Jaipur after obtaining clearance from Ethics Committee. Patients undergoing urological surgeries or requiring interventions were excluded from the study. Patients were randomized into 2 equal groups of 40 subjects. Group A received IV normal saline and Group B received 0.5 mg per kg IV ketamine after induction of anesthesia but before urinary catheterization. Urinary catheterization was performed with 16 French Foley's catheter 90 seconds after injection of ketamine or normal saline. The study compared incidence and severity of CRBD, time to first rescue analgesia, VAS score at incision site and local site, presence of side effects in the post-operative period up to 12 hours. The study was registered under CTRI. Results. There was no statistically significant difference in demographic data. The incidence of CRBD in post-operative period was significantly lower in Group B, which was 37.7% compared to Group A, which was 68.8%. Reduction in severity of CRBD was noted at 0 hour and 1 hour post-operatively in Group B compared to Group A, as all Group B patients experienced only a mild form of CRBD. Mean time to first rescue analysis was significantly longer in group B, which was 93.1 minutes, compared to group A, which was 37.8 minutes. The mean VAS score at incision site was significantly lower in group B as compared to group A at 0, 1, and 2 hour periods. No statistical significant difference was noted in percentage of cases who showed side effects in the form of sedation, postoperative nausea, vomiting, respiratory depression, hallucinations, and diplopia. Discussion. CRVD defined as an urge to void or suprapubic discomfort is common in the patients who have an indwelling urinary catheter in the postoperative period, which leads to negative influence on patient's quality of life. The mechanism of CRVD is found to be similar to that of an overactive bladder, which is caused by involuntary contractions of the bladder smooth muscles due to stimulation of vesical muscarinic receptors, mainly M2 and M3, by the indwelling catheter. Ketamine acts on muscarinic receptors, and analgesic effect of ketamine might be additive or synergistic with its antimuscarinic activity in decreasing the severity of CRVD. In our study, incidence of CRVD in postoperative period was significantly lower in group B compared to group A, and reduction in severity of CRVD was noted up to 1 hour postoperative period in group B compared to group A. These results are in accordance with Agarwal et al. And Reza Shariat Moharari et al., who concluded ketamine can reduce incidence and severity of CRVD in the early postoperative period. In our study, mean time to first rescue analysis was significantly higher in group B compared to group A. These studies are in accordance with Kevin Latkowski, who concluded intraoperative ketamine reduced opioid consumption and provided analgesia. In our study, VAS score was significantly lower up to 2 hours. These studies in accordance with Azim, who concluded that intravenous ketamine given prior to surgery provides prolongation of analgesia. In our study, we didn't observe any significant side effect with 0.5 mg per kg of IV ketamine. Similar results were observed by Simin Atakshoyi, who found addition of 0.5 mg per kg ketamine is not associated with any side effects. Limitations of the study. In our study, single dose of intraoperative 0.5 mg per kg ketamine before urinary catheterization provided relief up to 1 hour in the post-operative period. As this is a short period of time to maximize the effect of ketamine to provide relief from CRVD for a longer duration of time, we may have to give multiple doses or incremental doses of ketamine. Hence, the more large-scale, multicentric, randomized, controlled interventional studies are required. Conclusion: administration of intraoperative 0.5 mg per kg of IV ketamine before urinary catheterization can reduce incidence and severity of CRBD as well as prolonged postoperative analgesia without significant side effects during the postoperative period. Thank you.
Sir, any questions, sir?
So, what are the surgeries they were undergoing? And
Good
duration
afternoon,
of surgery?
Good
Good
afternoon,
afternoon.
Sir, the
Yeah, good
patient mainly underwent the abdominal surgeries, sir, which didn't include any urological surgeries, sir, or in surgeries in which there was no urological intervention, sir. Like patients who had subacute obstruction, sir, or the patients undergoing hernia
No.
repairs.
What was the approximate duration, average duration of your surgery?
Sir, the duration approximately was around 92 90 minutes, sir. In both
Okay.
the groups,
usually they catheterize before starting the surgery, isn't it? Or
yes, sir. Yes, sir. Yes, sir. Catheterization was performed after induction of anesthesia, sir. Then
okay.
before
So
catheterization, we gave ketamine, IV ketamine, sir.
basically, at the induction, we have given ketamine.
Yes, sir. Yes, sir.
So how long this effect lasted?
Sir, incidence, sir. When coming to the incidence of the CRBD, sir, it lasted up to 1 hour, sir. It reduced the incidence and severity also up to 1 hour, sir, post-operative period, sir. And we noticed, sir, reduced VAS score in up to 2 hours, sir. And time for rescue analysis was longer, up to sir 2 hours in the 1.5 hours, sir, in the ketamine group, sir.
Okay. So, sir, if you have any question, you can ask, sir.
So, when did you remove the catheter?
Sir, catheter was not removed, sir. In post-op period, our observation was only up to post-op 12-hour period, sir.
12 hours.
Yes, sir. In the post-anesthesia care unit, sir, up to 12 hours we observed the study, sir.
Okay. So, what were the benefits of giving ketamine? What were your observations?
Sir, my observation was that, sir, ketamine at first, sir, it reduced the incidence and severity of the catheter-related bladder discomfort, sir, as well as it provided analgesia, sir, to the patient. As we were using a very low dose of ketamine, sir, 0.5 milligram per kg, there were very less significant side effects which were noted, sir.
Right. Okay. Okay. We can go to next presenter.
Thank you, sir.
Okay, thank you. Yeah, please present next one.
Magnesium sulfate with esmolol for attenuation of response to laryngoscopy and intubation. Laryngoscopy and endotracheal intubation following induction of general anesthesia is commonly associated with hemodynamic changes due to reflex sympathetic discharge. Attenuation of hemodynamic response has been practiced by various methods like deepening the plane of anesthesia, using advanced airway devices, using drugs topically or systemically. This study was undertaken with the objective of comparing the effectiveness of magnesium sulfate with esmolol for attenuation of hemodynamic responses to laryngoscopy and intubation. Source of data was patients scheduled for elective surgeries under general anesthesia with endotracheal intubation in the Department of Anesthesiology, ASI Medical College, Bangalore. Sample size of 72 patients was calculated based on previous literature using 80% power, 95% confidence interval with ratio of sample size 1:1. Study design was a prospective randomized study. Inclusion criteria: patient willing to give informed consent, ASI class 1 patients 80 to 60 years of age posted for elective surgeries under general anesthesia with endotracheal intubation. Exclusion: unwilling to participate in the study, allergic to study drugs, anticipated difficult airway, emergency procedures, patients requiring rapid sequence induction and intubation, baseline heart rate less than 60 beats per minute, baseline SPP less than 100 mmHg, PR interval greater than 0.24 seconds, second or third degree heart block, sick sinus syndrome. Following ethical committee approval, patients fulfilling the criteria were selected and detailed pre-anesthetic evaluation was done. Informed consent was obtained. Study population was randomly divided into two groups using computer-generated randomization table. Group M received 30 mg per kg magnesium sulfate in 100 ml NS IV over 10 minutes before induction. Group E received 0.5 mg per kg esmolol diluted to 10 ml given over 60 seconds after induction. Heart rate, SBP, DBP, MAP was recorded at induction and every minute thereafter till 10 minutes after intubation. Any adverse effects was observed and treated.
with many other study. Earlier study by Norzima J et al. Who compared magnesium sulfate 40 mg per kg with esmolol 1 mg per kg in ASA 1 and 2 patients found that hemodynamic response was better attenuated with esmolol compared to magnesium sulfate. Another study by Sharma J et al. Who compared magnesium sulfate 40 mg per kg with esmolol 1.5 mg per kg also concluded that esmolol is more effective than magnesium sulfate. Our findings are also supported by another study by Urban K et al. In which magnesium sulfate 50 mg per kg compared with esmolol 2 mg per kg found that esmolol is a better agent than magnesium sulfate. Attenuation of hemodynamic response is better following laryngoscopy and intubation with esmolol compared to magnesium sulfate. These are my references. Thank you.
Hello.
Hello. Good afternoon, sir.
Actually, I couldn't hear anything from you. Sir, you have any question? You can ask, sir.
No,
Sir,
actually, there was no speech at all during the initial
yeah, I
talk.
couldn't hear anything, sir.
Anything. Can you just tell the conclusions of your study?
Sir, we have compared esmolol in a dose of 0.5 mg per kg and magnesium sulfate in a dose of 30 mg per kg for attenuation of intubation response, sir. We found that esmolol attenuated the intubation response better, sir. Especially the heart rate response was better attenuated with esmolol compared to magnesium sulfate. The blood pressure response was equally attenuated by both the drugs, sir. There was more incidence of tachycardia in the magnesium sulfate group, sir.
When did you give esmolol? What time?
Just after giving relaxant, sir, over 60 seconds, sir. We waited for 2 minutes before intubating, sir, before laryngoscopy.
What is the recommended dose of esmolol for
0.5 mg per kg up to 2 mg per kg has been used. 1 to 2 mg per kg has been used in various studies, sir. We have used the least dose possible and observed that it equally attenuates the response, sir, with lesser adverse effects.
Okay. Usually
And since it is a shorter acting,
for all.
I can't hear you, sir.
Yeah, that is the problem. Your voice breaks a lot. Hello.
Hello. Yes, sir.
Yeah, this was done on all the patients for oral intubation, isn't it?
Yes, sir. Orotracheal intubations.
Sir, if you have any question, you can ask, sir.
No, nothing.
Nothing. Okay, next.
Okay.
Okay.
Thank you. Thank you.
Thank you, sir.
Yeah.
Thank you, sir.
Yeah. Present next one.
Good morning, respected judges and audience. My topic of study is comparison of 0.75% of your versus 0.5% Eurocan with Ignocan and mixture in variable surgeries. Aim is to study the efficacy of comparison of 0.75% of your block, motor block, and hemodynamic changes, surgeon satisfaction, and post-operative analgesia. Secondary objectives include side effects or complications, if any. Introduction. Worldwide, there are 36 million cases of blindness and 270 million people with moderate to severe visual impairment. Cataract is one of the leading cause of blindness. An ideal anesthesia technique for ophthalmic surgeries should be easy to administer with minimal complications. Patients for cataract surgeries are usually elderly with multiple comorbidities. Peribral bar injection of local anesthetics are effective and safe technique for cataract surgery. Ropivacaine has low toxicity as compared to bupivacaine. Lignocaine and Hyleas enhance onset and quality of block. Methods include 100 patients of ASA 1 and 2 category undergoing small incision cataract surgery were recruited in this study. Group ropivacaine were given 4 ml of 0.75% ropivacaine with 2 ml of 2% lignocaine with 100 units of Hyleas. Group bupivacaine were given 4 ml of 0.5% bupivacaine and 2 ml of 2% lignocaine with 100 units of Hyleas. Study population patients coming for cataract surgery at our institute. Study period was June 2021 to September 21. Methods also include study design, randomized prospective comparative study approved by our institution ethics committee. Randomization was done with computer. A group allocation number was given in opaque envelope opened in OT. Study drug prepared and coded by anesthesiologists who were not involved in the study. Written and informed consent was taken. Inclusion criteria: ASA 1 and 2 status, age group from 40 to 60 years with both the sexes. Exclusion criteria was ASA 3 and above, patients with bleeding disorders, neuropathic disorders, patients who refuse to give consent, and uncooperative patients. Results were ropivacaine group showed slow onset of sensory and motor blockade compared to bupivacaine group. No significant differences of hemodynamic changes in both the groups. Postoperative analgesia and surgeon satisfaction were similar in both the groups. The demographic data was slightly different, but of not statistically significant. With respect to akinesia, the group B showed faster onset of motor block and also complete motor blockade faster compared to the ropivacaine group. And the hemodynamic changes with respect to these blocks were of not statistically significant. We compared the efficacy of 0.75% ropivacaine and 2% lignocaine with 0.5% bupivacaine and 2% lignocaine. The comparison focused on onset of action and quality of blockade and hemodynamic stability. The lignocaine bupivacaine mixture is currently used at our institute for peripheral blood block, combining the lignocaine's onset time and a long postoperative pain relief for bupivacaine. Both groups were considered similar with respect to demographic characteristics and basal levels of parameters evaluated before the block. There were no significant changes in heart rate, BP, or oxygen saturation. Minor changes which occurred were of any significant value. The time of onset and completion of sensory and motor block with 0.5% bupivacaine is faster, but ropivacaine takes longer time for the onset and also longer time for complete block. Conclusion: bupivacaine has faster onset of both sensory and motor blockade, but ropivacaine is less toxic and has a better safety margin. Surgeon satisfaction is same in both the groups. These are my references. Thank you. Good afternoon, sir.
Good afternoon. How much of the total volume you have given?
6 ml, sir. Yes, sir. 4 ml ropivacaine, bupivacaine, and 2 ml of lignocaine.
So, how did you say it is less toxic in your study?
Sir, there are studies which say ropivacaine is a safer drug compared to bupivacaine, sir, because it has a lesser side effects of. So, any accidental IV injection of drugs, there might be any accidental injection also. So keeping that in mind.
Were there any IV adverse effects in your patients?
No, sir, none, sir.
No. Okay. I don't do any blocks from ophthalmic side. Sir, if you have any question, you can ask.
No, nothing.
Okay, sir.
Nice,
okay, sir. Okay.
Thank you, sir.
Thank you so much, sir. Next presenter, please.
Hello everybody, my name is Dr. Nidhi Dubey, PG third year from SGRR Medical College, Dehradun. My topic is paper presentation. The Topic is ultrasound guided collar versus ilioinguinal iliohypogastric nerve block for postoperative pain using 0.25% ropivacaine with clonidine in pediatric patient undergoing inguinal scrotal surgeries, a comparative study. Pediatric patients have poor pain control. Postoperative pain management is of utmost concern. Inguinal scrotal surgeries is one of the procedure in the children and is associated with significant postoperative pain. Regional anesthesia provide excellent postoperative analgesia and attenuation to stress response in children and infants. Over the past decade, many study has demonstrated that USG guidance can significantly improve the quality of nerve block in almost all type of regional anesthesia. Aims and objective to evaluate and compare the efficacy of ultrasound guided caudal versus ilioinguinal nerve block for postoperative pain in pediatric population undergoing inguinal scrotal surgeries. To compare and study the postoperative pain and complication after caudal block and ilioinguinal iliohypogastric nerve block. Material and method. The proposed study was conducted in Department of Anesthesia and Intensive Care, SGRR, Dehradun, after obtaining hospital ethical committee permission and approved written informed consent from all the patient. A prospective randomized study was conducted in 40 pediatric patients undergoing inguinal scrotal surgeries under general anesthesia. Inclusion criteria was age 2 to 12 year, male, female, ASA grade 1 and 2, child weight 3 to 45 kg. Exclusion criteria: patient guardian refusal, weight less than 3 kg or more than 45, ASA grade 3 and 4, infection at the site of injection, and failure of the block, non-allergic to any drug. At the end of the surgery, children were randomly allotted in two groups by computer-generated random number table. It was a double-blinded study. Block was performed by anesthesiologist, and post-operative assessment was done by an assistant who was non-aware of the type of block. Group 1 received caudal block, which was injection with injection bupivacaine 0.25%, 1 ml per kg, and injection clonidine 1 mic per kg using 23 gauge needle. Group 2 received ilioinguinal nerve block with injection 0.25% ropivacaine 1 ml per kg, and injection clonidine 1 mic per kg using 23 gauge needle. Total number of 40 patients in two group of 20 each. Both the block were performed using ultrasound guided technique. Post-operative pain assessment was done after 30 minutes, 1 hour, 2, 4, 6, 12, and 24 hours. Post-operative motor block, it was assessed by motor power scale. Pain assessment was done by modified Hanan-Allah pain scale. The patient with pain score more than 4 were given paracetamol suppository 20 mg per kg as a rescue analgesia. This is the modified Hanan-Allah pain scale. This is the motor power scale. Now talking about the result, there was 27 male and 30 female among the study population. This is the chart for modified Hanan-Allah pain scale. The modified Hanan-Allah pain scale at 30 hour, 1 hour, 2 hour, 4 hour, 6, 8, 12, 24 was compared between two groups using the unpaired t-test. The modified the 30 minute, 1 hour, 2 hour was significantly more among group 2 as compared to group 1. This is the motor power scale. There was no any significant difference using the unpaired t-test. SpO2, again there was no any significant difference in mean SpO2 at baseline, post-induction, intraoperative or post-operative in both the group. Pulse rate, again there was no any significant difference by using the unpaired t-test. Systolic BP, again no significant difference intra-op, post-op or baseline. Diastolic BP, again no significant difference. Mean arterial, again no significant difference. So the conclusion is the current study demonstrated that caudal epidural block was more effective than ilioinguinal hypogastric nerve block among children undergoing unilateral inguinal scrotal surgeries. Caudal block carried the advantage of faster onset of action along longer duration of postoperative analgesia with no recorded complications. Thank you. These are the references.
Hello.
Hello, good afternoon, sir.
Yeah, good afternoon. They were undergoing unilateral surgery or bilateral surgery?
Sir, unilateral surgeries. Unilateral surgeries.
So you have given the block after surgery, is it? Before?
Yes, sir. We have given the block after the surgery. Yes, sir. Both for caudal and for ilioinguinal nerve block.
What is the reason? Like, usually we give at the start of the surgery, isn't it?
Yes, sir.
So that
actually,
general anesthesia, the GA requirements and all will reduce.
Yes, sir. After actually we want to see the duration. Most of the studies are, yes, you're right. Most of the studies are at the start of the surgery, but we want to check the duration of the length of post-op pain relief of the patient at the end of the surgery. So we have given, sir, at the end of the surgery.
For ilioinguinal block also you have given clonidine at the there only.
Yes, sir. Yes, sir. For ilioinguinal also.
Okay. So caudal is better.
Yes, sir. Caudal is better.
Actually, we all perform now this central neuroaxial blockade for post-op analgesia is going off the this thing. because they are associated with more complications.
Yes,
The
sir.
trend is towards giving more blocks. That's what we actually prefer
Yes, sir.
nowadays.
Sir, I had given ropivacaine and clonidine. So ropivacaine in comparison to yes, sir.
Yeah. No, just I am telling.
Okay.
Oh. So these were children between which age group?
From 2 year to 12 years, sir.
Okay.
Yes, sir.
Sir, any questions, sir?
Sir, you are muted again, sir.
Hello.
Hello.
Can you?
Good afternoon.
Good afternoon.
Sir. Good afternoon.
Is this the sole technique of anesthesia?
Yes,
Or
sir.
is it the sole technique of anesthesia, caudal and the ilioinguinal block, or you have supplemented with GA?
Sir, it is at the end of the surgery. At that time, I had given caudal and ilioinguinal nerve block. After the surgery, at the end of the surgery.
Initially, it was GA.
Yes, sir. Initially, it was GA.
Okay, nice. Okay, right.
Okay. Thank you, sir.
Okay. Thank you, Dr. Nidhi. Dr. Prashant, thank you. Dr. Srinivas, thank you. This is the end of the session 2. So now we are moving to session 3. Okay. And there's Dr. Ranjan and Dr. Devashish Swain. You can start the session.
Yeah.
Thank you, sir.
Thank you. Thank you very much.
Thank you, sir.
Hello.
Yeah, I'm Dr.
Hello,
Devashish
good
here. Good
Good
afternoon, I'm
afternoon,
Dr.
everyone.
Devashish from Odisha.
Yes, sir. Good afternoon, everyone. I'm Dr. Dhwani, Senior Resident in Anesthesiology Department, Rajkot ISA branch. I would like to welcome all our two chairperson, Dr. Ranjan sir and Dr. Debashish sir, and all our 15 participants. All are available, and I can see all joined here. So I would like to welcome our chairperson, and I would like to introduce. I would like to tell them to introduce themselves. Dr. Ranjan sir, can you introduce yourself, sir?
Good afternoon. First and foremost, wonderful conference. Thank you very much for this opportunity. My name is Ranjan. I'm a professor and head of the department, Pondicherry Institute of Medical Science. I'm taking care of the cardiac as well as the other parts of the anesthesia, and main interest is on cardiac and regional anesthesia. Thank you. I'll hand over our.
Okay, now I would like to tell Dr. Debashish sir to introduce themselves, sir.
Yes, good afternoon, all the participants, delegates, and the organizers. I am Dr. Devashish Swain. I am working as Associate Professor in SC Medical College, Cuttack. Currently, I am the head of the cardiac anesthesia unit in SC Medical College, and I am the ex-secretary, honorary secretary of Odisha State Chapter. So, I welcome all the participants to this presentation session, 1 to 3 p.m. college. Thank you.
Thank you so much, sir. And now we will start our presentation. The first presentator
Ranjan
is
sir,
Dr.
namaste.
Sir, good afternoon,
Ranjan
sir.
sir, namaste.
Good afternoon, Devashish sir. Good afternoon.
Yeah.
Okay, now we will start our presentation. First presentator is Dr. Nikita. Dr. Nikita.
Hello. Hello.
Yes, Dr. Nikita, start.
You are audible.
Hello, ma'am. Am I audible?
Yeah,
yes,
audible.
madam. Start.
Okay, sir.
Hello everyone, myself Dr. Nikita. My study topic is predicting difficult airway by evaluation of maximum contact radius distance without exposing upper respiratory tract in patients undergoing surgery with endotracheal intubation under general anesthesia. Unanticipated difficult airway is a potentially life-threatening event which is associated with mortality and morbidity. Predictive tests are conducted during preoperative evaluation with the aim of establishing safe strategies. However, none of the predictors used so far are accurate and reliable in identifying the difficult airway. And these routine investigation requires patient to remove his or her mask before opening the mouth while examined by the anesthesiologist, which undoubtedly increases the risk of nosocomial infection. So it is necessary to find new methods. Contact triggers maximum distance can be used for preoperative airway assessment, but the predictive value of CTMD remains unknown. The objective of the study is comparison of different tests to predict difficult laryngoscopy and calculating predictive value for CTMD. Source of data are patients undergoing elective surgery with endotracheal intubation under general anesthesia in hospitals attached to BMCRI. And sample size was calculated based on the previous study by Howe Wu et al. And it is 80 patients. Patients who are willing to participate in the study aged between 18 to 60 years are included, and patients who are not willing to participate in the study and who are edentulous or with facial-maxillary injuries are excluded. After obtaining informed written consent, patients fulfilling inclusion criteria were enrolled, and during preoperative examination, patient was made to sit upright, and the examiner used the index finger of both hands to locate the condyle of the mandible and instructed the patient to open mouth as wide as possible and evaluated whether the distance between the condyle and tragus could accommodate the width of one finger. Later, another anesthesiologist who was not aware of the evaluation results of CTMD measured other relevant indicators. Cormack-Leone classification was used to grade laryngoscopic exposure. The time of intubation and number of attempts to intubate are noted. Ease of intubation and CL grading are the assessment tools, and time of intubation and number of attempts to intubate are the outcome measures. Data was analyzed by descriptive statistics such as mean, standard deviation, percentage tables, and graphs. This is a graphical representation of comparison of ease of intubation predicted by all the other tests and time of intubation in seconds, number of attempts to intubate, and sensitivity, specificity, positive predictive value and negative predictive value of different tests. When compared to Mallampati grading, CTMD has more specificity and negative predictive value. Specificity is same as that of IID and negative predictive value is more in CTMD. And sensitivity, specificity and negative predictive value is more in CTMD when compared to ULBT. The evaluation of maximum contact tragus distance can predict difficult airway management without exposing upper respiratory tract. A prospective observational study done by Howe Wu et al. And the study findings were compared to IID, Mallampati classification, and ULBT. CTMD has higher value in predicting difficult laryngoscopy, which correlates with our study. And predicting value of upper lip bite test and ratio of height to thyromental distance compared to other multivariate airway assessment tests for difficult laryngoscopy in apparently normal patients by Pratibha Jain Shah. Study findings were ULBT is the best predictive test for difficult laryngoscopy in apparently normal patients, whereas in our study, the sensitivity, specificity, and negative predictive value is more in CTMD when compared to ULBT. In conclusion, CTMD evaluation can be used as an alternative to other tests for predicting difficult airway without exposing upper respiratory tract to the environment, which is safe considering the present pandemic situation. These are my references. Thank you.
Thank you, Dr. Nikita. Now I would like to request our chairperson to ask questions if they have any.
Dr. Nikita, you are there?
Yes, sir. Good afternoon, sir.
Good study, Dr. Nikita. What are the
Thank you,
inclusion
sir.
criteria? You had any obese patients, BMI more patients, or any difficult airway? Apparently looking difficult airway patients
Yes,
were
sir.
also
We
used.
included everyone, sir. Yes, sir. We included everyone because we wanted to test the difficult airway in all the patients, sir. Predicting the difficult airway in all the patients.
What was the correlation between Mallampati 4 and CT angle of more than 1?
Sir, in our study, about 3 patients were, no, sir, Mallampati has more specificity, sir. But in our study, it has 98% of specificity when compared to Mallampati. It is about 81% in Mallampati, sir.
So you use basically Mallampati, Cormack-Leone grading, upper bite lip test, right?
Upper lip bite test, interincisor distance, and CTMD, sir.
Okay. Good. So, Dr. Devashish, sir.
Yeah, good study. You have included all the adult patients only? Or
Yes, sir.
the patients are all adult patients. So there will be in many
Yes, sir.
situations,
Above
there
18
will be,
years.
yeah, so in many situations, there will be like loose teeth or damaged maxillary aperture. So in that, those patients are
We have
included.
excluded such patients, sir.
Right.
We
So
have
you need to
excluded
exclude
such
those.
patients, sir,
Yeah.
because it will be error.
Yes. So you have to exclude those patients where you are expecting error from the study. Yeah. Thank you.
Nikita,
Next.
Yeah, Nikita, one advice. When
Yes,
you're making a PowerPoint, do not make paragraphs in your PowerPoint. Write line, not more than 6 lines.
Yes,
Okay.
correct.
Okay.
Correct.
Okay, sir.
It will help you when you become a teacher or
Yeah, when you are
when you start.
presenting in a when you are presenting in a national level competitions and or even presentation also, we have standard guidelines for that.
True.
Okay, sir.
Since
Okay,
you
thank you,
belong
sir.
to the college which I studied, and you are sitting in a place where I did my MD, so this is advice from me. Take it.
Okay, sir. Thank you so much.
Thank you. Next one, please.
Thank you, Dr. Nikita. Now, next presentation will be done by Dr. Rajni. Dr. Rajni.
Comparison between Dexmed and midazolam during mechanical ventilation for post-operative patients. Coming to introduction, as we know, sedation is very much required to reduce the anxiety and improve outcome in ICU patients. Optimum sedation is vital in striking a balance between providing pain relief and maintaining patient calm. Traditionally, benzodiazepine like midazolam were used for ICU sedation. Dexmed has been studied as an alternative to benzodiazepines for sedation in ICU. Midazolam is a fast-acting benzodiazepine with a short elimination half-life. It has anxiolytic, amnestic, hypnotic properties and has been used for sedation. Dexmed is centrally acting alpha-2 agonist with sedative and analgesic properties. It has demonstrated efficacy in managing pain, agitation, and delirium in variety of ICU patients. The main objective of the study is to determine the efficacy of Dexmed and midazolam in maintaining sedation, reducing the ICU stay to compare the hemodynamic parameters. Ethical committee approval was taken for the study. Consent taken from the patients attended. It is a prospective randomized control study done at Chigiteri Hospital, Davangere. It was done from April to June 2021. Post-operative patients shifted to ICU for mechanical ventilator support by the study population. Exclusion criteria were ASA grade 3 or more, age less than 18 years and more than 85 years, allergic to study drugs and surgeries done under combined GA and epidural anesthesia. Coming to the methods, patients were randomly divided into two groups. Group D received Dexmed and a loading dose of 1 microgram per kg for 10 minutes and maintenance dose of 0.4 microgram per kg per hour. Group M received midazolam, a loading dose of 0.05 mg per kg and a maintenance dose of 0.1 milligram per kg per hour. Infusion were titrated hourly to maintain Ramsey scale of 3. Sedation continued for 24 hours after the admission to ICU. Visual analog score was recorded hourly and additional fentanyl at 2 microgram per kg was given if it was more than 5. Hourly heart rate, SBP, DBP, and mean arterial pressure were recorded. Duration of the ICU stay was noted. Standard criteria were followed for weaning from ventilator, extubation, and discharge from the ICU. Categorical data was represented in the form of frequency association between variables were assessed with chi-square test. Quantitative data was represented using mean and standard deviation. Analysis of the quantitative data was done using unpaired t-test. P-value of less than 0.05 was considered statistically significant. Statistical analysis was done using IBM SPSS version 22 for Windows. Coming to the result, there was no statistically significant difference between the two groups with respect to age and weight of the patients. There was a statistically significant difference in heart rate and mean arterial pressure between the two groups, with decrease in heart rate and mean arterial pressure more in group D than in group M. There is no significant difference between two groups in terms of duration of ICU stay, although the group D patients showed early extubation after stopping the sedation. There is significant difference in the additional requirement of analgesia between the two groups, with group D requiring less analgesia compared to the group D.
Coming to the discussion, a previous systemic study review demonstrated that sedation with the dexmed was associated with a lower 28 days mortality rate than sedation with other agents in patients with sepsis. That was done by Zamani et al. In 2016. In another recent study, the use of dexmedetomidine for light sedation in patients undergoing mechanical ventilation was associated with a similar 90 days mortality rate at the use of midazolam, propofol, or other sedatives, done by Shahabi et al. In 2019. Coming to conclusion, dexmedetomidine sedation reduces the need of analgesia in postoperative patients. Dexmedetomidine produces better hemodynamic stability compared to midazolam in postoperative patients. There is no significant difference in duration of ICU stay between patients sedated with midazolam and dexmedetomidine. Thank you.
Thank you, Dr. Rajini. Rajini, you are there?
Yes, sir.
Hello.
Hello.
Dr. Rajini. Yeah, Dr. Rajini. ICU is a broad term. What type of ICU you are using? Post-op ICU, medical ICU, neuro ICU? What type of patients were used?
Post-op ICU, sir.
Post-op ICU.
Yes, sir. Yes.
Okay. Immediately post-surgery, you are taking them there.
Yes, sir.
Okay. And your statement, which started with midazolam is the most commonly used sedation, which is, I don't agree with you. Midazolam is not the most commonly used continuous infusion sedation postoperatively. Then you are comparing two groups where you are trying to assess the post-op analgesia also. Midazolam doesn't have an analgesic property. And how are you comparing dexmedetomidine and midazolam in terms of analgesia? If you had used a fentanyl versus dexmedetomidine, probably okay, I would have said okay, analgesic effect. But midazolam and telling that dexmedetomidine is better in controlling the pain compared to midazolam is already proven. There is nothing to be proved, right? So,
yes.
Little falsies in the studies, yeah. And how many maximum hours where sedation was used?
Sir?
Maximum number of hours, sedation hours were used?
Up to 24 to 48 hours was used.
Okay. So the problem with dexmedetomidine, we don't have FDA approval to use for more than 24 hours continuous infusion in ICU. Okay. Off-label, we are using it many places. It's a good drug, but probably if you had compared fentanyl with dexmedetomidine, I would have been happy. Comparing midazolam with dexmedetomidine is you're comparing apple with the orange, right? So Dr. Debashish, sir.
Yes, sir. You are correct. Actually, midazolam, normally no one correct. You have to compare. Normally, we do not compare midazolam with dexmedetomidine because, and you are telling about analgesic property. Midazolam, there is no analgesic property in midazolam. So how can we compare that? So that is the issue. Another thing, age you have written 85 years. I think age range you have taken little long. I think something 60, around 60 patients you should have selected. 85, those patients beyond 60, I think they have other issues. So when you are comparing, many of those patients will be in trouble when you are using drugs for the study purpose.
Okay.
And as we have discussed with the previous presenter Nikita, then in discussion also you are using paragraphs. You should use points. You should not use such long paragraphs. Otherwise, you have to rectify a few things in this study. Thank you.
Thank you.
Okay, thank you, Dr. Rajni. Now, next presenter will be Dr. Ravi Kumar. Dr. Ravi Kumar?
Yes, ma'am. Good morning. I am presenting e-paper on serum magnesium and perioperative pulmonary functions in adult surgical patients. Magnesium is an essential element for life. It is involved in the activation of hundreds of enzyme systems in the body. It is used in the pre-eclampsia, depression, arrhythmia, convulsions, tetanus, but its significance as a drug has only been recognized recently. A prospective observational study was carried out on 120 adult surgical patients in ASA grade 1 and 2. Clearance for the study was carried out from the Institutional Ethical Committee. Aim of the study is to correlate the perioperative changes in the serum magnesium levels with the PFTs. Patients explained the spirometry. Best of the three readings were noted PFT and electrolytes were done at 2 intervals, pre-operative and post-operative. Day 1, GA was provided as a standard protocol with routine standard of care and monitoring. CTRA registration was done for the study. Observation. PFT parameters and pulmonary diagnosis. PFT parameters were noted and pulmonary diagnosis was made. Intraoperatively, note of the adverse hemodynamic and respiratory events were noted. Post-operatively, patients were kept under observation for 24 hours. Analysis. Statistical analysis was done using the SPSS version computerically. Serum magnesium levels. Pre-operatives in 85% patients, serum magnesium levels were in the normal range. In 6.6%, they were decreased, and in 8.3% patients, they were in the elevated. Post-operatively, 70% patients were having serum magnesium in the normal range, and 30% patients having serum magnesium decrease. Pulmonary diagnosis based on the PFT. Pre-operatively, normal PFT was present in the 66.7% patients, deranged PFT in 33.3%, among which restrictive pattern was in 85%. Post-operatively, deranged PFT was in 73.3%, among which restrictive pattern was in 92% patients. Pre-operative serum magnesium levels and PFT diagnosis. Mean serum magnesium levels in pre-operative period were 2.34 mg per deciliter and post-operatively 1.99 mg per deciliter. Post-operative serum magnesium levels and PFT diagnosis. Magnesium and PFT diagnosis pre-operative versus post-operative. Pre-operatively, PFT was normal in 80 patients, abnormal in 40, and restrictive pattern was present in 34. Magnesium was normal in 85%, low in 6.6, and high in 8.4% patients. Similarly, post-operatively, deranged PFT was present in 88, and restrictive pattern was present in 81. Normal magnesium was present in 7. And decrease in 30%. Use of the magnesium is beneficial in terms of the requirement of drugs, anesthetic, analgesic results, and better post-operative respiratory outcome. Continuous exposure to the environmental pollutants harmful. Magnesium was decreased in the more patients in 30%, and PFT derangement was in more patients, that is in 73% patients. Among those with the abnormal PFT, restrictive pattern in 85% patients in pre-operative and 92% patients in the post-operative. PFT and serum electrolytes both were decreased in a greater number of patients in the post-operative period. In patients with low magnesium, PFT was abnormal in 77.8% and restrictive pattern was common. Commonest derangement was restrictive type. Our impression is that these results are significant because the patients were ASA 1 and 2 undergoing elective surgeries. Results may be very significant in ASA 3, 4, and emergency surgery or GI surgery exclusively. References. Thank you.
Dr. Ravi, are you there?
Yes, sir.
Unfortunately, there was some technical lag. We couldn't hear properly.
Yes, sir.
I didn't understand your study. Can you tell me just in 30 seconds what exactly was your study?
Sir, we conducted the serum magnesium levels pre-operatively.
In all patients?
In all ASA 1 and 2 patients undergoing the general surgery and gynecological surgeries.
Okay.
And we did the PFT pre-operatively at the time of doing the PAC 24 hours before the surgery. And then general anesthesia was given as per the routine protocols. And then after 24 hours after the surgery, we again did the serum magnesium levels and PFT. And then we assessed the serum magnesium correlation between the serum magnesium and PFT levels. As serum magnesium is a bronchodilator, and because of anti-calcium actions, it affects the pulmonary functions. So we try to correlate the correlation between the serum magnesium and pulmonary functions, basically.
Okay. So what was your conclusion? What did you say? Most of the patient had magnesium deficiency?
Yes, sir. Sir, post-operatively, serum magnesium was decreased in most of the patients, and PFT was deranged. And in the patients in which the serum magnesium was low, comparatively the major pattern was restrictive type, contrary to the belief that COPD pattern we were assuming. But
what was the incidence of low magnesium in your patient? How many patients you assessed? How many patients had low magnesium?
Sir, we have taken 120 patients in our study, and out of that, post-operatively, serum magnesium was low in 30% of patients.
30% of patients.
Yes, sir. And pre-operatively, it was low in the 6.6% patients only. And PFT were abnormal in 73% patients post-operatively compared to 33.3% patients pre-operatively. And sir, abnormal PFT were seen in 77.8% patients in which the magnesium was low.
Okay, fine. I mean, I would have gone through your article more. It's a new study, but there are so many questions, but with the time limit, it is difficult. I'll ask Dr. Debashis to have some input on this.
Yeah, Ravi, how the outcome is going to be improved with your study?
So outcome, if we assess the serum magnesium levels pre-operatively, we can supplement these patients with serum magnesium levels, and this serum magnesium levels and supplementation of serum magnesium can have roles with the improvement in the post-operative pulmonary functions. This was the main outcome that
then how we are going to do the pulmonary function test in a post-operative care room?
Sir, we were using a handheld spirometer, and we were doing the PFT with the spirometer, which was provided to me by my department of anesthesia, by my guides also.
Okay, and how you give magnesium for all these patients?
Sir, actually, in the study which I conducted, we did not give the serum magnesium. We just only assessed the serum magnesium. But this I am advising we can conduct the further studies, and there we can give the serum magnesium in which there is a deficiency, and that
so you have not used post-op serum magnesium for any patient, any of your patients?
No, sir, we have not given serum magnesium. We have only done the observational study.
We need scientific literatures to support this type of therapy in future.
Yes, sir. Yes, sir. There are literatures which suggest that there are changes in the post-operative pulmonary functions in the laparoscopic surgery, and there are many literatures which suggest that there are decrease in serum magnesium post-operatively. But there are very few literature which give the correlation between them, and we try to correlate the serum magnesium and pulmonary functions.
Okay, fine. Well, sir. Thank you.
Yes, sir. Welcome, sir.
Thank you, Dr. Ranjan sir and Debashis sir. Next presentation will be by Dr. Sahana Patil.
I'm here to present my paper on the comparison of Pasca mask with Prosil LMA in adults under controlled ventilation. With the introduction of classic LMA by Archibald in 1988, brought paradigm shift in the management of airway under general anesthesia. The Pasca mask is one such new innovation and a recent addition to the family of supraglottic airways with salient features like self-sealing membranous non-inflatable cuff that seals and opposes the glottis with increasing airway pressure. Large distal aperture located at the upper end of the esophagus, which opens into a sump cavity that is drained by two drainage tubes, allowing for rapid clearance of the gastric fluid. A tab for manually curving the mask to facilitate easy insertion. OSP is an important parameter for evaluation of clinical performance of supraglottic airway devices and controlled ventilation. There is literature to compare the effectiveness of these two devices. Hence, in this study, we intend to compare the devices in terms of OSP. These are the salient features marked. The primary objective of the study is to compare the oropharyngeal sealing pressure of Pasca mask and PLMA. The secondary is to compare success rate, insertion time, ease of insertion, and fiber optic laryngeal view of Pasca mask and PLMA. There were 68 subjects in the study, with inclusion criteria being 20 to 60 years of age, duration less than of surgery less than 2, BMI less than 30 kg per centimeter meter square, inter-incision gap more than 2.5 centimeter. Exclusion criteria being anticipated difficult area, risk of aspiration at gastric contents, head and neck surgery, surgery in non-supine position. Adults of Pfizer gender age 20 to 60 years were randomly assigned either Pasca group or PLMA group. After return in informed consent, pre-medication and induction of anesthesia, appropriate size supraglottic airways was inserted. The cuff of the PLMA was inflated using cuff pressure monitors to 60 centimeters of water. The appropriate device was selected based on manufacturer's recommendation. Oropharyngeal sealing pressure was measured with head in neutral position under manual ventilation by closing the expiratory valve of the circle system ventilation at a fixed gas flow of 3 liters per minute. The airway pressure was measured on pressure gauge of breathing system at the ceiling pressure, and ceiling pressure is the plateau pressure that was achieved. After the OSP measurement, a flexible fiber optic scope was passed through the airway tube, and the visualization of glottis was scored accordingly. While placing the device, maneuvers that were used were movement of the device upward or downwards, jaw lift, jaw thrust, head extension, and neck flexion. Ease of placement was graded as very easy, no maneuver used; easy, one maneuver used; difficult, more than one maneuver used. Any complications were noted post-operative. 68 patients were studied with 34 in age group. There was no significant difference with regard to age, BMI, ASA grading, and gender distribution. The mean insertion time was significantly higher with PLMA group compared to BASCA group. We found that most of our patients had single attempt in PLMA, but one patient had 2 attempts in BASCA group. OSP had no statistical significant difference in both the groups. There was one failed insertion in group B. Fiber optic view was better with group B. Complications were similar compared in both the groups. In Anil Kumar's study, 100 adults were observed undergoing short duration elective surgeries under general anesthesia. The mean time for device insertion was 9.7, and the OSP was 42.46, and leak fraction was 80.81%. They concluded that BASCA is an effective supraglottic device which is easy to insert, providing good ventilation and has minimal complications. Similarly, Alravai SAS et al. Concluded that BASCA takes significantly shorter time for placement and gives better ceiling pressure. In this study, I conclude that BASCA is another step forward in the world of supraglottic airways, which needs lesser time for insertion, providing good ceiling compared to Procil LMA. Thank you. These are my references.
Dr. Sahana? Dr. Sahana? You're muted. Can you unmute yourself, please?
Good afternoon, sir.
Yeah, good afternoon. Sana, did you use relaxant to introduce, or without relaxant it was introduced?
With the relaxant, sir.
Huh?
With the relaxant, sir.
With the relaxant?
Yeah.
Good. And you found BASCA insertion was easier compared to Procil LMA?
Yes, sir.
How was Procil LMA introduced?
Digital method only.
Digital, not the introducer?
No, sir.
Do you think if you had used an introducer, your observation would have been different?
Probably, sir. Probably it might have.
Why you didn't use introducer? Again, you are muted.
Sorry, sir.
Procil LMA, you are supposed to use an introducer or a bougie to introduce. Why did you use digital method? It's a flexometallic sort of tube. So
yes,
it will be little difficult using a digital method. Obviously, you will find it difficult to introduce.
The comparison between the two equipments would be deceived then, because I'm not using anything for the BASCA mask.
No, BASCA mask is a rigid tube.
Yes.
Procil LMA is a flexometallic tube. So obviously there is the instrument itself is a different one. So Procil LMA, the best way to introduce is using an introducer. And you abolished that, and now you are saying BASCA is easier to introduce compared to Procil LMA.
Yes.
BASCA size is bigger compared to the Procil LMA. It has been found now that BASCA introducing is difficult among all the supraglottic airway devices.
So there are some studies which shows BASCA introduction is easier compared to PLMA.
Good.
But what you found in your study, I think if you are not following the standard protocol, even if it is a scientific study, then you are likely to cause some damage to the patient also.
So
is not it? For your study, it should be as per the protocol. For the study, you should not be like, because I am doing the study, so I'll do like that. So yes, in that way, you'll be causing harm to this patient.
Yes, sir.
So your study should include such techniques which are approved, with approved standards of technique, right?
Yes, sir.
So what sir has pointed out correctly, you should always use a introducer. Otherwise, Procil is very difficult to put.
Yes.
Right. Okay. Thank you.
Thank you.
Thank you, sir. Next presentation will be by Dr. Sai Krishna Prasad.
Comparison of hemodynamic stress response to McCoy and McIntosh laryngoscope. Principal author Dr. Sai Krishna Prasad R. Co-author guide Dr. Vijay Kumar. Introduction. Laryngoscope and trachea intubation leads to hemodynamic stress response by stimulation of sympathetic nervous system, exposing the patient to detrimental effects such as arrhythmia, systemic hypertension, and increased intracranial pressure. Since the introduction in 1940, the McIntosh laryngoscope has been the gold standard for trachea intubation. The McCoy laryngoscope, a modification of the McIntosh, is later than introduced for the intubation or when limited cervical spine movement is required. Aim to study the hemodynamic stress response to McCoy and McIntosh laryngoscope at first minute, third minute, fifth minute post intubation, and also record the mean time of intubation at both laryngoscopes. The inclusion and exclusion criteria. The exclusion criteria are patient with morbid obesity, pregnant patients, patients with diabetes mellitus, patients on hypertension, patients with coronary disease, and patients on beta blocker therapy. Incision ethical committee clearance is taken. The study was conducted 70 ASA grade 1 patients between the age of 20 to 50. They are divided into two groups of 35 each, group A and group B. Group A is McIntosh, group B McCoy. A written informed consent was taken. PAC was done on the day before surgery. Patient was pre-medicated with injection glycopyrrolate 0.2 mg, ondansetron, and midazolam, and induced with propofol 2 mg per kg, fentanyl 1 microgram per kg, and mectronium 0.1 mg per kg. Pulse rate, systolic blood pressure, diastolic blood pressure, mean arterial pressure, EC changes, and SpO2 were monitored pre-induction and post-induction, first minute, third minute, and mean time of intubation was also recorded. Research. The pulse rate in the McIntosh group, that is group A, was significantly higher when compared to McCoy group, that is group B, at first minute, third minute, fifth minute post intubation, as seen from the graph and the table. The systolic blood pressure was also higher in the McIntosh group, that is group A, at post intubation, first minute, third minute, fifth minute, and statistically significant with p-value less than 0.05. The mean arterial pressure in the McIntosh group post 1 minute intubation was 103.3 with standard deviation of 4.8, 101.6 with standard deviation of 4.8 at post intubation third minute, and 99.5 with a standard deviation of 4.9 at post intubation fifth minute. This was significantly higher when compared to the McCoy group, and it was statistically significant with p-value less than 0.05. The mean time of intubation was higher in the group A McIntosh group, 16.7 seconds, and it was 14.5 seconds in McCoy group. There are various techniques to blunt the hemodynamic stress response to intubation. The use of topical anesthesia, deep brain of anesthesia, calcium blockers, OPRs, beta blockers, LMA have been tried to varying extent. In our study, heart rate post intubation with McIntosh rate was significantly higher at first minute, third minute, fifth minute, which was also seen in a study conducted with Tiwari et al., in which there was significant rise in heart rate and BP post intubation. Fedra et al. Showed that there was significant rise in heart rate and BP at 2 months post intubation, and McIntosh rate was used for intubation. Agarwal et al. Conducted a study to compare the hemodynamic stress response to trachea intubation of McIntosh, McCoy, and CMACT video laryngoscope, and reported that the rise in diastolic BP was 13.6 seconds in McIntosh group, 6.88% in the McCoy group. Our study had similar results with 11.6% rise in diastolic BP in McIntosh group and 7.4% increase in McCoy group. The mean arterial pressure increase in study was found with 31% in McIntosh group and 9% in the McCoy group. Agarwal et al. Reported 12.94% increase in the McIntosh group and 6.12% in the McCoy group. The mean time of intubation with McCoy group was found to be 14.5 seconds and 16.5 seconds in McIntosh group. Agarwal et al. Reported a mean time of intubation of 15.53 seconds with McIntosh laryngoscope and 18.64 seconds in McCoy group. There were no significant episodes of desaturation defect in both groups, and there were no arrhythmias in both groups in the post-intubation period. Conclusion: the hemodynamic stress response is more than McIntosh laryngoscope is just. There is 21% increase in heart rate in McIntosh group as compared to 14% in McCoy group. Systolic blood pressure in McIntosh group 15.1%, and in the McCoy group was 8%. And rise in diastolic BP was 13.6%, and the McIntosh group was 6.8% in the McCoy group. The increase in mean arterial pressure in the McIntosh group was 13.1% and 8% in the McCoy group, signifying the increase to be more in the McIntosh group. These are my references. Thank you.
Dr. Sai, you are there? Yeah, hi. You're muted. You unmute yourself.
Can you hear me, sir? Sir,
Yeah,
can you
yeah.
hear me?
Yeah, Dr. Sai, I can hear you. See, it's already been tested and tried McIntosh, McCoy, and it's been proved. What was the intubation suppressing drugs you used? Laryngoscopic suppression drugs?
We didn't use any suppressing drugs, 7 mg per kg. Like, we didn't want to suppress the hemodynamic stress response. We're just seeing how much it is going to be with the
You got ethical clearance for that. Without suppressing the laryngoscope, you did a laryngoscope. No? it is ethically, it's an unethical to do a laryngoscope without suppressing. You didn't use fentanyl, you didn't use lignocaine, esmolol, anything. You just use glycopyrrolate and some
Fentanyl
intubation.
1 microgram per kg, sir. It
Which
is an analgesic dose, but not at a. Fentanyl is used 1 microgram per kg at an analgesic dose, but not at a. Stress response.
Was these things were difficult airway cases or regular
No, sir.
airway?
It
Normal
was
airway?
ASA grade 1 and 2, sir. Non-difficult airways, sir, all cases.
So the use of bougie, use of stillet is more with McCoy because you are lifting the epiglottis or lifting the tongue and doing it. So the angle changes. So the laryngoscopic response actually will be more in the McCoy. You're a postgraduate, Sai?
Sir.
Your PowerPoint slides needs to be changed. When the postgraduate, you need to have a white background with a black letter. Fancy looks good. When you're doing a local presentation, it is good. When you're doing a national presentation, keep a white background, black letter, not paragraph. You have written a textbook in your thesis. So, Dr. Devashish.
The same thing, sir. I was about to tell him that some type of presentation should not be accepted at national level. The way you have prepared the slides, so you rectify all those slides, and there is nothing new in this study, and should have been done more professionally. Thank you.
Thank you, sir. Next presentation will be by Dr. Samir Kangle.
Good afternoon, everyone. This is Dr. Samir Kangle from Mumbai. My topic is analysis of analgesic effect of USG guided thoracic truncal versus thoracic paravertebral versus ESP block in breast oncosurgeries. Opioids, NSAIDs, and regional anesthesia with thoracic epidural or paravertebral block are commonly used techniques, whereas techniques such as PEX block, ESP block have become popular with better safety profile and comparable pain relief. So we compared USG guided thoracic truncal, TPUV, and ESP block for intraoperative and postoperative analgesia. The study design was prospective randomized double blind, 75 females ASA1 and ASA2, 25 patients in each group. Opioid-free general anesthesia with injection midazolam, propofol, and proceed element without muscle relaxation was given to the patient. Maintenance was done with sevoflurane to maintain MAC1 and maintain entropy between 40 to 60. Multimodal analgesia included paracetamol, Maxalfa, and dexamethasone. These are the USG guided blocks, which is given in supine position. Group 2 is TPUV, Group 3 is ESP block, which are given in lateral position at T5 and T4 level respectively. Each of the block was given 25 ml of total local anesthetic. We compared intraoperative hemodynamic, sevoflurane, and fentanyl consumption, postoperative VAS, and need for rescue analgesia. Patients with VAS more than 3 received rescue analgesia, that is 1 gram paracetamol. Demographically, all the patients were comparable except for the height. Hemodynamic parameters: no increase in heart rate, systolic BP, or diastolic BP at incision. Systolic BP and diastolic BP was low in thoracic paravertebral group subsequently, which required treatment with ephedrine, which was given at 6 mg aliquots. MAC, sevoflurane consumption, and sevoflurane consumption rate was significantly low in thoracic paravertebral group. Consumption of intraoperative fentanyl was comparable between all the 3 groups in our study. Fentanyl consumption, 3 patients in thoracic truncal, whereas in TPUV and ESP, 4 out of 25 required fentanyl. All the 3 groups were comparable in terms of post-op VAS rescue analgesia requirement, but only 3 patients in TPUV had VAS more than 3 as compared to 6 patients in TP and ESP group. No literature mentioning use of regional anesthesia technique to provide intraoperative analgesia with opioid-free multimodal analgesia. In our study, hemodynamic parameters, intraoperative sevoflurane, and fentanyl consumption suggestive of adequate analgesic effect of blocks to surgical stimulus as a part of multimodal analgesia. TPUV can unilaterally cause both somatic and sympathetic nerve block. Hypotension in TPUV group of our study could be due to positional spread of local anesthesia, leading to bilateral sympathetic blockade. Hemodynamics and entropy levels helped us lower MAC and reduce sevoflurane consumption in thoracic paravertebral group. Other studies their post-op analgesia is PEX more as compared to ESP and TPVP, whereas in our study, thoracic paravertebral provided more relief as compared to TT and ESP group. We conclude that regional anesthesia in the form of thoracic truncal, thoracic paravertebral and ESP block should be used as a part of multimodal analgesia. All the three blocks provide good surgical anesthesia and analgesia. Thoracic paravertebral results in significantly lower MAC requirement and reduced total sevoflurane consumption and consumption rate. These are my references. Thank you, everyone.
Dr. Samir.
Good afternoon, sir.
Hi, good afternoon. What was the type of surgery? MRM was done or
Sir, MRM as well as breast conservative surgery, BCS
with
and
axillary
MRM.
clearance?
Yes, with axillary clearance.
And you had inserted ProSeal for all those cases?
Yes, for all the cases we inserted ProSeal LMA without any muscle relaxant.
Total duration of surgery?
Total duration of surgery was around 180 minutes for all the three blocks. Mean duration of surgery.
In 3 hours, you kept them in spontaneous ventilation?
No, sir, not spontaneous. We kept them on mechanical ventilation.
Relaxed and with the blocks?
With the block.
Thank you. Dr. Devashish, please.
Yeah. Yes. Was there any benefit during the post-op period?
Post-operatively, we have given paracetamol as a rescue analgesia if the patient had VAS more than 3. But as we have said that in thoracic paravertebral group, only 3 patients out of 25 required rescue analgesia within 24 hours as compared to other groups. Although it was not statistically significant, but out of 25, only 3 patients in thoracic paravertebral required rescue analgesia. Also, they required less amount of fentanyl intraoperatively as compared to thoracic truncal and ESP blocks.
Okay, and you kept on monitoring for how many hours post-operatively?
Post-operatively or?
Yeah.
Post-operatively, we monitored for VAS score and post-op complications such as nausea vomiting for 24 hours. So we monitored the patient for 24 hours for pain relief.
Okay, and they didn't require anything, only you continued with your NSH group. You didn't give any opioid group drugs during the post-op period.
No, sir, we have not given any intraoperative opioids or induction. We have given SOS if the patient's BP or heart rate increased more than 20% as compared to his baseline. That was considered as the need to give the intraoperatively pain relief. So at that time, we have given 2 mics per kg fentanyl to the patient intraoperatively.
Okay, thank you.
Thank you.
Thank you.
Thank you. Next presenter, please.
Dr. Devashish.
Thank you, Dr. Samir.
Thank you.
Yes, sir.
Yeah, you take the questions first. I'll take the question later, next set. I'll only interfere.
No, not an issue, sir. You carry on, sir.
Okay. Next presentation.
Okay, thank you. Next presenter is Dr. Samira Halima. Dr. Samira?
Yes, sir.
It was interesting.
Because of intraperitoneally instilled bupivacaine versus hydrocortisone in laparoscopic hysterectomy for postoperative pain. Laparoscopic hysterectomy can lead to pain due to abdominal incision, pneumoperitoneum, and the tissue injuries. Intraperitoneal instillation of drugs can be used for effective analgesia. Primary objective was to evaluate the efficacy of intraperitoneal instillation of bupivacaine versus hydrocortisone in these patients for post-op analgesia. The secondary objectives were to see post-op analgesic requirements, frequency of nausea, vomiting, and time taken for static unassisted ambulation. It was a prospective randomized comparative study. ASA 1 and 2 female patients undergoing laparoscopic hysterectomy under general anesthesia aged between 30 to 60 years were included in the study. These were the exclusion criteria. The patient and the surgeon instilling the intraperitoneal drug were blinded. The sample size was estimated to be 19 in each group. After explaining the procedure and taking consent, the patients were divided into Group A and B. Group A received 100 mg of hydrocortisone into 50 ml saline into the peritoneum, whereas Group B received 100 mg of bupivacaine into 50 ml saline. After induction and intubation, the patients received IV paracetamol after incision, 1 gram, and before the insufflation of carbon dioxide to create pneumoperitoneum, the intraperitoneal drug was instilled, and the patients were placed in Trendelenburg, anti-Trendelenburg, left and right lateral tilted position and supine position for 2 minutes each. At the end of the procedure, the both sides were infiltrated with local anesthetic. The duration of effective analgesia was time taken from time of extubation to request of first rescue analgesia. It was given with injection tramadol 50 mg slow IV. The data was entered into Microsoft Excel datasheet. Chi-square test and independent t-test were used as test of significance. A p-value of less than 0.05 was considered statistically significant. The difference of ASI distribution and weight and duration of surgery in minutes between the two groups were statistically not significant. The mean time for request of rescue analgesia in Group A was 185 minutes and Group B was 321 minutes, which was statistically significant. The total tramadol consumption at the end of 12 hours was significantly lower in Group B compared to Group A. The mean VAS for shoulder pain score and abdominal pain score at 1, 2, and 4 hours were significantly lower in Group B compared to Group A. The mean time taken for unassisted ambulation in hours were not statistically significant. The difference in both the groups. The difference between the two groups in mean nausea score and duration of hospital stay were not statistically significant. The safety of intraperitoneal instillation of different drugs for postoperative analgesia in these procedures have been supported by current literature. Intraperitoneal local anesthetics act by blocking peritoneal free afferent nerve endings and systemic absorption of local anesthetics. The steroids act by suppressing tissue levels of bradykinin and reduction of prostaglandin production. Both bupivacaine and hydrocortisone provided satisfactory pain relief, but bupivacaine significantly prolonged the duration of analgesia when compared to hydrocortisone. Amin et al. Studied the effect of intraperitoneal hydrocortisone for pain relief after laparoscopic hysterectomy and concluded that injection of hydrocortisone before gas insufflation reduces postoperative pain. And T. Chandigarh et al. Studied intraperitoneal bupivacaine for effective pain relief after laparoscopic cholecystectomy and concluded that it reduces the pain in the initial postoperative period. The limitations of my study where the primary investigator was non-blinded, the dose and drugs of the local anesthetic and hydrocortisone were not weight adjusted, though the surgeons waited 10 minutes after instilling the drug. It was suctioned out for better field of visualization, and duration of hospital stay was 2 days, irrespective of the outcome. Further studies are required to compare the analgesic efficacy when drug is instilled before pneumoperitoneum and at the end of surgery. It was concluded that bupivacaine instillation prior to pneumoperitoneum provided better post-op analgesia for shoulder tip and abdominal pain in comparison to hydrocortisone in early postoperative period. These are my references.
Samira, can you hear me?
Yes, sir. Yes, sir.
Yeah. There are so many anesthetic drugs available for local infiltration. Why you decided to select hydrocortisone?
Sir, the side effects will be lesser compared to local anesthetics if there is any systemic absorption, sir, with hydrocortisone or any steroids. So I decided to compare between local anesthetic and steroids.
But when one is a local anesthetic agent, another is not an anesthetic agent at all. You have compared both, is not it?
Yes.
You have compared effect-wise.
Yes, sir.
So you should have added hydrocortisone to another drug and one placebo to the other group. That would have been a better study, as Ranjan sir.
Yeah, true. Like in a brachial plexus block, can you compare local anesthetic with the steroids?
Yes.
In one group, I'll give local anesthetic. In another group, I'll give steroids only and compare the analgesic effect. Is it possible? No, right? So hydrocortisone, you act as an additive. So when you do that, you compare it with dexmedetomidine, hydrocort versus dexmedetomidine, hydrocort versus some other additives, clonidine. So your comparison was not well matched. If you had used something else, 2 different doses of local anesthetics or 2 different types of steroids, it would have been ideal, right? Thank you, Dr. Sandhya. Thank you.
Next question, sir.
Next presentation will be by Dr. Sandeep Punia.
I am Dr. Sandeep Punia. My guide Dr. P.S. Lamba. My e-paper is outcome of mandibular nerve block with dehydrated alcohol for trigeminal neuralgia and observational descriptive study at Asmus Medical College, Jaipur. Introduction. PAN is defined by the International Association of the Study of Pain is an unpleasant sensory and emotional experience associated with the actual or potential tissue damage or described in terms of such damage. Trigeminal neuralgia is detailed in the International Classification of Attack Disorder as follows: paroxysmal pain attacks of facial and frontal lasting and is distributed along one or more division of the trigeminal stabbing or burning pain in the precipitation of pain from certain daily activities, that is eating, talking, facial washing or brushing. Symptoms between paroxysm and the event of neurological deficit. 5% of patients with trigeminal neurological treatment require additional interventions such as steroid or alcohol injection. The aim of the study is outcome of mandibular block with a dehydrated alcohol for the trigeminal neuralgia to assess primarily to assess the proportional case who remain pain-free at the end of 1 year post-block period. To assess the mean duration of pain-free period in case. Secondary objective to differentiate the proportion of cases who experience side effect or complication during 1 year post-block period on average 2 months. After obtaining due permissions from Institute of Ethics Committee, the study will be conducted and clinical assessment. 6% required as 70 cases would be required at 95% and 6.6% of cases remain pain-free at the end of 1 year post-block period. After taking informed written consent and confirming overnight fasting, patient will be taken in the operating table. IV cannula inserted and RL connected. Then 2 to 3 ml 1% into steel for convenience. Then deposit nearly situated between the zygomatic arc and nose after contact. Lateral pterygoid plate and angle slightly superiorly toward the ear and 2 ml data injection administered. This criteria patient of either sex is group 20 to 70 years age. First, second, patient is present the diagnosis of neuralgia detailing of a not only participate in the study cases with self-suspect in the local site, patient with non-allergy to alcohol, patient with uncontrolled hypertension, bleeding disorder, non-anticoagulant, emergency disorder, increase both PTNR and decrease platelet count, COPD. This is the result and this is the discussion in this project. 56% patients 80% have showed 1 year pain-free duration, 2% 2.9% patient have showed 6 months pain-free duration, 12% 17.2% patients have 9 months of pain-free duration, while only 14.3% patients require second dose. Complication was found in 5.7%. Sensitive discomfort, itching, dysphagia, hyperphagia, the majority resolved in 6 months. It will only be strong that our present data support the notion that mandibular nerve block with alcohol should be reconsidered as a useful treatment option for medical intractable trigeminal neuralgia, because our results indicate that this modality offer a high rate of lasting impact without complications. Furthermore, our show that repeated mandibular nerve block with alcohol does not influence complete pain level duration. Doctor both for seeking better and better treatment option. This furthermore study and this is required for seeking better treatment option. Friends, thank you.
Dr. Sandeep.
Good morning. Good afternoon, sir.
Good afternoon. There are a lot of disturbances during your presentation. Your slide 7 shows discussion, conclusion, and reference. All three in one slide. This type of presentation is not accepted in our Isacon presentation. So you rectify that. Second thing, but your study, how it is going to change the current practice scenario?
Yes, sir.
Your study, how it is going to improve the current practice scenario?
In my study, we include the we evaluate the मतलब alcohol block in trigeminalgia about 1 year. Hello?
You are not audible.
Yes, sir. I am audible, sir. Yes, sir.
Okay.
Not audible to us. You are audible to you only.
You changed your slide 7. You cannot put everything into one slide. Slide 7 shows discussion, conclusion as well as reference. Okay, you change that slide. Don't present in that form. Okay, sir. Ranjan, sir.
No, there was a lot of audio disturbances. Even videos were well clustered. Sandeep, sorry for that. Whatever technical glitch. I don't have any questions. We will move to the next slide.
Yeah, next slide, please.
Thank you, Sandeep. Next presentation will be by Dr. Sandeep Hintre.
Comparative study to evaluate the effect of addition of methylprednisolone versus dexamethasone to local anesthetic for a brachial plexus block. We will be discussing under 3 seconds. Introduction. Supraclavicular approach to the brachial plexus is the best suited for surgeries of the upper limb. It is also called as a spine of upper limb. Here, many drugs has been used to prolong the duration of the sensory and motor blockade. Here, we are using dexamethasone and methylprednisolone. Aim is to compare the sensory and motor characteristics of the brachial plexus with the addition of either methylprednisolone or dexamethasone. And secondary aim is to compare the cardiorespiratory variables and any side effects. Methodology, it is a double-blinded randomized controlled study. The sample size is calculated based on the previous study and using this. And here the 60 patients has been taken, each group having 30-30. In group M, it will get 40 mg methylprednisolone. In group D, it will get 8 mg dexamethasone. And here the patient is evaluated 1 day prior and before shifting to the operative theatre, and informed consent is taken, and AS standard monitors are attached. The inclusion criteria includes the patient age between 18 to 60 and ASA 1 and 2. And here, after giving the drug, the onset and duration of the sensory and motor blockade and any cardiorespiratory the variables were compared. Here, the sensory blockade, it is scored using the numerical rating score, and score 3 it is taken as onset, and score 0 taken as a complete onset. The motor blockade scored fluid rating scale, score 3 taken as onset, score 0 is taken as a complete motor blockade onset. All the data entered in a Microsoft Excel, and it is compared. It is entered in a IBM SPSS statistics, and all the variables where we get. Here the primary outcome, the sensory and motor block onset, it is comparable, and the duration of sensory and motor blockade, it is also comparable. There is no significant changes. Also, the cardiorespiratory variables were not much. These are insignificant. Here, the dexamethasone, it is a very potent and highly selective glucocorticoid. It is long acting, so it will cause pituitary adrenal suppression. Methylprednisolone is more potent than hydrocortisone and more selective than prednisolone. It is less glucocorticoid effect and has slightly middle cortical effect. In our study, you will compare these two drugs. Here all the variables are comparable. There is no significant changes. In our study, we are included only the 18 to 60 year patients and only ASA 1 and 2 patients. Methylprednisolone also is used as as effective as dexamethasone in prolonging the duration of post-operative analgesia. So you can use methylprednisolone also as a adjuvant in a brachial plexus block. Thank you.
Sandeep, it's a comparative study, no?
Yes, sir.
But in the conclusion, there was no comparison.
Sir, it is
you have told
comparable,
it's as
sir.
good as.
Huh, sir.
When you are comparing,
comparable, sir. The result what you got, sir.
both are good. Both are good, and both are having equal.
Both are good, sir. Yes, sir.
Okay. And practically, how many patients you have given in your study?
That is, sir. Sir, initially, sir, we used to give.
Okay.
Dexamethasone only, sir. In our study, sir, we have given methylprednisolone also. Methylprednisolone.
Any complication you found? Any complication you faced during your study?
No, sir.
Okay. Ranjan, sir.
There were no significant complications.
Dr. Sandeep,
yes, sir.
Why did you decide to compare two steroids? What was the advantage or disadvantage?
Sir, this dexamethasone is having more glucocorticoid effect, sir, but methylprednisolone has glucocorticoid. Sir, slightly it has a glucocorticoid effect. It is insignificant. So in sir, patient with diabetes use methylprednisolone safe than dexamethasone, sir.
Okay, Dr. Sandeep. Ideally, we compare two different group of drugs, opioids with alpha-2 agonist,
Yes,
or
sir.
with steroids with mild opioids. Same group of drugs, very rarely we compare. It has been proved beyond doubt that dexamethasone
Yes, sir.
addition will prolong the duration as well as it's the least side effect. And it is very cheap compared to methylprednisolone. Methylprednisolone is costly compared to dexamethasone. It has been already proved. So now to find an alternative to dexamethasone is not required, right? Until unless you have a significant improvement in the onset or in the duration. Okay. Yeah, okay then. Thank you.
Thank you. Thank you.
Thank you, Dr. Sandeep. Sir, next presentation will be by Dr. Sangeeta Yadav.
Sandeep Sharma.
Okay. Sorry. Next
Sandeep
is
Sharma.
Sandeep Sharma. Please.
Yes, ma'am. Present.
Teachers, the oral post-operative analgesic properties of pre-operative oral pregabalin versus tramadol in patient of lab coli, a randomized double-blind interventional study at SMSMC Jaipur. Principal author Dr. Sandeep Sharma, co-author Dr. Manoj Kumar Soni. Introduction. Major intention of post-operative pain manage is to introduction the lessen the dose of a medication, speeds up ambulation, patient well-being to lessen the factor effects and provide corrected sufficient analgesia. Post-operative pain differs from special acute pains as intraoperative pain manipulation. The nature and duration of surgical procedure, the site and size of incision line, and the amount of surgical trauma. Through lab technique, it has less body tissue damage in surgical strategy like cholecystectomy, appendectomy, ovarian cystectomy, etc. Opioid analgesics with their well-known side effects continue to represent a cornerstone in post-operative pain control. Pregabalin has been used for the treatment of various neuropathic pain. Present study to compare the post-operative analgesic properties of pre-operative or pregabalin versus tramadol in patient of lab coli. The objective of this study to compare difference in mean time duration for need of fast rescue analgesia, total mean doses of rescue analgesia 24 hours, mean VAS score, and side effects. material methods. After obtaining due permission from institution ethics committee, the study will be conducted in the Department of Anesthesiology and Critical Care SMS MC Jaipur. Sample of 30 cases in each group is required at 95% confidence limit and 80% power to verify the expected difference of 1.94 in change in mean VAS score from baseline to 24 hours. Extubation in both groups. 60 eligible lab quali candidate whose age group 18 to 16 years, body weight 45 to 65 kg of either sex belonging to ASA classified as second, randomly allocated in two groups with opaque sealed envelope method. Patient will receive 150 mg pregabalin capsule orally and 100 mg tramadol capsule orally 1 hour before surgery with sips of water. The study will be conducted in the following two groups of patients. Each group will consist of 30 patients. Result: in the present study, there was a significant decrease in pain scores of patients who received tramadol compared to the pregabalin. Need of mean duration of first rescue analgesia, p-value 0.019, total mean dosage of rescue analgesia 24 hours, VAS score p-value 0.05 less than, the anxiety score significantly low in group T compared with group P. The sedation score are significantly high in group D than group P. Nausea, vomiting, and drowsiness side effects are more common with tramadol, but difference between group are not statistically significant. The table depicts comparison of pain score in between group P and group T. Discussion: all the cases of pregabalin group and tramadol pregabalin group and tramadol group were needed for first rescue analgesia. In pregabalin group, time interval for the first rescue analgesia is significantly earlier than the group with tramadol. Need of total doses of rescue analgesia significantly high in group P than in group T at the time of extubation: 1 hour, 2 hour, 4 hours, 6 hours, and 24 hours. After extubation, post-operatively, the level of sedation in the pregabalin group was found to be significantly less in comparison to tramadol. We also observed the analgesic effects of tramadol was superior to that of pregabalin. However, the anxiety scores in the pregabalin group were found to be significantly higher in the tramadol group. Side effects like nausea and drowsiness more in tramadol than pregabalin. The conclusion of my study: tramadol has better analgesic, less anxiety, more sedation compared to the pregabalin, but nausea and drowsiness more in tramadol. Reference of first and second shows these studies. Thanks.
Sandeep, can you hear? Sandeep, can you hear?
Sorry, sir, not audible.
Sandeep, cannot. Yeah, now you are audible.
Yes, sir.
Sandeep, you are now audible.
Sir.
Can you hear me?
Yes, sir.
This tramadol and pregabalin, I think both are in different directions, both the drugs.
Yes, sir.
Like tramadol will have some predation effect. So you consider more post-operative effect and all.
Yes, sir. Post-operative pain.
Instead of another drug which you compared, right? So pregabalin is basically and not one is about it as an opioid effect. So one opioid and another group.
Sir, not audible, sir.
Sir, can you hear? Sir, on mute, sir.
Sir, pregabalin have an analog. Can you audible, sir?
Sorry, sir. Dr. Sandeep, is it audible now?
Sir. Yes, sir.
Yeah. What Dr. Devashish is saying, if you look at the pain ladder, okay, so pregabalins and all, they're the first step. They are not a few good analgesic. After that, opioid like drugs like tramadol, then the opioids. So when you are comparing,
yes, sir.
When you are comparing pregabalin and the opioids, they don't come in the same ladder. You should have used a drug which comes in the same ladder for comparison. That's what Dr. Devashish was advising you.
Sir, the pregabalin have a GABA analog and tramadol opioid.
The pregabalin alpha to delta subunits bands and
No, I can understand. It has a analgesic, little bit of analgesic potency, but not as good as tramadol, right?
yes, sir. Pregabalin have analgesic, but less than tramadol.
It's already
But
proved. Then what you wanted to prove by doing this study?
With the seed articles of 2 to 3 seed articles, sir.
Why you particularly choose lap cholecystectomy? Any GA could have been done. Why only lap cholecystectomy was used?
Sir, my guide guide according.
Okay. Thank you, Sandeep. Thank you.
Okay, thank you.
Next slide, please.
Good morning, respected organizers and delegates. Myself, Dr. Sangeeta Yadav, and the topic of my paper is comparison between phenylephrine and ephedrine in preventing hypotension during spinal anesthesia for cesarean section. My study was conducted in Jorhat Medical College and Hospital under the guidance of Dr. Rajiv Hazarika, sir. Spinal anesthesia is a widespread prevailing technique for cesarean delivery because of superior quality of surgical anesthesia, rapid onset of action, and excellent patient comfort. Neuraxial anesthetic technique produces hypotension due to the blockade of sympathetic nerve fiber. Hypotension in the setting of spinal anesthesia is defined as systolic blood pressure less than 90 mm of mercury. The vasopressor drugs like ephedrine and phenylephrine has been found to be more effective in prevention of spinal-induced hypotension. The aim of my study was to compare maternal and fetal effects of intravenous phenylephrine and ephedrine administration in preventing hypotension during spinal anesthesia for cesarean section, and the objectives were to compare the efficacy of ephedrine and phenylephrine, to evaluate the hemodynamic changes sustained during the administration of ephedrine and phenylephrine, and to evaluate the side effects of ephedrine and phenylephrine, if any. My study was hospital-based observational study, and the sample size was obtained to be 80, 40 in each group. In group E, 40 patients received prophylactic bolus of 5 mg ephedrine at the time of intrathecal block, plus rescue boluses of 5 mg ephedrine whenever the systolic blood pressure was less than 90 mm of mercury. And in group B, 40 patients received prophylactic bolus of 50 microgram of phenylephrine at the time of intrathecal block, plus rescue boluses of 50 microgram phenylephrine whenever the maternal systolic blood pressure was less than 90 mm of mercury. The hemodynamic variables like systolic, diastolic, mean arterial pressure, and heart rate were recorded in my study. Firstly, the baseline values were recorded, and after in every 2 minutes till the delivery of the baby, and after that in every 5 minutes values were recorded. We gave 5 mg of ephedrine and 50 microgram of phenylephrine prophylactically to the patient to preserve the systolic blood pressure more than 90 mm of mercury, and we found that both the drugs maintained systolic blood pressure more than 90 mm of mercury. Regarding the episodes of hypotension, in group E, 24 patients out of 40, and in group B, 26 patients out of 40 had one or more episodes of hypotension, which on comparison found to be statistically insignificant. And about the comparison of number of vasopressor doses, in group E, 23 patients required single doses of vasopressor and 1 patient required 2 doses of vasopressor, and in group B, 23 patients required single doses of vasopressor and 3 patients required double doses of vasopressor, which again on comparison found to be statistically insignificant. The neonatal data was expressed using Apgar score and umbilical cord pH, and on comparison between both the groups, we found that no neonate had Apgar score less than 7 at 1 and 5 minutes. And about the side effects, in phenylephrine group, the incidence of bradycardia was significantly higher, that is 19 patients out of 40 experienced bradycardia. In ephedrine group, 6 patients out of 40 experienced bradycardia. So we can say that the incidence of bradycardia was significantly higher in phenylephrine group. And as both the vasopressors effectively maintain systolic, diastolic, and mean arterial pressure, and the incidence of hypotension and requirement of rescue doses of vasopressor were also similar in both the groups, and the incidence of bradycardia was significantly higher in phenylephrine group, we came to the conclusion that both the drugs are equally efficient to prevent hypotension after spinal anesthesia in cesarean section without any adverse neonatal outcome. Thank you.
Sangeeta, Yeah.
Good afternoon, sir. Good afternoon, sir.
So, you have studied electives.
Sorry, sir. I'm not able to hear
Devashish,
you.
your voice is breaking. Probably internet bandwidth is low. It is it's breaking in between.
Sorry, sir. I'm not able to hear.
You go ahead, sir.
Yeah. Okay. Dr. Sangeeta, yeah.
Good afternoon, sir.
Many studies have been done already. We know that phenylephrine has its own advantage, disadvantages. Your study also proves both are good agents. Probably should have, now the time is to do the next level of investigation. We are worrying about the fetal acidosis. Okay, of whatever the vasoconstrictors are using, whether it will affect the fetal blood supply, whether it will cause fetal acidosis. That is what the next level of thinking. So we should UPGAR score. Yeah, it can be. It's just a clinical scoring. It will not tell exactly about the fetal acidosis part. So probably you can know next time if your facility is available in your hospital. So comparing ephedrine versus phenylephrine, not only on the hypotension, also about the fetal acidosis, fetal bradycardia, all these things also should be looked into. Okay. Otherwise, good study, it's already been done in many places. We know that phenylephrine and ephedrine both are good agents in hypotension. Each has its own role in particular diseases, right? Okay, thank you. Next presentation, please.
Next presentation will be by Dr. Saptaki Majmudar.
Sanjay. It is Dr. Sanjay, right?
Good afternoon, sir.
Yes, sir.
Yes.
Can I play?
You are Sanjay, no?
So there seems to be a little confusion. As per the list, my name is next on the presentation list.
This is who?
Okay,
This is Sanjay talking?
Yes, sir. Yes, sir. This is Dr. Sanjay Naik speaking.
Yes, Sanjay, please go ahead. No problem.
Sure, sir. Sure.
Presentation on the effect of dexamethasone nebulization on post-operative sore throat and prone position surgery. Significant number of patients complain of sore throat after surgery with endotracheal intubation. Common cause being trauma to pharynx and tonsillar forces by laryngoscopic plate, trauma to larynx by endotracheal tube, and cuff pressure affecting tracheal mucosal capillary perfusion. Incidence of post-operative sore throat is reported in up to 60% of patients, with various factors being size of the tube, time manipulation needed to insert tube, cuff pressure, and duration of time at which tube is in situ. Dexamethasone is a glucocorticoid with anti-inflammatory and analgesic properties that has the potential for decreasing the incidence of sore throat. Many studies are focused on effect of intravenous as well as nebulized dexamethasone on post-operative sore throat and supine position surgeries, and the study aimed to focus on effects of dexamethasone in prone position surgeries. Patients undergoing elective surgeries in prone position under general anesthesia and MS Ramey were selected for the study. Type of study was a prospective double-blind randomized controlled trial with ethical clearance taken from Institutional Ethical Committee. Primary objective was to evaluate the incidence of post-operative sore throat with and without dexamethasone nebulization in patients undergoing surgeries in prone position, and secondary objective was to evaluate the severity of sore throat. Inclusion criteria included ASA 1, 2, and 3 patients undergoing elective surgeries in prone position with patients between ages between 18 to 65 years. Exclusion criteria include a history of recent respiratory tract infection, NSAID use or steroid usage, previously undergone head and neck surgeries, duration of tracheal intubation less than 60 minutes or more than 300 minutes, or required more than one attempt for tracheal intubation. Lee et al. Observed incidence of post-operative sore throat in group with normal saline was 67%, with 0.1 mg per kg dexamethasone was 40%, and with 0.2 mg per kg dexamethasone was 30%. In the present study, expecting similar result with 80% power, the study requires a minimum of 45 subjects in each group for a total of 135 subjects. To compensate for potential dropouts, 50 patients will be enrolled in each group. Patients were kept nilparol 6 hours prior to surgery. Pre-medication, tablet pantoprazole 40 mg plus tablet 4 mg were given. Patients were allocated into normal saline group, dexamethasone 0.1 mg per kg group, or dexamethasone 0.2 mg per kg group. Nebulization was given as to group allocation 30 minutes prior to shifting to OT. General anesthesia was given with fentanyl, propofol, and antifuran I mentioned dosages.
Intubation was done with flexometallic tube with an internal diameter of 8 to 8.5 millimeter in males and 7 to 7.5 millimeter in females. Cuff pressure was adjusted to 25 centimeter water, maintained with cuff pressure monitor, and also maintained after position change. Anesthesia maintained with isoflurane plus oxygen plus air. End-tidal carbon dioxide was maintained between 28 to 32 millimeter mercury. End of surgery, patient was shifted to supine position and reversal was given with neostigmine 0.05 mg per kg plus glycopyrrolate 0.1 mg per kg. Gentle oral suction done and patient extubated when able to obey commands and lung ventilation deemed adequate. Duration of tracheal intubation and prone position plus incidence of sore throat during extubation was recorded. Descriptive statistics of proportion of postoperative sore throat was analyzed and summarized in terms of percentage, 95% confidence interval estimated. Chi-square Fisher exact test was used to find the significance of study parameters on categorical scale between two or more groups. Fisher exact test was used when cell samples were very small and p-value of less than 0.05 was considered as statistically significant. Results, demographic characteristics for all three groups were similar with no statistical significance. Patients predominantly underwent PCNL surgery followed by spine surgeries and noted across all three study groups. Incidence of sore throat was greater in normal saline group at time of extubation. One patient in normal saline group complained of severe sore throat. Incidence of sore throat had inverse relation with time in post-operative period and observed in all three study groups. Sango Lee assessed the effect of intravenous dexamethasone on post-operative sore throat and prone position surgeries. Patients were divided into groups of 50 based on dosage and time of drug. Normal saline group, dexamethasone 0.1 mg per kg and dexamethasone 0.2 mg per kg. Incidence of sore throat was lower in group D2 as compared to group B. Salama et al. Assessed efficacy of dexamethasone nebulization in decreasing incidence of sore throat. Patients were divided into two groups, normal saline and dexamethasone 8 mg. Incidence and severity of postoperative sore throat was significantly reduced in dexamethasone group. In our study, preoperative dexamethasone nebulization in both doses did not show reduction in incidence or severity of sore throat either statistically or clinically as compared to normal saline nebulization. Limitation of the study was no additional follow-up beyond 24 hours. In conclusion, preoperative dexamethasone nebulization at doses of 0.1 mg per kg or 0.2 mg per kg does not reduce the incidence or severity of postoperative sore throat as compared to normal saline nebulization in patients undergoing sedation in prone position. These are my references. Thank you.
Sanjay,
yes, sir.
Can you hear me?
Yes, I can hear you, sir.
Yeah. So what benefit you will be getting out of this study?
So an institution upon post-operative follow-up, beyond post-operative nausea and vomiting and post-operative pain, the sore throat was always a common complaint between the patients. So we were hoping that in our study, choosing dexamethasone as a nebulization, which would be, much more easier to administer. So we were hoping that the post-operative sore throat incidence and severity would be lesser in the post-operative period. However, what we may have failed to account for is that with the patient in prone position undergoing surgery in prone position, the further displacement of the tube and variation in the cuff pressure, which we've tried accounting for in the study, might have played a role in having no significantly statistical effect on the incidence and severity of sore throat post-operatively.
Okay, sir, Ranjan sir.
Yeah, Dr. Sanjay.
Yes, sir.
With the sample size, when you are calculating, you used a study where it showed that there was significantly reduction in sore throat with the steroid group.
Yes, sir.
How do you explain that study with your study where it was so much differences?
So the parent article, actually, we chose the parent article with having the closest correlation to our study. The parent article had said that IV dexamethasone was used. The greater bioavailability of dexamethasone could have played a role in reducing the incidence and severity, sir. We have, during the review of literature, we found that there were not many studies explaining or comparing the effect of nebulizations in prone position surgeries. Although nebulizations have been done in supine position surgeries, prone position surgeries was one where it was not well explored.
True. I agree with the fact. So probably your study design would have been different. One is a normal saline group, one was an IV dexamethasone, another was a dexamethasone nebulization. Probably you would have got a better result. What do you think?
True, sir. It was something we had considered, but we wanted to stick by the parent article and try to do justice by that.
Good. Well presented, well defended.
Thank you, sir.
Next presenter, please.
Thank you, sir. Next presentation will be by Dr. Saptaki Majmudar.
Good afternoon. here to present validation of two pre-oxygenation techniques, 3 minutes tidal volume breath and 8 vital capacity breath techniques in tribal and non-tribal population of Eastern India. Aim of the study was to check appropriateness of two methods with specific objective to measure the time of TV breath and number of VC breath to reach ETO to 90% and to compare the values in tribal and non-tribal population of Eastern India. Methodology: descriptive and analytical study in general surgery and gynecological OTs after getting ethical clearance. Patients scheduled for OT under GA willing to participate, 20 to 50 years, ASA 1 and 2 were included, anticipated difficult intubation, obese, smokers, history of alcohol and drug abuse, pregnant and lactating, pulmonary and musculoskeletal disease were excluded. Out of 146 patients, every odd number of patient was tested for TV method and even number for VC method with 100% oxygen at 10 liter per minute with Mapleson A circuit. 6 patients were non-compliant in VC group. Subgroups of each group were tribal T, non-tribal NT, tribal male TM, non-tribal male NTM, tribal female TF, non-tribal female NTF. Result analysis: demographic profile of each group was comparable in both groups. In TV group, NTM completed better pre-oxygenation than TM, but mean time was similar in all subgroups. In VC group also, NTM completed better pre-oxygenation than TM, but mean number of VC breaths was similar in all subgroups. Coming to discussion, in our study, in TV method, the mean time for pre-oxygenation was higher than 3 minutes and similar in all subgroups. Very few percentage of patient completed pre-oxygenation, the rest of the patient completed in a few more seconds, that is 2 to 18 seconds, which is clinically non-significant. Kang H. et al. Found that elderly group could not reach 90% ETO2 in 3 minutes, but young group could. Here the age of patients were different. Nimagata U. et al. Found that ETO2 plateaued by 2.5 minutes at 88% with 10 liter per minute FGF, which supports our study. AIDA recommended tidal volume pre-oxygenation for 3 minutes, but they suggested 20-degree head elevation, which we didn't do in our study, though it was a consensus data of the members of the society, not derived from any study. In our study, in VC method, the mean number of VC breaths was higher than 8 and similar in all subgroups. Some percentage patient completed pre-oxygenation, the values are higher than TV group. Many patients didn't complete pre-oxygenation, but they completed with a little extra, that is 0.20 to 0.75 VC breath, which is clinically non-significant. Nimagata U. et al. Showed that with 8 deep breath or VC breath in 1 minute resulted in ETO2 value 87% at 10 liter per minute. So it didn't complete in 1 minute. This supports our study. Pandit J. et al. Found that ETO2 was significantly different in 3 TV and 8 dB methods. Kapatti L. et al. And Chiron et al. Found that 8 dB achieved better pre-oxygenation than 3 TV, though here the patients were pregnant. Maitra SN et al. In AIDA guidelines showed that 8 VC method is an alternate method of 3 minutes TV method, but in our study, VC method was superior to TV method. Conclusion: VC method achieved better pre-oxygenation than TV method in all subgroups, though they were not statistically compared in our study. But performance of VC breaths by patients seemed difficult even after proper training. We didn't record ETO2 at 3 minutes in TV and at 8 VC breaths. It requires further study to conclude whether the difference with national guidelines is clinically significant or not. These are my references. Thank you.
Dr. Saptaki, right?
Yes, sir.
Why did you compare tribal and non-tribal in this? Can't you have made a same group? Comparing vital capacity with the tidal volume breath?
Sir, our country has a large diversity of population of different genetic patterns and different ethnicity and geographical and regional factors. So different subgroup of patient may behave differently to the pre-oxygenation as it is dependent on the FRC of the lung.
How do you pre-oxygenate?
Sir, by 2 methods, tidal volume and vital capacity. By tidal volume method, with 10 liter per minute of 100% oxygen for 3 minutes, and for vital capacity with same oxygen flow at for 1 minute.
So why? How do you explain in tribal group it was not achieved? Was their lung condition was different? FRC was different, or are they smokers? What is the reason?
Sir, both tribal and non-tribal did not complete pre-oxygenation in both TV and VC method. And
Why was that? Why they didn't
sir,
complete?
though the age, height, BMI, ASA, all the parameters were similar, but we didn't record the chest circumference, the upper half and the lower half of the length ratio. These parameters could have been recorded in
So
our studies.
my question is, why you couldn't do 3 minutes pre-oxygenation? Whether they were non-cooperative?
Sir, both methods were tested in both tribal and non-tribal.
But they were cooperative.
Yes, sir.
So 3 minutes you could keep the oxygen.
Yes, sir.
Only that you are not able to achieve end-tidal oxygen of more than 90%.
Yes, yes, sir.
In both the groups.
Yes, sir.
So what is your explanation for this now?
Sir, although All India Society of Difficult Airway suggested 3 minutes tidal volume respiration, but our patients completed in 3 to 4 minutes. So it should be done for more than 3 minutes in TV method, and for 8 VC method, it should be more than 8. All patients completed by 10th VC breath.
So according to you, duration doesn't matter. End-tidal oxygen is what is important. Whether it is 2 minutes or 4 minutes, we should.
No, sir. Actually, we didn't record the ETO2 at the end of 3 minutes and at the end of 8 vital capacity breath. It should be done. As we have seen that it was around 88%. So it may not be clinically significant.
Okay, Dr. Devashish.
Yes, sir. There are no questions, sir. Already 2 minutes over. Next slide, please.
Thank you.
Thank you, Dr.
Thank you. Next presentation will be done by Dr. Satyashri. Dr. Satyashri?
Yes, ma'am. Yes, ma'am, there. Hello.
Good morning. My topic is comparative study of pre-medication effect of oral pregabalin and gabapentin in post-operative pain in abdominal hysterectomies. Introduction: high quality pain control after the surgery is still a major challenge, and multimodal approach has been suggested to improve the post-operative analgesia and to reduce opioid-related side effects. Antihyperalgesics drug provide pain relief by preventing the development of central sensitization. Gabapentin is structural analog of the GABA and it has high binding affinity for alpha-2 delta subunits of the presynaptic voltage carrier calcium channels, which inhibits the calcium influx and subsequent release of excitatory neurotransmitter in the pain pathway. Pregabalin is also analog of the GABA, which shares the same mechanism, has superior pharmacokinetic profile, and more effective in preventing the neuropathic component of the acute pain. Aim of the study is to compare the pre-medication effect of the oral gabapentin and pregabalin in control of the post-operative pain. Objectives: duration and quality of the post-operative pain relief, to study the post-operative requirement of analgesics and study side effects, if any. After obtaining the approval from the Institutional Ethics Committee and informed consent, a prospective randomized double-blind controlled study of the study population containing 60 people were divided into 2 groups. Group G were given the dose of gabapentin 900 mg and Group B was given the oral dose pregabalin 300 mg. Period of study is 12 minutes. Inclusion criteria: ASA grade 1 and 2 posted for elective gynecological surgeries on spinal anesthesia age 30 to 70 years. Exclusion criteria: patient with contraindication to the spinal anesthesia, severe dizziness with the gabapentin and pregabalin, emergency surgeries, compromised cardiorespiratory function, renal disease, metabolic and cognitive abnormalities. Provision informed consent was taken. Concept of the visual analog score was introduced on day of surgery. Vital parameters were noted, and then the drug selected for the study was given with the sips of the water. On entering the OT, IV line was secured. Preloading was done, and preoperative vitals were recorded. Anesthesia was instituted. Intraoperative routine monitoring of the vitals continued along with the fluid administration. In post-operative period, pain assessment was carried by the VAS score, and motor block was assessed by Broman scale. Intramuscular diclofenac 75 mg was given as rescue analgesia. At that time, VAS score was recorded. Duration of the effective analgesia was measured as time from the intrathecal drug administration to the patient's first request for the anesthetic, either in the recovery room or in the ward. Patient was kept under the observation for a total period of 24 hours to observe for the total number of the doses of rescue analgesia required and if any side effects. Statistical analysis 1 was done. P-value less than or equal to 0.05 was considered as significant for both types of the data. Results: comparison of the mean systolic pressure, diastolic pressure, mean arterial pressure, mean pulse rate, and mean respiratory was showed significant fall in the hemodynamics in the Group G than Group B. In terms of first analytic dose required in the hours post-operative, pregabalin regimen 10 mg studied better than the gabapentin 900 mg by 7 hours and 5 hours respectively. For vascular, it is observed that pregabalin is better drug than gabapentin in post-operative pain control with scores of 5 and 7. No significant complications like nausea and complications were noted. It's a comparison between the effect of pregabalin and gabapentin on mean blood pressure, mean pulse rate, mean respiratory rate, and graph depicting the mean VAS scores of the gabapentin and the pregabalin. Comparison between vascular and duration of analgesia. Comparison between the duration of analgesia. Discussion of our study suggests that a single dose of gabapentin and pregabalin 60 minutes prior to the surgery was effective in reducing acute preoperative anxiety and increased levels of sedation before and after surgery. Pregabalin 10 mg is better anxiolytic and sedative than the gabapentin, which could be explained due to better alpha-2 delta ligand binding property. Total number of analgesic doses and total dose of analgesic in first 24 hours is lower in pregabalin group, and results are correlated with the studies conducted by Saraswati and Aurora. On conclusion, intraop hemodynamics were more stable in the group B than in the group G respectively. To conclude, oral pregabalin and gabapentin are useful as adult adjuvants for the management of post-operative pain by providing analgesia through a different mechanism than the opioids and act as multimodal therapy if not a sole analgesic. These are my references. Thank you.
So what is the benefit out of this study? Satyasri?
Yes, sir. Sir, here we want to, my aim of the study is to say we can omit the post-operative nausea and vomiting, urinary retention caused because of the opioid. If not the sole analgesics, we can use the pregabalin as a pre-medication, which can also provide anxiolysis and sedative effects.
No, practically, have you found all these effects? You said you don't need antiemetics and all. Practically, you have found it, or you are presuming?
Sir, practically, post-operatively we have patient who does not complain any nausea. So,
how many patients complained of nausea out of the study?
Sir, 5 of them complained of nausea, sir.
What you use for them?
Sir, we used ondansetron post-operatively. We gave. When they complained of nausea, we gave ondansetron.
Okay, so you have excluded from this study, or you have included again them in your study? Because that doesn't correlate with your study protocol.
Sir, out of 60 patients, only 4 of them have, 4 to 5 of the patients have complained. Otherwise,
okay, Ranjan sir.
Satyashri, study, yeah, it's been proved. Your study also proves both are effective.
Yeah.
It's basically your PowerPoints. It's not compulsory to read anything and everything in your PowerPoint from top to bottom. PowerPoint should not be used as a textbooks. PowerPoint should be used as a guide. 3 lines, 4 lines, and you should talk. You should not read from the PowerPoints. Okay, cultivate that habit. About the study, a good PG study, nothing much to add to it. Thank you.
Thank you, sir. Our last presenter of the day is Dr. Sheetal.
GG, ma'am. From GR Medical College, Gwalior. The topic is comparative evaluation of the combination of intravenous ketamine plus dexmedetomidine and ketamine plus midazolam in procedural sedation for short surgical procedures, a randomized controlled study. Introduction. Sedation is defined as depression of patient's awareness to the environment and reduction of responsiveness to external stimulation. The anesthetic agents used in short surgical procedures should be hemodynamically safe and should provide adequate analgesia, sedation, and immobility. Early recovery, fewer postoperative complications, and rapid home discharge are important factors influencing the choice of anesthetic agent. The choice of Dexmed with ketamine for sedation provides several advantages over conventional drugs. Dexmed provides anxiolysis and good sedation, and ketamine adds up hemodynamic stability stability by counteracting the bradycardia produced by dexmed. The combination of these two drugs reduce the incidence of postoperative cognitive dysfunction. Aims and objectives: to compare the effects of ketamine dexmed and ketamine midazolam on sedation, hemodynamic and respiratory parameters in short duration surgical procedures, to evaluate the effect of the drug combination on adequacy of anesthesia, to compare the postoperative recovery time, analgesia, and complications. Material and methods. After obtaining approval from the Institutional Ethics Committee, present prospective double-blinded randomized control study was conducted on 100 ASA 192 patients undergoing short surgical procedures at GR Medical College. The sample size is calculated by the following equation. Inclusion criteria: consent to participate, and ASA physical grade 1 and 2. Exclusion criteria: emergency procedures, pregnant and lactating women, history of any significant systemic diseases, chronic use of alpha-2 agonist. Method: selected patients were randomly divided by envelope method into two groups, KD and KM. Group KD received bolus dose of dexmed 1 microgram per kg in 100 ml NS over 10 minutes, and group KM required bolus dose of midazolam 0.05 milligram per kg in 100 ml of NS, and both the groups received a dose of ketamine 1 milligram per kg at the start of procedure. Parameters of study include assessment of adequate sedation using Ramsey sedation score, assessment of intraoperative and postoperative hemodynamic parameters, time for rescue anesthesia using PRST score, adequacy of anesthetic technique, and duration of postoperative analgesia, recovery time, and complications. The statistical analysis was done using SPSS software. Results: the demographic parameters like age, weight, and sex were comparable between both the groups, and both the groups provided adequate sedation, and there was no statistical significance between the groups. A statistically highly significant reduction in pulse rate was observed in group KD compared to group KM at all the time intervals. There was significant reduction in mean arterial pressure in group KD during the intraoperative period, and the time for first rescue anesthesia was longer in group KD than KM, and it was statistically insignificant. Group KD patients had a shorter recovery time than group KM, and it was statistically highly significant. Time for first rescue analgesia was prolonged in group KD, and the incidence of postoperative complications were similar in both the groups, except that nausea vomiting was more pronounced in group KM. Discussion. In our study, we found that dexmedetomidine and ketamine provided more hemodynamic stability, shorter recovery time, and prolonged analgesia and recovery period than the midazolam ketamine combination. Both the combination provided adequate and comparable sedation and anesthesia and stable respiratory parameters with no incidence of apnea or respiratory depression. Side effects of midazolam ketamine combination were more compared to the dexmed ketamine combination. The findings of our study was consistent with that of Garg et al., who found that dexmed to be safe and effective drug for sedation during short surgical procedures. Conclusion: dexmedetomidine ketamine combination may be a good and safe alternative agent for sedation with more stable hemodynamic profile, better analgesia, and shorter recovery period than midazolam ketamine combination in short duration surgical procedures. Thank you.
Shital,
Ji sir.
yeah, can you hear? Yes. So, which one you prefer in your daily practice? Nowadays, this is your study. Other than your study, which one you are using? As a postgraduate, how you?
Yes,
what
sir.
is used in your institution?
Sir, I can clearly hear.
The other combination, midazolam combination.
Sir, your audio is
We have
breaking.
also.
Sir, we are not able to understand you. Your voice is not clear, sir.
Yeah. Now, can you hear?
Better, sir.
Yes,
Better.
yes.
Yeah, it's good. Better, sir.
Sir, please.
Yeah, yeah, okay. There is some audio problem with Dr. Debashis.
Yes,
Sitil, at last somebody presented a good PowerPoint. I was thinking about it. Then you came to discussion. Then you made a paragraphs and discussions. Hopefully, you can rectify that thing.
Yes.
Other than that, so why ketamine midazolam combination is famous? Do you know why ketamine midazolam combination is famous? What is the problem with the ketamine?
Sir, yeah, it can produce cognitive dysfunction in patients. So
it's basically causes dissociative anesthesia rather than
dissociative
cognitive
anesthesia and hallucinative effects.
hallucination. So, what is the advantage of adding midazolam?
It helps to reduce the cognitive dysfunction and hallucinative properties of ketamine.
Why? What is the advantage? What does midazolam do? midazolam causes anterograde amnesia, right?
Anterograde amnesia, yes, sir.
So that is an advantage of adding midazolam to
Midazolam and
ketamine because
ketamine.
it causes amnesia. The patient won't recall whatever happened
Yes,
during the
sir.
ketamine effect. So the combinations. So how do you explain dexmedetomidine to do this effect with the midazolam? Are you saying dexmedetomidine has amnesic effect?
Amnesic effect, no, sir. It is not.
Only benzodiazepines have this amnesic
Only
effect.
benzodiazepines have this anterograde
dexmedetomidine.
amnesic effect.
So how do you explain ketodex, which is now famously known as ketamine dexmedetomidine?
Yes.
How do you explain ketodex is better than ketomidaz?
Sir, in our case, the sedation levels were similar between both the groups, but in case of recovery time and postoperative complications, it was lesser in ketamine dexmed group, and we
Now, how do you
conducted our
explain
study.
it? Can you explain it? Why? Theoretically, midazolam should be better, right, compared to dexmedetomidine. Practically, why is not this is dexmedetomidine is better than midazolam?
So it has more effects on the. It is more cardio stable drug, so we can also give it to patients who are having systemic illness also.
You're not understanding my question. Doesn't matter. So now it is proved that ketamine dexmedetomidine combination maintains the heart rate, maintains the BP, and
Yes,
post-operative cognitive dysfunction we have not yet completely understood. Okay.
Yes,
Till now,
yes.
midazolam was used as a good drug. Now we have ketodex supposed to be the better option compared to those things. Thank you. Thank you. Well presented. Thank you.
Thank you, sir.
Thank you, Sheetal. Thank you, Dr. Ranjan and Dr. Debasish, sir, for
Thank you so
sparing
much.
your valuable time and chairing this session. It was nice meeting you, nice connecting with you. So, any closing remarks, sir?
Yeah, I think you were managing the show in a very professional manner. We had also our web conference this year in March, and I think things are going very comfortably, and we are also on time. Thank you.
Okay. Thank you so much, sir, for the remarks. Yeah. Thank you. So,
Thank you,
Namaste.
Debasish, sir. It was nice meeting you for the first time.
Yeah. Thank you. Let's
Please,
call it a day.
we are conducting a South Zone conference in Pondicherry. It's in December 17, 18, 19. Debasish, sir, please do come.
Right, I'll try my best.
Madam, thank you so much for the Dr. Dwani, right?
Yes, sir.
Yeah, thank you so much, Mata. It's nice interacting with you people. Very well conducted. All the best for the future. Thank you so much.
Thank you, sir. Thank you so much. Have a good day, sir. Bye-bye.
Same to you. Thank you. Bye.